fantastic program is continue for the second day. And today we'll follow the same tradition. We'll have a couple of plenary sessions, followed by some symposia, and then we will have parallel symposia. And we will actually have a quite excellent sessions towards the end of the day, concluding by the endocrine grand round. It gives me special pleasure to welcome the chair of the first plenary lecture, Dr. Bashir Taha Saleh, who's a very well and renowned figure actually, who has been in the area of obstetric medicine. Actual fact, he is a pioneer of obstetric medicine in United Arab Emirates as well as in the Gulf. With no further ado, Bashir, the center stage is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa barakatuh. Thank you, Dr. Professor Tariq Al-Had, for this introduction. It gives me a great pleasure really to introduce a friend and colleague and my younger brother, Dr. Muhammad Bashir from Qatar, Doha. Dr. Muhammad Bashir has a fantastic record in dealing with women's health in Qatar. He is now a senior consultant in the Women Wellness Hospital, where he treats mainly women, or mostly women, and especially in diabetes and other endocrine problems. And we can't have, he has a wonderful record. He is a good researcher and has published really enormous in the field of women's health. Dr. Muhammad is going to take us on the problem which has been puzzling me for years, is the diabetes in pregnancy. And Muhammad is really the best person to tell us, is it an illusion or a success? Muhammad, the floor is yours.
I would like to thank the organizing committee for the invitation, and it's always an honor that to be presented with our godfather, Dr. Bashir Taha. So I have no conflict of interest to disclose regarding this talk. And generally speaking, we have three forms of diabetes in pregnancy that we deal with in our clinics. I'm an endocrinologist, so this is part of the work I do. So we look at GDM at majority of our cases, type 2 diabetes and type 1 diabetes. But I make always an argue that GDM and type 2 diabetes there is a huge similarity between them. But for today, for the sake of this talk, I'm going to focus on type 1 diabetes in pregnancy, which I think is a different form of diabetes from the rest of them. And to set the scene here, I'm just going to go through some data of the outcomes of diabetes in pregnancy around the globe, which remains quite poor. I'm looking at data that we published back in 2019, an audit from the United Kingdom, Ireland, and a study that included multiple countries from Europe. And looking at baselines, the average ages were similar. However, in our study, our women seem to be heavier and have a high rate of obesity. Duration of diabetes are usually the same. In our part of the world, our HbA1c at booking is actually much higher than probably a little bit higher than some countries. But when it comes to outcomes of glycemia, we seem to achieve decent levels of HbA1c similar to, say, the United Kingdom. However, our preterm delivery is categorically high. This roughly stands in around 9 to 10% rates in the general population. All the countries, including us, is 4 times higher. Cesarean section rates, which vary across countries between 25 to 35%, is significantly increased all across the countries. Large for date, which normally sits around 10% by definition, is 5 times higher in most of the countries. However, in our part of the world, the rate is much lower, something that puzzled me for a long period of time, why we have a lower rate of large for date. And macrosomia rate is, again, sits around 5% globally. So you can see over here, while some countries start well, end up well with terms of glycemic control. However, the rate of complications remains high in almost all these categories. And just to set the scene a little bit, what does it mean? So if you said that 99% of those offsprings were born alive, at that point in time, do we consider that this is a success? But if you look at the long-term implications of these complications, we have to think again. A child who's born large for gestational age have a higher risk, lifelong risk of all the metabolic diseases, obesity, hypertension, diabetes, and so on and so forth. Cesarean section rate is an independent risk factor of obesity and it's also an independent risk factors of other complications. One of them has been proposed as type 1 diabetes. And a child who's born preterm, again at high risk of metabolic disorders, but other risks of other respiratory disorders that have long-term consequences as well. So these complications rates are quite high, and those children are starting their life with the back foot in terms of the metabolic health. And back in 1995, there was a declaration in which countries came around and said, okay, we have to do something, and we should aim that the outcomes of diabetes of pregnancy approximates the general population. They didn't say be the same, but say approximate, and nobody knows what approximate means. But the mandate was that should happen within 5 years. And 1995, now 30 years, some of you might not have been born at that time, and we're still not even close there. And to understand these difficulties, we have to go a little bit further when we look at diabetes in pregnancy. I know I'm talking to mostly of endocrinologists, but if we're dealing with these cases, you just need to understand these parts. So the focus at the start of any of the pregnancy and the start of the pregnancy is the process of organogenesis and placental development. So any intervention, any interference at that time can lead to high risk of malformations, but any interference with the process of placentation per se can have sequences on a short term or early on of a miscarriage. However, if the placenta was poor, there are other problems that can continue. One of them is that it makes them at high risk of preeclamptic toxemia, which is a very serious complications with a high morbidity and mortality. Babies could be small. If nothing happened, there's still a high rate of preterm delivery, spontaneous preterm delivery, and those children are at high risk of intrauterine fetal death. So this is, you can say, up to 16 weeks. That's the main part. However, after that, the focus is in the growth of the baby, the weight gain of the baby, and that follows a certain pattern. Early on, the rate is very low. However, from 16 weeks onwards, start to increase 29 grams per week, becomes 59 grams per week. But after that, there is a hike or an acceleration growth between 28 to 35 weeks. That's when most of the growth happened. After 35 weeks, the rate goes down. So if you're looking at your glucose control, the glucose control should start and continue early on before the growth sprue happens. Otherwise, the baby is going to be overfueled and overgrow. And then literally after 35 weeks gestation, the impact of glycemia will be a little bit less. If you miss the boat at that point in time, you're probably not going to fix it when you're at 35 weeks because the growth goes down. Insulin resistance goes down as well. So there are multiple challenges when you manage type 1 diabetes in pregnancy. And this management is the continuous changes in the insulin sensitivity, starting with an enhanced insulin sensitivity where you need to reduce the insulin to an accelerated form of insulin resistance where you need to continue to add more insulin doses. The changes in that happen in pregnancy, nausea and vomiting early on and later on delayed gastric emptying, all these can impact your postprandial glucose excursion. It's very hard to come up with a formula to do carb counting during pregnancy because of the continuous change in the insulin sensitivity. There's some issues with insulin absorption variability as well, and also some issues with the timing of insulin administration. As time goes on, you probably need to administer the insulin earlier than what you used to, 5 minutes, 15 minutes, sometimes half an hour earlier. And there's a significant, when you look at CGM right now, we have an issue with a significant increase in the CV variability, which makes things a little bit more worse actually during for adjustment. And the question is, as endocrinologists, we focus on glycemia mostly, but the question is, can glycemia improve these outcomes and reduce these adverse outcomes? I'm not going to go through historic data. I'm going to focus on the current era of CGM and pumps at this point in time. I'm going to zoom in a study called the CONCEPT study. And the CONCEPT study was randomized type 1 diabetes women to either use a CGM or use a capillary blood glucose, but they enrolled them before pregnancy. They were optimized, they were followed throughout pregnancy. And there were more outcomes because it was designed by endocrinologists, was to look at changes in HbA1c at 34 weeks gestation, and then look at time range changes, and then other maternal and neonatal outcomes. And what's interesting to look and see in this study that at the time of enrollment to the study, before pregnancy, they were you can argue they're well controlled. 7.4% in type 1 diabetes is not bad. By the time pregnancy started, they are at target. They're 6.8%, 6.9%. So have a very good start for the glycemia. By end of 34 weeks gestation, there was a significantly lower HbA1c levels in the CGM group. But if you look at it numerically, the difference is really, really small. However, more people achieve a HbA1c less than 6.5%. And I think this is the figure that matters. The mean in these studies actually dilutes the effects or sometimes exaggerates the effects. So more people achieved HbA1c less than 6.5%, which is the target during pregnancy. And time in range went from 52% up to 68% at 34 weeks gestation. Did this improve outcomes? So large for gestational age remained around 50% on the control arm, and in the CPG, almost close to 70%. Neonatal hyperglycemia remains high, lower with the CGM, but still relatively high. Preterm delivery, again, and very little difference. Cesarean section rates remained high, and preeclamptic toxemia remained high. However, this study was celebrated as considered a sweet success. And the sweet success here was the fact that their CGM, they were able to start the pregnancy well, continued well, and there was lower rate of some of these complications. Anything in gold is actually statistically significant finding. So we have a winner, and the standards start to move around that we actually used to use CGM. And in this study, some of the women on the CGM were on pumps, and some of the women on the CPG were actually on pumps as well. So it's CGM, with or without insulin pump, will be the way to go to improve outcomes. However, and then the guidelines have actually changed to reflect that, and we currently understand that we need to aim for a tight time range in pregnancy, which is between 63 to 140 milligrams per deciliter, 3.5 to 7.8 millimoles, if that's what you use. And we should aim for a 70% or more in this range, less than 4% hypos and less than 25% on the hyper range. However, there was a question. So you started well, continued well, why there is still a high rate of life at gestational age as a marker of hyperglycemia? So the concept investigators went back to look at their numbers, and what they found is that it's taking time to reach this level. So starting with the 51.6% time in range, it dipped actually, and then later on towards the end of the pregnancy, we started to achieve the target. And if you remember the growth chart the rate I showed you, you're probably achieving this very late in pregnancy. Already the baby is receiving sorry, I lost the screen in my, okay, thank you. So already the baby are already facing large amount of glucose supply, and we have the large for date going around. But there's another problem as well, because we are looking at percentages and means and so on. You need to know how many people actually achieve the time in range in pregnancy. So when they looked at their groups, they found at booking, when they started, in the CGM, only 7.7% achieved the time in range. It increased to 10.2% in the second trimester and reached 35% in the third trimester. So it's still a challenge to get them to the time in range in general. But again, it's taking time. It's taking a long time to reach this level. And still that is leading all the complications to continue. So we decided to look at our cohort as well, because we started to use the CGM quite early. So we actually looked at our group. We had about 265 women with type 1 diabetes. This data from 2022, but it was published 2024. So we have 92, about a third of them was in the CGM groups. And what we found is we have the same thing. We're still starting with a 44.2% time range. We reach about 54% by the end of the pregnancy. And it is taking us some time to reach this level. And this 54% this was disappointing. But hold your thoughts here, because after we analyzed our data, a randomized control trial called the ADAPT was randomized women to a hyperclosed loop, and I'm going to zoom in this study later on, versus CGM. And what I'm interested in here is that in the CGM group, they started their time in range process 44.5%, improved it by 10% throughout the pregnancy. And the improvement again in the CGM happened towards the end. So still, with the CGM per se, it's taking them in the randomized control trial setting, it's difficult to achieve the average time in range higher than or improving more than 10%. Another study did similar result study, and in the CGMR, they started well, say almost 58%, and increased by 5% at the end of the study. So with the CGM, it's still challenging to get women to target. So you need always to look at this in front of you when we're looking at when managing women with diabetes, to think where we should start to tighten up the supply of glucose. And as I said, it's taking a long time, and because of this long time, we start to achieve the target at the time where probably can argue doesn't really have a huge impact. After 35 weeks gestation, we got to the levels, but the time the growth is already slowing down. So the AID-APT study is try to answer a good, important questions. It's used a insulin pump, the CAMPS, which use the Cambridge algorithm, and this is a pump which is approved in pregnancy. And it randomized women to either CGM or to use the CAMPS, and they were boarded at 11 weeks gestation. And what they showed over here, that in the CGM arm, I showed you before, there was a 10% increase in the time and range. HbA1c came down from 7.9% to 6.4%. In the hyper-closed loop, they actually got the time and range on average from 47% to 68%. And the HbA1c came down from 7.6 to 6%. Did this improve the outcome? And before we look at that, we just want to see the time and range achieved throughout the pregnancy. And in red, so in red, you can look at the pumps and you can see it's maintained throughout, starts well, maintained well, but it improves as time goes on. But when you look at the standard of care with the CGM, you have some twists and turns throughout the way. So it dips down, goes up, dips down, and then eventually you reach the levels closer to the pump by 36 weeks gestation. So these twists and turns, should expect the results or predict what the results are going to be. So the study was not powered to look at any outcomes, so they did not do any formal statistical analysis for these outcomes. But you can actually see that the launch for date in the hyper-closed loop listing was 39%, and this by far the lowest reported in any trial that I know of. No difference in neonatal hyperglycemia, NICU admissions. Preterm delivery was actually higher in the pump group, and cesarean section rates remained to be sky high. Preeclamptic toxemia was much better. So with this hyper-closed loop pump, you get a better glycemic control, seems to be maintained, but there is still an increase in the rate of large for gestational age, much better than what you get with any other intervention. Another randomized control trial looking at pumps is known as the Crystal trial that used the Minimed 780, and smaller numbers, similar design, but boarded a little bit earlier. And they were started at a better glycemic levels. HbA1c was 6.2, it improves to 6.1, very little changes. Time and range improved by 5% in the CGM group. In the hyper-closed loop, they achieved time and range 66%. The change was small, 6%, and the A1C was from 6.5 to 6.3. Because the effect size in the study is small, we should not be expecting a huge amount of differences in the outcomes. But again, you see the same pattern occurring again. With the pump, you're able to maintain it a little bit earlier and keep it going. Gets better towards the end because the insulin resistance is reduced. But with the CGM, you have these twists and turns, and we get it right at the end of the pregnancy. So, but the large for date or almost all the other complications remained much higher than the background population. We're talking about few folds higher. And one finding here that was reported in this study that was not reported before is the very high rate of excessive gestational weight gain. In our cohort, excessive gestational weight gain is affecting almost 50% of the patients, of the women. And that's one of the other reasons why we're still facing a high rate of large for date in women with type 1 diabetes. Because the high BMI and excessive gestational weight gain are independent risk factors for a lot of complications in type 1 diabetes. And it's significantly increased among those women. And this is just one recent meta-analysis that basically showed that the BMI is associated with an increase, high BMI is associated with increase of prenatal complications, but it's the excessive gestational weight gain that almost increases by 50%. And if you zoom in these complications, you can actually find out that it is actually the large for gestational age, the macrosomia, the C-section rates with the excessive gestational weight gain, which is something while you're dealing with type 1 diabetes and trying to figure out how to reduce all these fluctuation in insulin and glucose and keep the glucose level tight, it slips out of the radar, it slips out of the focus, the amount of gestational weight gain. But it ends up to be one of the main issues, which I can argue is one of the main issues that makes the control quite difficult when the insulin resistance is peaking. So there's another factor here as well to come to play, which a theory which was put forward by Gernot de Soy from Austria. He came over and started to think loudly and say, over the last few years, we have seen an improvement in the general management of type 1 diabetes. And that is reflected in a reduced rate of congenital malformations. We have better insulins we have than what we used to have decades ago. However, paradoxically, despite that we're starting pregnancy at better HbA1c, we have a higher rate of large for gestational age. And he's talking about Europe mostly in this paper, that in the Western it's reaching 50 to 70%. I told you we have 30% rates or lower than that. So his proposal, his theory is that it's when you start with a good glycemic control, we're starting with a healthy blood vessels. So the placental process, the placentation process is actually quite good. But when we're starting with a poor glycemic control, particularly if it's going for a long period of time, we probably have a process of you can say subclinical atherosclerosis. So the blood vessels in the uterus are very hard to penetrate. And then we have a poor placentation process. And what he put forward there is that if the woman started with a high HbA1c, the placenta is going to be impaired. If at that point in time, we manage to get the HbA1c down, the placenta is not allowing a lot of glucose to go through, those children might be delivered at a normal weight, but they have a very high risk to become a small for gestational age, because you're going to provide a form of a growth restriction for those because the placenta is not allowing the glucose to travel. On the other side, if we started with a poor placenta, however, and the HbA1c did not improve at all, this poor placenta is kind of shielding this child from the effect of the glycemic control. And they are born normal, but he's arguing that they might not be normal. There's this thin fat phenotype being described in Southeast Asians where they have more visceral fat than muscles. However, if we start with a good placenta and a good HbA1c and the control slipped throughout, more glucose are going to be siphoned to the baby. They're going to be larger. And the best way is to start good, end up well, and this is where you only have a normal gestational age. So there's only one scenario here that you have you'll have a normal baby in terms and all start well, end up well. As you will imagine, we decided to test this theory in our cohort. So we went over and looked at our cohort. We collected data on 154 placentas, and then we examined our data. So what we found was, well, at the start, when women who start their pregnancy with a good HbA1c, less than 7%, they have heavier placenta than those who start their pregnancy with a HbA1c above 7%. And then when we looked at the fetal weight, and we found that when the women start well, and then the control slips, they started with a good control, but the HbA1c becomes poorly controlled, they have the heaviest fetal weight. When they start well and the control remains well, the next kind of fetal weight, so there you can consider the normal group. But when we start poor and the control continues to go poor, these are the third group. So their weight, they're not particularly large for gestational age, they're actually lighter than the other groups. When we start poor and we get the blood glucose down to the target, those have the lowest gestational weight gain at that point in time. And that pretty much fits with his theory that he put forward. But we wanted to go one more further and examine how how much of this is actually mediated by the placenta, because yes, it is the theory, but we want to do it mathematically. So we did a mediation analysis, and I'm not sure how many are familiar with mediation analysis, so I'm going to explain it a little bit easier. In a mediation analysis, we perform stepwise regression analysis, but we have to draw something called as the DAG. So in this theory, we think that the first HbA1c, the last HbA1c have an impact on neonatal weight, but we also know that there are multiple confounders that impact neonatal weight. But we're putting forward here that the initial HbA1c impact the placental weight, and that has an impact on the neonatal weight. So in order to test that, you need to go with a regression analysis in a stepwise fashion. So initially, we did an analysis where we didn't correct for anything. We just looked at first HbA1c, last HbA1c, in correlation to the fetal weight. And then we saw this opposite bidirectional relationship. The higher the HbA1c at booking, the lower is the fetal weight. And the higher the HbA1c at the end of the third trimester, the higher is the fetal weight. So they've gone opposite directions. So we corrected for multiple confounding factors, and the effect still remains. The higher the initial HbA1c, the lower is the fetal weight, going to the other direction, which would be contrary to your intuition that starting poor means the baby is going to be larger. So the next part here is to block this pathway between the placental weight and the neonatal weight. And when we block this pathway, the impact on the initial HbA1c on the fetal weight is completely lost at that point in time, meaning that this effect is mostly mediated by the impact on the placental process, placentation process. And in this mediation analysis, what we found is, so this pathway is that 64% of the impact of the pre-conception on early HbA1c on outcomes, on fetal weight particularly, is actually mediated by the placenta, which further supports the initial theory put by Gernot Desoy in his papers. So this makes things a little bit more complex when managed women with type 1 diabetes. So what do we need to do? We need to start early. So treating the women at the time when they get pregnant, as showed you already, we missed the boat a lot. We need to start with an adequate glycemic control and an optimum weight gain, and hyperclosed loop seems to be starting early, seems to be the way to go, or otherwise CGM should be considered. Early on the first trimester, we need an early intensification. We'll get a little bit laxed in the first trimester with all the physiological changes that are happening, but you need to start and maintain it early and provide a very early nutritional support to avoid excessive gestational weight gain from as early as possible, in addition to establishing an integrated care where there is an obstetrician and a diabetologist who are looking after the patients. In our center, we sit in the same room. So my next desk is actually an obstetrician, and we see the patient together. Throughout the pregnancy, we need to maintain that. We need to keep the intensive glycemic control going on. We need to keep an eye on the gestational weight gain, which I said it can slip over the radar with all the problems happening and the difficulties with glycemic control. And the last part that we take a back seat on is the delivery plan. I think we should take the front seat in the delivery plan. And the front seat in the delivery plan, we need to co-plan the pregnancy, the plan of the delivery with our obstetricians. And our obstetricians and our colleagues there, they are very, very scared of intrauterine fetal death. It's a very traumatic experience to have a baby die at term. So they're very scared of the intrauterine fetal death. Need a little bit of reassurance. And the reassurance comes from various data. So one of the largest data set reported on IOFD was coming from Scotland. And what it did show is that if the HbA1c was high at the start or at the end, that the rate of intrauterine fetal death increases by 3% and 2% and 6%. You put this in numbers, if you have a background population, 5 deaths out of 1,000 deliveries, 3% will mean 5.05 in actual numbers. So the actual glycemic impact on IOFD rates, it is there, statistically significant, but in terms of magnitude, it is small. What you need to worry about is that if the baby is too small because you have a placental insufficiency, or the baby is too large because you have an accelerated growth. Here, the IOFD rate is increased by 6-fold or 2-fold. And in type 1 diabetes, there is a pattern to look at. It can happen at any time, but it seems to peak from 37 weeks onwards. And that's why we try and hold the hands of our obstetric colleagues right now, because the preterm delivery rate, when we looked at it, is very high. Hold their hands, to get to the 37 weeks line over there and keep reassuring them. And otherwise, you will face what we've found in our cohort. What we found in our cohort is we had a very high rate of cesarean sections, 68% in type 1 diabetes. We examined that, we found 40% of primary cesarean sections. And we also have a high rate of preterm deliveries. And what we found is that this is all iatrogenic. So our obstetric colleagues take those women to induce them at 36 weeks, induction fails, end up with cesarean section. So if we do not intervene here or do not reassure them, this is going to continue. And we have changed our practice that we are now dictating the time of delivery and helping them to keep it as long as possible to 37 weeks. So by that, I come to an end of the talk. And I don't want to have confused you, but I just want to make sure that management of type 1 diabetes during pregnancy is complex. And I think you should, if we focused only as endocrinologists on what to do for glycemia control after delivery, we probably will not be able to reduce the adverse events. And we need to have plans for preconception care. And I think every woman at a conception age should have tighter control all the time. I think hyperclosed loop is a good standard. It might become the gold standard in the future, but at least use it with the CGM. And it's very important that you start well, continue well throughout with avoiding excessive gestational weight gain, and keep this at the center of the control. And I think integrated care where we talk with the obstetricians is the way to reduce iatrogenic complications. And thank you very much.
Thank you very much, Mohammed Bashir. That was excellent. And I think we learned a lot about type 1 diabetes in pregnancy. I think I'll hand over to my colleague, Dr. Walid Kirtan, for the next session.
Thank you, Bashir. Good morning. Assalamu alaikum, everybody. It's my pleasure to introduce the second speaker for today's program. My close colleague, distinguished physician, Dr. Asmadib, is a consultant and chief of pediatric endocrinology at Sheikh Shakbout Medical Center. She's also the chair of the ASPED, that's the Arab Society for Pediatric Endocrinology and Diabetes, which represent the whole Arab countries. Dr. Asma also is the chief or the chair of the Research and Ethics Committee at SSMC, a very prominent speaker and known physician, not only in UAE, but in the whole Gulf region. I think today's topic is one of her passions. She's going to talk about the fascinating interface of clinical and genetic features in pediatric endocrinology in the Gulf region. Dr. Asma.
Thank you very much, Walid, for this nice introduction. Good morning, ladies and gentlemen. I would like to thank and congratulate GAED board and Mr. President, of course, for this success. My special thanks go to Dr. Tariq Al-Had for his trust in me for advising on the pediatric program. That's my title, and the reason why I chose this is to express one of the very many regrets in life, professional life, for things that I didn't do. And one of those things is that I didn't do genetics. The reason why I didn't do that is when I was younger, I hated botany and I didn't understand genetics. And at that time, the teaching was almost centered on Mendelian law and his work on plants and garden beans, explaining the autosomal recessive and dominant. And I couldn't quite get what those all about. And getting older and wiser, I realized that genetic is basically the basis of what we practice today in precision medicine, pharmacogenetics and pharmacogenomics. And I remain short of proper understanding of medical genetics, which I'm trying to compensate with talks like this. So during my career of endocrinology, the last 25 years or so, for today, I just picked some areas of pediatric endocrinology where the impact of genetics cannot be underestimated. Metabolic bone diseases, monogenic diabetes, monogenic obesity and lipodystrophies, and growth. So I'll try to squeeze some examples of fascinating science that I personally and many of you see in clinic, reflecting how important genetic is in human health and in formation of human body. So when we teach medical students, we tell them that the endocrine glands are pituitary, adrenal, thyroid, gonads, and so on and so forth. And what we actually ignore to teach medical students is a very important endocrine gland, that is the growth plate. And the growth plate is very different from the other classical endocrine gland because it's a dynamic gland. And that line that we see on X-rays assessing the bone age, which looks like a very static, boring line in X-ray, is actually a whole orchestrated system with many phases of resting phase, proliferative, hypertrophic, and with defects in the growth plate implicated by genetics. We see a plethora of science in front of us in the clinics. There is lots of genetic defects that can be subcategorized, arising from mutations and defects in this neglected endocrine gland that has lots of signals and cascades that leads to what we see in clinic. So that's a novel thing that we need to at least think about. If the gentleman at the back try to play the video because I can't see the arrow. So long time ago, we started learning about rickets. And in 1650, the description of ricket was out. And now in 2025, we still see those children with rickets. You have seen this impressive girl that walked into my clinic last year. So the knowledge is still lacking. And while this girl does not have nutritional vitamin D deficiency causing the classical ricket, she does have rickets because of other genetic interesting condition. So this young lady has, so this young lady had a mutation in FEX gene, and FEX gene, we started knowing a little bit more about it because of these novel molecules that have been in the market. And what FEX gene does is it prevents the renal tubules from reabsorption of phosphate. So what these patients end up is losing phosphate in urine, hence lack of mineralization. And these children suffered, and these adults as well, from the traditional treatment of X-linked hypophosphatemic rickets for years, because replacing phosphate and giving active vitamin D is not really the ideal solution for this. The ideal solution for this, which has been introduced in the market, is using monoclonal antibodies, things like purosumab, which has been offered for us for use, and it has been improving because of the innovative technologies, from being a murine molecule, highly immunogenic, to a fully human one that changed lives in many people. And staying in metabolic bone diseases, I would like to introduce this little girl that I knew around 25 years ago during my SHO training in the UK. So she presented to our clinic at 6 months of age. She had hypercalcemia and her alkaline phosphatase was very low. She had severe rickets, like the what you see on the X-ray. And we struggled managing this child. We managed to diagnose her with hypophosphatasia, but we couldn't treat her. We tried everything: low calcium diet, chlorothiazide, calcitonin, bisphosphonate, growth hormone, you name it. We even thought about bone marrow transplant. And unfortunately, she continued having progressive demineralization and unfortunately died at the age of 14 months because of respiratory failure. If you look at her chest X-ray, I hope you will appreciate the resorption of her ribs to the extent that there were no ribs in the picture because there was no mineralization. We published this in 2000, expressing our disappointment with the currently available treatment for children with hypophosphatasia. But that disappointment hasn't stayed for many decades because now people understand the underlying genetics of hypophosphatasia, and we now have enzyme replacement for such a condition. But you might say, so this is not really a rocket science. It's just an enzyme replacement that can alter or revert the abnormality. I would say it is, because this enzyme is expressed in multiple organs, and these children might be underdiagnosed because they might present purely with refractory seizures. And the reason for that is because the alkaline phosphatase, if it is deficient, then we have lots of abnormalities in the brain, and we will not end up having GABA, the inhibitory transmitter, and these children end up having refractory seizures, and they will not have their seizures controlled until the diagnosis is known and are given pyridoxine to revert their treatment. So this is a cartoon showing where the defect is. Nowadays, we have this aspartame alpha. Again, without knowing the genetics, we would have never managed to reach to innovation of such a component. Now, this is a replacement therapy that, again, changed these children's life. This is another case also talking about the hypocalcemia, metabolic bone disease. These are two siblings that I shared care with my colleague Jamal Jabe. That's how the girl legs looked like, and what looks like as a straightforward ricket ended up to a novel discovery, because this gene that was detected in these children was the very first time that it is discovered in a human. It's well known in rats, and with our colleagues in Newcastle, UK, we thought, okay, we hit New England Journal here. We didn't quite get it, but we were so proud to pick these children in clinic and show the world that we have patients and we understand genetics, because these children had deafness, and this gene is expressed in bone and inner ear. And our colleagues in Newcastle upon Tyne did a lot of work in terms of gene modeling as well as transcription assays and functional analysis to show how important this is. If I move from bone and go to fat cells, I wouldn't say pure obesity, but fats in general, again, it's another neglected organ, adipose tissue releasing leptin. We fail to identify this to our medical students as another endocrine gland. And it's beyond fascinating what people have shown in obesity. We all know about the Cambridge group, Sadaf Farouqi, Steve O'Reilly, and others who engraved their names in the medical history because of their discoveries of leptin gene and others, and we follow their paths. What's nowadays even more fascinating is the MC4 pathway leading to monogenic obesity. So leptin receptors and all others related to POMC and POMC4, in addition to others like Bardet-Biedl syndrome and all those other genetics. This is what is the source, or what the source is for understanding MC4, the mouse model, the blonde mouse, which we see in clinic as children with ginger hair who have monogenic obesity and severe adrenal insufficiency. And all this led to providing or making this novel molecule available to us in clinics, setmelanotide. Many of you have used this medication, and I had the pleasure of knowing these two young ladies in clinic. Classical features of Bardet beetles with the polydactyly, as well as narcolepsy, and I did try setmelanotide on them. So obesity is interesting. Our adult colleagues know a lot about type 2 and a metabolic cardiovascular disease. I don't quite understand those, but what I enjoy in obesity is knowing unusual things about it. So in addition to monogenic obesity, we had this young lady who is 12, and that's her growth chart. We can never catch her weight on the normal growth chart. And this young lady, she has type 2 diabetes, nothing unusual, but she comes repeatedly with pancreatitis. She doesn't have any gallstones or bile duct stones. She doesn't have triglyceridemia or any of the secondary causes of pancreatitis. But what we found out that she has is this mutation, SPINK mutation, which is apparently known to cause recurrent pancreatitis in children with obesity. So this is another message about the importance of thinking of genetics when we find something that's a bit unusual in practice. Staying at the lipid and the fat cells, there is this plethora or big umbrella of heterogeneous conditions of lipodystrophy, and we had the pleasure to publish many of those. In fact, I have given a talk last weekend in Lisbon about the MENA region experience in lipodystrophy. The credit goes to one of my colleagues, Saif Al-Arabi from Oman, who had the largest number of patients in the region of lipodystrophy. And we had been recognized for the multiple publications. We have really fascinating condition. We recently collaborated also with Rebecca Brown, who is #1 in the world when it comes to lipodystrophy, and put together a teaching module consisting of many patients with lipodystrophy. My last and the most interesting patient with lipodystrophy is this young lady who I met when she was 12. And at some stage, her mother persuaded me to believe in evil magic. She kept telling me how her girl is cursed with magic. And the girl had this plethora of abnormalities, majority autoimmunity related. So she started losing her fat on the limbs, and all her fats was in her neck and abdomen. Then she had vitiligo, then alopecia, then hypercholesterolemia. Then she developed diabetes. She had Graves' disease. She had Addison disease. She had ophthalmology issues with losing vision secondary to Graves' orbitopathy. That's her. You can see the abnormal distribution of fat. And so this is one form of acquired generalized lipodystrophy. She did not have any gene mutation identified, but I'm pursuing more genetic testing on her. This is a very famous family from Turkey where metroleptin, again, the relationship between the discovery of genetics and the precision medicine. So you can see the top photo and the bottom one when these 5 members were put on metroleptin after being diagnosed with generalized lipodystrophy. So just some food for thoughts. If I move from obesity to diabetes, and this is really one of my main area of interest, and practicing in Abu Dhabi, we have seen a large cohort of different forms of neonatal diabetes. So this is a baby who presented to us with upper respiratory tract infection, found to be positive for COVID. Her blood sugar was very high. She was acidotic, dehydrated, so diagnosed with diabetes and started on multiple daily injection of insulin. And we thought we are doing very well because we hit the 44% of time in range. I know Nancy is not very impressed here, but this is a 3-month-old baby who breastfeeds. And then we said, let's go a little bit more sophisticated. So we put her on Omnipod. We got a better time in range. I hope you are happier, Nancy. But we were not happy because the mother was not really managing with insulin pump. But then we thought, okay, what's going on here? There was no consanguinity in the family, and we utilized the Emirati Genome Program, did her genetics, and we found out that she had KATP channel mutation. So it got more exciting because we managed to shift her from insulin to sulfonylurea, and she walked out from our hospital instead of having multiple daily injection of insulin or even insulin pump stuck to her little thigh into half a tablet twice daily of sulfonylurea. Lots of literature showing how useful use of sulfonylurea in monogenic diabetes, specifically when patients have KATP channel mutation. But we had a very interesting experience shifting her from insulin to sulfonylurea, utilizing the technology, particularly of the CGM. Another very good example of precision medicine is this condition. So the thiamine responsive megaloblastic anemia with monogenic diabetes. So this is a cohort put together by my colleague Abdelhadi Habib from Medina, who looked at a group of patients who have monogenic diabetes, neonatal diabetes, and megaloblastic anemia. In pediatrics, we don't leave things go away when we have multiple pathology. It might be normal in adult endocrinology, but in peds, having multiple pathology always is a flag for us. So having deafness, in addition to monogenic diabetes, in addition to megaloblastic anemia, must have something to make them in common, and more often than not, it's a very interesting thing. So Abdelhadi put together this cohort and showed how diabetes control improves with thiamine, in addition to insulin, of course. So great examples of precision medicine after knowing the genetics. And I'd like to finish off with some examples when it comes to growth. And I must admit here, I don't know if you agree or not, growth is the most interesting aspect of pediatric endocrinology. So, and the reason why I'm saying this is I had the honor to do some basic science in growth, and I managed to work on pituitary rat cells in vivo. So I quite understand how things work, and that made me continue to be interested. Genetics of growth disorders is endless. It started with small number of genes and it keeps expanding. This slide is about 2 years old and I'm sure it's much bigger now. And in addition to me hating botany and not understanding genetics, I hated embryology as well at medical school. Another regret, because understanding embryology gives an insight of what happens in the future of the human body. So the reason why I'm flagging this is to show that from the beginning of conception on day 9, genes start working on the pituitary. So if you talk about multiple pituitary deficiency, HESX1 is one of the very first genes that start working in embryology. And initially it was only described in animals until Mehul Datani in Great Ormond Street described people with HSX1 presenting either as an extreme, life-threatening with cyclope and one central eye, or mild form with only central incisor. And then people started understanding PIT1 gene mutation after knowing about the knockout mouse, the Snell and Jackson mice, where the anterior pituitary is hypoplastic, or PROP1 mutation, Ames dwarf mouse, that sometimes fools us because it's in the MRI, you see the pituitary as a mass, and many people are or get subjected to resection when it's not actually a tumor. This is one area that I really developed interest in, isolated growth hormone deficiency secondary to the GHRH receptor deficiency. And this was the thesis of my PhD, where I worked on those pituitary cells. And if you transfect the pituitary cells that have mutation in GHRH, then you see the difference. So that's where the expression of growth hormone is very different. With the wild type, which is GH3R7, you see lots of growth hormone in the Petri dish of the media, and GH3, which doesn't have the receptors, there is nothing there. The human model for that is dwarf of SIND, who have isolated growth hormone deficiency secondary to this mutation. And then if we go down, so from the hypothalamus, pituitary, go a little bit down, I'd like to share this little girl, one of twin, with you, who presented with severe short stature. When she was 2 years old, her standard deviation for height is minus 6.8. Minus 3 is severe short stature. She is minus 6, so she didn't grow at all. Her investigation showed lots and lots of growth hormone, but she didn't have any IGF-1, giving us the suspicion of growth hormone receptor mutation leading to IGF growth hormone resistance. And again, in the world or around the world, Dr. Laron, who discovered or told the world about this, is the human example of Laron dwarf. And that tribe remained short because they didn't have access to this molecule that we have access to nowadays, Increlex, synthetic IGF-1, which patients respond dramatically to and grow very well with because it simply replaces the deficiency. This is the liver, ladies and gentlemen, and if you think that growth is purely conversion of growth hormone into IGF-1 at the level of the liver, then I have to say, sorry, you are mistaken, because there is a lot happening in the liver, dealing with growth hormone, lots of things. And my final example before I close is related to what happens in the liver. So after we succeed having growth hormone releasing hormone, and we get lots of growth hormone, we need it to be converted to IGF-1. And even if you manage to convert it to IGF-1, you need IGF-1 to be released from its ternary molecule. What we find in the lab when we ask for IGF-1, we get the total IGF-1 and we say, okay, well, it's normal. But what we don't ask in the lab is the free IGF-1, because IGF-1 is captured with 3 molecules in a ternary complex. You need them to be released for the child to grow. And I learned this 3 years ago, and the credit goes to my colleague, Dr. Amir Babakar, who I don't think he is in the audience. So Amir has discovered this condition in a Saudi family where he had 2 siblings who are not growing very well, and they have lots of IGF-1 available. They responded nicely to growth hormone stimulation test, but they didn't grow even with high doses of IGF-1. And Amir, being Amir, he explored multiple areas until he managed to publish this case with colleagues from Madrid as PAPA, A2 deficiency. At some stage in pediatric endocrinology, this was a very hot topic, PAPA2. So pregnancy-associated plasma protein A2 deficiency. And if you have that, it means you have plenty of growth hormone, plenty of IGF-1, but it gets bound. It doesn't get released if you have this mutation. And it was really a game-changing for his family when he converted them from growth hormone to IGF-1. This is my last slide, ladies and gentlemen. There was no timer and Walid was quiet, so I enjoyed talking to you about these patients. I made a word cloud of the contents of my talk, and pediatrics comes first, the love of my life. Pancreas is there, genetics, pathology, monogenic, autoimmunity. So that's the ingredients that make life really interesting and worth it all, going every day to a pediatric endocrinology clinic. One thing that I did not regret in my life. And my conclusion in a nutshell is that genetics is the script, hormones are the actors. Without the genetic script, hormone action has no direction. Thank you very much.
Thank you so much, Asma. Thank you. Very interesting. So we still have 2 more sessions before you get released for break. So I would like to introduce Dr. Jalal Nafash, who is going to talk to us about Mounjaro and type 2 diabetes.
Welcome and thank you for dedicating your time to attend this meeting. At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
Is it working? All right. Well, I want to say that my talk is going to be much easier than Dr. Asma's talk, much simpler. I enjoyed it, but it was quite complex for an adult endocrinologist. So, my name is Dr. Jalal. I work in Diabetes Center. And really what we're going to do is we're going to go over, using tirzepatide or Mounjaro in treatment or management of type 2 diabetes, how to look at it. And I'm not really showing any new information. It just kind of I don't know why this is. Sorry about this. So this is the disclosure. Okay. So Mounjaro is approved for 2 indications here under the same name. One of them is type 2 diabetes. Now, of course, when you treat type 2 diabetes, here's the approval based on how the trials were done. So mainly you use it as adjunctive diet and exercise in patients with type 2 diabetes, uncontrolled, who fail a treatment, or if they cannot tolerate metformin or contraindicated, then it can be used as monotherapy. And then the second indication is the weight management. Now, of course, here is the same name. Different countries may have a different name for different indications. So again, as a weight loss, all the treatment for weight loss is indicated usually based on the trial design. So usually BMI of 30 or 27 with complication. Now, saying that, things over time may change because they may design the way the trial is done. The European Association Study of Obesity have now created this kind of a if you want to call it a consensus, where they try to really look at BMI of even 25 as long as the patient has complication related to obesity. So in the future, you may think different, at least from a label perspective, on the indication from the weight loss. So here we're going to kind of present a case of a patient who's 40 years old, type 2 diabetes, A1C 8.3%, patient on MET IMPA. Now again, the patient is uncontrolled with the A1C. Patient also taking perindopril, amlodipine, rosuvastatin, ezetimibe, and the duration of diabetes is 1 year old. Blood pressure is uncontrolled. As you can see, the patient is quite overweight, BMI 35. And so this is give you kind of the typical patient you see. Now, in our area, we may have more patients that tend to be a little bit less heavy than this population. But the typical, for example, US population is BMI of 33. Now, when you get a patient like this with this A1C, really you have choices, and the choices will be, and I'm not going to go over the choices, I'll give the concept and then go back to it, is first, TZD, still it's an agent that works, that we still can be used. And I actually have quite a few patients on. Sulfonylurea, basal insulin, DPP-4, GLP-1 agonist, or GLP-1 GIP. So you have all those choices, and the problem is if you try to look at combination, it's going to be quite a bit. So when you get a patient with diabetes, you're going to say what choices I have, and you have the insulin. Now again, insulin is not bad, but again, you try to avoid using insulin if you really don't need it. If patient is not catabolic, if the patient don't have very high glucose, they're not symptomatic. And because also the weight gain, the titration, and you know, all of us that even when we start patient on basal insulin, usually they don't do the titration and the calculation correct anyway. You have the oral agents like SU, TZD, and so on. And then you have the newer agent, in a way, it's not new anymore, which is the DPP-4, SGLT2, GLP-1 agonist, and so. So we have all those choices. And actually, if you're going to try to do combinations, you can have maybe 200 different combinations. You can have one with one, one with one and one. So you have all kind of combination you can do to treat the patient with diabetes. And of course, you have to look at the patient, you know, how he looked. Does they have osteoporosis? Are they overweight? And so on. The problem happened that despite all this medication we have, we're still not doing better. And so if you look at the National Health and Nutrition Examination Study, NHANES, you can see that despite all the treatment, we continue not to do well. And actually 2021 is very similar data. It's not here on the slide. So patients continue to be uncontrolled despite all the treatment we have. And that's a major problem. And on top of it, we are becoming heavier over years. I mean, if you compare the 1970s, for example, US data, you know, Americans tend to be at least 16 pounds heavier, which is 8 kilograms. Now, that again, in translation, it increased quite a bit of risk of diabetes. Every time you gain 4 or 5%, your risk of diabetes double. So that's quite a bit of issue. So we're dealing with two issues. Number one, that despite everything, we're still not doing a good job. And number two is the fact that patients continue to be overweight and actually gaining weight. Now, getting the A1C in target is very important. And I think it'll be, you know, if you look at all the trials, if you compare, for example, UKPDS with VADT. So Veteran Affair Diabetes Trial was older, sicker patient, duration of diabetes 13 years, and really did not show much benefit. The same, for example, that you don't see benefit on using statin on dialysis patient out of batch. But what we see in the UKPD is that actually, when you did control the patient, even though the difference in the A1C was not very significant, in the initial phase, there was improvement in microvascular. There was no statistical improvement in the macrovascular disease. And then when they did the follow-up trials, what you see is improvement in microvascular, improvement in type 2 diabetes death, MI, all-cause mortality. And so what it shows that maybe we have kind of legacy, that if we control patient very well, very early, are more likely to benefit patient. And on top of that, if you look at two somewhat newer trials, that actually if you get patient very tightly controlled from the beginning, one of them, the more recent one is Verify, and they put patient on med DPP-4. But the whole idea is they started with baseline A1C of 6.8. They kept them very tightly controlled. They're less likely to have a secondary failure. So the concept is you treat them early, you get them very aggressive. And even in the UKPDS, they had 44 years data follow-up. Now, again, 44 years most of the patient died in a way, but those who lived, they continued to have reduction in MI and all-cause mortality. So we continue to see a benefit or kind of a legacy effect of the treatment. Now, one thing when with respect to the GLP-1, that it seems that the earlier the better. Now, again, this is not a strong evidence, but when you start, and again, this is 1,100 patient cohort, that when you started as a first agent or second in line, and you look at 2 years data, you're more likely to have more meaningful A1C reduction. Now, again, this data is not necessarily tirzepatide, but it's just the concept. You may want to be aggressive. I think a lot of time we shy, and especially in the insurance world, because insurance always will deny you if you don't put it third or fourth in class. So mainly they deemed you to be failing in a way. Now, this is the direct trial. So the direct trial is mainly diabetes remission. So UK-based trial, have about 280 patients randomized, but the intervention was so severe. In a sense, you're going to do about 12 weeks of mainly meal replacement therapy, where you're doing only about 800 calories, 830 or so. So you're doing very strict diet, and then they're going to start doing meal, start to introduce meal gradually, and they're seeing dietitian at least monthly. So it's very, very, very intensive, labor requiring trial. But irrespectively, despite all of this, only about 11% of the patient lost 15 kilograms. Now, why 15 kilograms is important? Because in this trial, it showed very clearly that this seems where I kind of get remission of diabetes. So I get somebody with diabetes, they lose 15 kilograms, maybe they're in remission. Again, this is 2-year, I think, data. But the idea is, despite all of this, 800 calorie, meal replacement, dietitian every month, I don't think any of us can do this in a regular practice to patient. And despite all of this, only 11%. And again, they live in England, so they eat dinner at 6. If you're going to compare it here, they eat dinner 1 in the morning I don't think we're going to achieve even 11%. But those who lost 15 kilograms, they're much more likely to have an A1C below 6.5. So what we want to do is, again, when you look at the guide, this slide is back. I'm terrible with this one. Okay, it doesn't show here. But again, when you look at the ADAES, mainly you have 2 targets. So you have to use medication that reduce cardiovascular disease. And that should be irrespective of the A1C. So if you have somebody who have an A1C of even 6, and they have established disease, you may want to change them. For example, if they're taking DPP-4 to, if they have, ASCVD, maybe to GLP-1. And you're not doing it for weight loss, and you're not doing it for an A1C because they're controlled. So the cardiovascular risk reduction has 0 relation. And the problem is, for most of the people, when I tell them I need to change you because you have established disease, they say, well, I don't want to lose weight. Well, I'm not giving it to you to lose weight. So people still thinking about this class of drug as only weight loss and not diabetes severe risk reduction. Number 1. Number 2, when you look, the second part that's important is, again, we need to get the A1C down. We need to get the weight loss down. And again, depend how much of a reduction in the weight and how much reduction in the A1C, you have different choices. And of course, this most superior is really semaglutide and tirzepatide. So what's about the A1C reduction you're going to get with Mounjaro? And again, this is a phase 3 trials, but I'll go with you quickly over it. So what you're going to see here very quickly is, again, here as placebo monotherapy, which is the SURPASS-1. And you can see they started baseline A1C of about 8%. They have a reduction about minus 1.9. And SURPASS-2 compared to semaglutide. And what you see here, that there was a reduction of about 2.46 at the 50 milligram dose. And again, starting with a baseline of 8.28. To give you a perspective, for example, if you use DPP-4, the average reduction here will be maybe 0.1 or so. So just to give you a perspective. With the SURPASS, for example, with a baseline of 8.3, the likelihood to have an A1C below 7 is 92%. So if a patient comes to you, and they're taking treatment, metformin, let's say, or metformin SGLT2, and they come to you with an A1C of A3, the likelihood, for example, to get below 7 using Mounjaro is 92%. DPP-4, 30%. I use DPP-4, but again, it's about the case. So if a patient comes with such a A1C, it's very unlikely to be controlled. So if a patient comes to you, you can tell him, I can give you a pill, but most likely you're not going to lose weight, and your 30% is going to be below 7. Again, assuming your target is 7 and not 6.5. For example, in the SURPASS also, 3, and comparing to degludec, you're going to see that you have superior A1C reduction versus an insulin. Why is that? Because basal insulin doesn't really manage well the post-meal hyperglycemia. And this is actually a randomized trial, which means the patient was pushed to titrate the insulin. In a regular life, typically, most patients do not titrate the insulin correctly, and they may not even achieve the 1.34% reduction they achieve with the insulin here. And to add to it, for example, in this population, not only that you had a reduction of 2.37, the likelihood to have what we call euglycemia, which means have an A1C below 5.7, is 48%. So half of the patient with an A1C of 8.2 become below 5.7. This is the way you're going to look at it. Wow. And then again, if you compare to another basal insulin, it's superior. And the last one, the SURPASS-5, is really what's nice. We're showing you that if you have a patient who you're adding to, so mainly a patient who failed well-titrated basal insulin. Again, they titrated, they arrived to a good fasting, but they continue to have a high glucose because they're high post-meal. You're able to achieve quite significant A1C reduction across board. And what's about weight loss? Again, you have somewhere around 12 kilogram to 13 kilogram weight loss. And again, we have to remember that diabetic tend to lose less weight than non-diabetic, and that's something well known. Now, if we look at the SURPASS-2, which is again comparing to semaglutide 1 milligram, and again here in patients with type 2 diabetes, so the trial was mainly 4-arm, and again, it cannot be double-blinded because difference in devices. So mainly one arm did receive semaglutide 0.25, 0.5, then titrated to 1. And then you have an arm that started with 2.5, go to 5 milligram. The other arm go to 10 titration, and the other go to 15. So the idea is saying, if I have a patient who is uncontrolled on metformin, and if I add sema or if I add tirzepatide 5, 10, 15, what do I get? And what you get is this. So you started with baseline A1C of 8.3. You have 2% reduction of 5 milligram, 2.4 on the 10, and 2.5 on the 15. And then you had about 1.9% on the semaglutide 1 milligram. So it shows a superior A1C reduction in comparison to semaglutide. And you can see here very nicely that they went from the 8.3% all the way. You can see here 5.8 and 5.9, almost euglycemia. You see normal glucose, you see 90s and 80s, and it's not hypo, this is normal. We got used maybe or accustomed even physician to have a sugar of 140. It's like, okay, it looks okay. But typically when you treat a disease, you want to be as normal as possible. Well, with this, you can almost be there. Now, here, if you split the baseline A1C, which means how much a drop I can get based on the baseline A1C, so A1C 8.5 or this. So you're going to get about 3.3% reduction. To give you a perspective, for example, SGLT2 with a baseline A1C of 9, you get 1.4% reduction. DPP-4, you get 1.2 with a baseline over 9. Here, you're getting 3.3. So there is a difference. So you have to know the efficacy of the drug at a certain A1C to decide what's the appropriate treatment for the patient. The weight loss, as I showed you in the earlier slide, is about 12.4 milligram in the 15 milligram dose. And you can see that very nicely continue to drop down. Of course, the study was stopped at 40 weeks, but most likely you're going to continue to have weight loss if you keep it longer, but it was only 40 weeks trial. Now, if you try to make a post hoc analysis and say, I'm going to calculate the odd of a patient have an A1C below 6.5, which is the ACE goals, weight loss at least 10%, and no hypoglycemia. And you compare all of them with the Mounjaro, you have 32% with a 5 milligram dose and 60% in the 15 milligram dose and 22% in the semaglutide. Again, this is a post-hoc analysis, not pre-specified, but is the concept is you say, what's my likelihood to get a good A1C, a good weight loss, no lows? And that's what you get. Now we go back to the patient. So he come to you and remember his A1C was about 8.3. They're taking MET, EMPA, and then you have all the choices. And you can use, of course, TZD. But again, you have to discuss with the patient. It's a good drug, but there is possible weight gain. The patient already want to lose weight. And you remember the data I showed you already on the direct that weight loss really is influential in all across, even in remission of diabetes. You give him that possibility. 2, SU is a choice, but I mean, who anymore use SU as a second line? 3 is insulin. Would you use an insulin on somebody with baseline A1C of 8.3? Knowing with basal insulin, you cannot anyway, in the majority of time, get below 7.5 because you control the fasting, you cannot control the post-meal. So overnight dysglycemia, so patient will be sleeping with sugar of 230, they'll wake up with sugar of 90. That's what you're doing with basal. Most people taking more basal than they need. That's another choice. Then you have the DPP-4, and I mentioned before that the likelihood of success is really 30% at most. So, you have to give the all possibilities to the patient. Some patient may tell you, I don't want to do it. Say, it's okay, it's your choice. We can do this. And then you can use Mounjaro, and I kind of shared with you the efficacy data. So you talk to the patient and say, we can increase your dose and just go to 5 and go to 10. And, there is a degree of difference in the A1C reduction that you kind of can propose to the patient because some patients have different, preference. Even with insulin, I have some patients say, I don't want to go over 30 units because they decided so. So you have to give them that this is how much A1C reduction you get with this, how much weight loss you get with that. Now, patient started at 8.3, started with a weight of 114 kilogram, responded actually very fast. Now, number one, this is a case. It doesn't mean it applies to everybody. So does everybody lose weight? The answer is no, if you're looking at weight loss. So usually even in the weight loss trial, 95% of people lose weight more than 5%. So not everybody lose weight. Why they don't lose weight? One possibility, you can screen them for Cushing's. There was data presented in EASD where they actually did screen people for Cushing. I think it was about 24% of those who required multiple treatment therapy and did not respond despite high dose Mounjaro actually did have Cushing's. So you may want to screen them for Cushing's if you see something that doesn't make sense. But irrespectively, this guy responds very nicely. You're going to have a super responder. You're going to have people who lose, 30, 40% of the weight. Not everybody. You have an average weight loss. Some people lose more, some people lose weight. But your target is both the weight and the sugar. And you can see here very clearly that again, the patient went from 8.3 to 5.5, which is the typical reduction, 2.4, 2.5% in the A1C. Patient become euglycemic. And typically what you're going to see on top of this, of course, the reduction in the blood pressure, that's quite significant. Even sometimes it could outpace the reduction in the weight. So you're going to be very careful that when you start patient, that they understand, especially let's say they came to you well-controlled blood pressure with a blood pressure of 120. You need to tell them, you need to check your blood pressure at home. And if it's running, below 110 systolic or let's say 60 diastolic, you may need to cut your antihypertensive medication. And that's kind of what happened to this patient because they went from being taking perindopril 10, amlodipine 5 to taking only perindopril 5 with much better blood pressure. Does it happen to everybody? No. Is this guy outlier? The answer is yes, because you can see that the patient lost quite a bit more weight than the phase 3 trials I showed you before. So there is a variability in the response. If there's a way to predict the response or to predict who's going to do better or not better, no. It works very well, but some people work really well. I mean, you get mainly pure remission. So what we've seen with this guy is we get 2.8% reduction in the A1C, the weight loss, and the improvement in the blood pressure, despite the fact that the patient taking less medication. The other thing you can see, of course, beside this is typically the reduction in the waist. Here is about 10 centimeters. So again, this is a diabetes trial. You have more waist loss in the obesity trial. But again, this is 4-inch. So if somebody wearing a jeans 40-inch, you can tell them most likely in 6 months or so you'll be wearing 36, an average. So it's about safety. And again, this is just the SURPASS-2 comparing to semaglutide, and it's actually very similar from a perspective of the nausea and so. Now, one thing to add is it seems that the GIP, again, the Mounjaro is more GIP-1 than GLP-1, sorry, more GIP than GLP-1, that the GIP has an ameliorating effect of the GI side effect of the GLP-1. So the combination seems to work better in a sense of tolerance. Now, how do we start patient? Well, you start with 2.5, you do it for 4 weeks, then you go to the 5 milligram. And then typically you want to re-examine the patient and not only look at their A1C maybe because it's only 2 months, look at their actual glucose number, ask the patient to bring their readings. And then you decide with the patient, are you happy the way it is or you want to push the dose? So you can keep it at 5 or you can say, I don't like your glucose, or I may be able to push the weight down. And this is, of course, sometimes the insurance may fight you on it because they said if the A1C below 7, you're done. You cannot push the Mounjaro up. So sometimes I push it before I repeat the A1C so I'm able to get it through. So you go 7.5, then you go to the 10 milligram, and then you can maintain the patient on 10 or even go to 15. Now, typically, at the 10 milligram, you get about 95% of the benefit in a perspective. So at the end, I think I kind of stopped at this point, and I know it's very boring talk. You already most likely seen all the data, but it's just to present one of the options you have to kind of treat your patient with type 2 diabetes. And I'll stop at this point.
Jalal, thank you very much
you.
for such a fantastic talk. I would like to thank the distinguished speaker. Would like to thank Eli Lilly for their support and their presence here.
Thank you. Thank you.
I think for the sake of time, we just have to move on. Again, I would like to thank and endorse the immense contribution of our sponsor of this conference. And now, sorry, I didn't realize that the mic is off. So thank you very much, Jalal Navesh, and thank you very much, Eli Lilly. And would like to pay tribute and fully endorse the unwavering support of our sponsors. It gives me another pleasure to welcome our next speaker. Again, he's going to deliver a talk on behalf of another quite esteemed sponsor. I would like to call for Professor Ali Zahrani to give his presentation on behalf of Queer Karen. Thank you all for being here. And Ali, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. Great pleasure to see you again. And I was given the task to review with you some recent guidelines and also to share with you a project that we have started several months ago here in the Gulf related to XLH. So as you can see the title here, XLH, Bridging the Gap, the latest guidelines on diagnosis and management in adolescents and adults. So most of this talk will be about adolescents and adults. These are my disclosures. And this is basically the guideline that I will review some of their highlights. This was written by a group of experts on this subject and was published in Nature Review Nephrology this year. And the title, as you can see, Clinical Practice Recommendation for the Diagnosis and Management of X-linked Hypophosphatemia. To start with, like any guidelines, they start with the method of grading the evidence. And as you are all familiar with this, the evidence is basically graded as A, B, C, D, and X based on the strength of evidence. And there is also some qualification of those grading. So there's a strong and moderate and weak recommendations, as you can see here. And to save time, we'll just move on to the guidelines. So the first part of the guidelines is about diagnosis, then follow-up, and then treatment. So for the diagnosis of XLH, should be considered in children when they have clinical, biochemical, or radiological evidence of rickets, or they have impaired growth velocity. One of the manifestations of XLH is impaired growth velocity. Or obviously when serum level is low or age-related reference range and is associated with isolated renal phosphate wasting in the absence of vitamin D or calcium deficiency, especially if there is family history. So I think these are common sense recommendations. When there is some indication that the growth or the bone formation is abnormal, there are evidence of rickets, hypophosphatemia, then XLH should be considered. In adults, the story is a bit different because in adults, they usually have the complication of XLH. So in adults, we should consider XLH when there is lower limb deformities, regardless, or when there is a clinical, biochemical, or radiological signs of osteomalacia, the counterpart of the pediatric rickets. The manifestation in adults include pseudofractures, early osteoarthritis, spinal degeneration and stenosis, dental abscesses and dental caries is very characteristic of XLH that was not treated, and enthesopathies. In the context of serum phosphate level below age-related reference range with isolated renal phosphate wasting, and again, especially if there is family history. So I think these are common sense. Now, when we come to the details, what are, again, the clinical symptom signs that suggest XLH, clinical evidence of rickets in children or osteomalacia in adults, growth failure in children, dental issues. When there are excessive dental problems, then this is very important sign, whether it's in adults or children. Craniosynostosis or intracranial hypertension, and signs of osteomalacia. An orthopedic assessment of the musculoskeletal system should be performed in the presence of lower limb deformities. What are the radiological assessment or diagnostic features? Again, radiological evidence like what you see on this slide, deformities in adults, rickets in children, pseudofractures are very characteristic of XLH. Biochemically, things that we should obtain to support the diagnosis, obviously serum phosphate, calcium, alkaline phosphatase, parathyroid hormone, vitamin D, 1,25-dihydroxyvitamin D, and if you have the ability to do FGF23, and obviously the renal function. So this is the workup for any rickets. It again makes sense. But in addition to this, you want to assess the renal phosphate excretion by getting spot urine for creatinine, phosphate, and calcium. And you should calculate the phosphate, renal phosphate excretion. And there are many formulas for this available online. Molecular diagnosis is recommended if it is available because it's the most definite way to diagnose XLH. And as you know, the underlying gene for XLH is FIX. And if you have the ability to do that, that's the most definite way of diagnosing XLH. What about if the test is negative? Then consider other causes of hypophosphatemia. However, if you don't have the test available or it came back negative, a family history of XLH, X-linked inheritance, which means basically running into males, as well as non-suppressed plasma level of intact FGF23 in association with hypophosphatemia, is very compelling evidence of XLH. So that's the diagnosis. I think the clinical features, the biochemical features, the radiological features, and if you have the ability to do molecular testing. What about the follow-up? This is their recommendation that this is a multi-system disease and it needs multidisciplinary approach. And they think that the least number of types of expert who should be involved in this is an expert in metabolic bone disease, in addition to GP and pediatricians, radiologists, orthopedic surgeons, physical therapists, rheumatologists, and dentists. But in some situations, you need neurosurgeons for cranial deformities, otolaryngologists, ophthalmologists, and so on and so forth. How to follow those patients for children and adolescents at least every 3 months during the phases of rapid growth, and that's infancy and puberty, or after initiation of therapy. So every 3 months in children, and at least every 6 months in patients with positive response to treatment to make sure that they are moving in the right direction and have stable condition. For adults, the recommendation is less frequent, 3 to 6 months if receiving therapy, and every 6 to 12 months if they are stable in treatment. There are several things that you need to do, including functional assessment, skeletal assessment, kidney ultrasound, hearing problem, neurological assessment, as dictated by the patient presentation. And you can see some of those recommendations on the slide. In all patients, alkaline phosphatase is a very important marker of response to treatment. And it's probably the first one that responds to treatment, but we obviously will get calcium, phosphate, creatinine, parathyroid hormone, and vitamin D. And we will assess urine excretion of calcium and phosphate also. In patients receiving brusumab, it's also recommended to measure fasting serum phosphate and TMB over GFR every 2 weeks during the first month. This is very important recommendation. So every 2 weeks during the first month, every 4 weeks for the following 2 months, and then every 3 months during the first year, and at least every 6 months thereafter. So the message here, initially you need to closely monitor those patients because you don't know how the response is going to proceed. But as the patient becomes stable and you have seen the effective treatment, you can slow down and make it less frequent. Measure fasting serum phosphate 4 weeks after each dose adjustment. If you increase the dose or decrease the dose, then after 4 weeks, measure serum phosphate. And measure 125 dihydroxyvitamin D at least every 12 months, as this is one of the effects of the high FGF23 in XLH. Target, we have to make sure that those patients have enough vitamin D, enough calcium supplement, because you could be treating hypophosphatemia and forgetting the other part of the bone minerals and vitamins, and that may lead to impaired response. If parathyroid hormone is elevated, rule out vitamin D and calcium deficiency. That makes sense. That's even in common practice. If on phosphate and active vitamin D, and the patient has hypophosphatemia, high PTH, then you may want to optimize the vitamin D, decrease phosphate dose, and again, some other recommendation here for the management of high PTH in hypophosphatemia. When switching to brusumab, this is very important recommendation that came recently. There are some reported cases of patients developing severe hypercalcemia on brusumab. So if the patient is on brusumab and he has hypercalcemia, the recommendation is to take care of hypercalcemia first. So treat hypercalcemia adequately first. It could be due to tertiary hyperparathyroidism, It could be because of any other cause, including even immobilization or excessive use of vitamin D and calcium. And therefore, it's very important in patients, especially those with severe hypercalcemia, to treat hypercalcemia adequately before starting brucimab to avoid exacerbation of this condition. Monitor serum calcium BTH before treatment initiation and during treatment, especially in patients with existing tertiary hyperparathyroidism. What are the risk factors for hypercalcemia? We all know it: dehydration, prolonged immobilization, excessive use of vitamin D, and renal impairment. So in the last 5 minutes or so, I'll talk about the treatment of XLH. I think we covered the diagnosis, we covered the follow-up. And talking about the treatment, first, I think many of you understand the mechanism of XLH. So XLH is because of mutation in FIX gene. FIX normally suppress FGF23. So if there is mutation, you lose that suppression, and FGF23 increases. And when the FGF23 increases, it has 2 impacts. One, it decreases the expression of the sodium phosphate cotransporters in the renal tubules, and that leads to phosphate leak. And it also inhibits the conversion of 25 to 125 dihydroxyvitamin D, and that leads to low 125 dihydroxyvitamin D. And that has its own consequences on phosphate and calcium absorption. So what we do with brucimab, we block FGF23. Brucimab is an antibody against FGF23, and that restores this balance. So basically, you have better expression of sodium phosphate cotransporters, and you have better level of 125 dihydroxyvitamin D. So you get less phosphate excretion, better phosphate reabsorption from the intestine, normalization of phosphate. And that's basically the simple mechanism of brucimab in XLH. Simply, FGF23 is high, and we block that FGF23, we restore normal physiology. These are the approval for this drug in the Gulf region. So in Saudi Arabia, brucimab is approved for treatment of XLH in adults and pediatric patients 6 months of age or older, and also for the treatment of tumor-induced osteomalacia in patients 2 years of age and older. In the rest of GCC, the brucimab is approved for treatment of XLH in children and adolescents aged 1 to 17 years with radiographic evidence of bone disease, and in adults, again, with tumor-induced osteomalacia. This is a study that assists the efficacy of brucimab in adults. This is a 24-week trial, placebo-controlled trial, and what you can see here is serum phosphate improved significantly in patients who receive brucimab compared to placebo. And after 24 weeks, there was basically open label, and patients who were on brucimab, who were on placebo, received brucimab, and they improve dramatically. So you can see normalization of phosphate, improvement in stiffness, physical impairment, and fracture healing. What are the expected response to brucimab in children living with XLH? Within 1 week, you will see increased TMP, GFR, and serum phosphate. So serum phosphate, usually within the first week, you would expect improvement. Within the first few months, the patients usually will start to feel better. In fact, in my practice, I've seen this happening even within the first few weeks, reduced musculoskeletal pain. Within 6 months, there's improvement in serum alkaline phosphatase, and within 12 months, alkaline phosphatase normalize in the majority of patients. After 12 months, marked improvement in response in growth in children, and again, they continue to improve. So the response is a gradual but soon appreciated in patients on brusumab. This is again from the guidelines. We recommend continuing brusumab beyond completion of growth. So this guidelines advocate for continuation of brusumab after completion of growth in adults. In children who are or adolescents going into adult age, we suggest continuing brusumab treatment if available until at least the middle of the third decade. So we're talking about 25 years or so. The time of peak bone mass. If brusumab is not available, we suggest treating with oral phosphate and active vitamin D. The recommended dose for brusumab, this is important, is 1 milligram per kilogram given every 4 weeks in adults, and the maximum should not exceed 90 milligrams. We don't recommend routine treatment of asymptomatic adults with XLH. However, a careful clinical assessment is needed to establish asymptomatic disease versus many adults who adapt to minimizing their activities. So there are many adults who may not complain of anything, but if you take very detailed history, you will find that they have many limitations in their life, but they have, because of the chronicity of the disease, they have adapted. Those patients might be candidates for treatment. We recommend treating adult patients with significant symptoms and manifestation of XLH, including pseudofracture, musculoskeletal pain, stiffness, biochemical abnormalities, and radiological abnormalities. We also recommend considering treatment for patients undergoing planned orthopedic surgery or dental implant surgery. All of these are common sense recommendations. We recommend beginning treatment with active vitamin D together with phosphate in patients with biochemical and clinical signs of osteomalacia, musculoskeletal pain, or stiffness. We suggest treatment with brusumab in patients with pseudofractures or insufficient musculoskeletal therapy, response to therapy. I see the chair is coming closer to me, so I have to push. We recommend starting brusumab in adults at a dose of 1 milligram per kilogram body weight, not exceeding 90 milligram every 4 weeks. Let me skip some of those. So this is the end of those guidelines. And as you can see, people who are in the field know that many of those are world authority on XLH. I just want to mention briefly that because we have so many particular issues in the Gulf region, with limitations sometimes, with non-availability of brusumab or FGF testing or molecular testing, Kyowa Kirin sponsored an advisory advisory group to look in our situation. And we have actually a paper now under review in one of the journal. It's GCC XLH white paper. Again, these are the contributors. You can see many of them are familiar to you, and many of them are experts in bone diseases. And we have also an international expert from Germany, Professor Lothar Siegfried. And the objective is basically to develop consensus-based, regionally adapted guidelines for the diagnosis and treatment and transitional care of adolescents and adults with XLH. We used a modified Delphi method. 15 experts from 5 GCC countries, and Germany participated in multiple rounds and communication, physical and online. And as I mentioned, the manuscript now is under review, and this is the first GCC region-specific clinical guidance for adults and adolescents with XLH, as intended to unify care practice, improve outcome, strengthen patient-centered infrastructure across the region. Just the prescribing information here in UAE. And again, this is the end of my talk. Thank you so much.
Thank you very much for an excellent talk. And beyond doubt, Kyowa Kirin is making an excellent initiative. And I'm sure this is going to make a hell of a difference to the management of a rather very rare but quite important and debilitating disease. Thank you very much. Would like to thank Q Karen. Thank you all. And we will break for coffee, and we have to reconvene in 2 rooms. Room A here, where we'll have 2 parallel symposia, one here and the other one in room B. Thank you very much, and see you all at 10:30, please. Just after just over 10 minutes from now. Thank you. Thank you, Ali. Assalamu alaikum jami'an. Welcome back, everybody. We shall be starting the symposium on obesity in room A. And if I may just request the 3 chairpersons to come to the center stage. Muhammad Hassanin and others, please. Noor and Lamin.
Assalamu alaikum. Good to see you, everyone. Thank you for GAED for the kind invitation. My name is Muhammad Hassanin. I'm a consultant endocrinologist at Dubai Hospital. Have the pleasure to co-chair this session with Dr. Noor Busaidi from Oman, as well as Dr. Lamin Abdul Qadir from Dubai Hospital. We have a session on a symposium on obesity and monogenic diabetes. I have the pleasure to introduce the first speaker, Professor Alex Miras. I cannot see Professor Miras. Okay, so perhaps if maybe we can then introduce the second speaker, maybe we change the program and go to the second speaker.
Assalamu alaikum. It is my pleasure to co-chair this session on obesity. And our second speaker is Dr. Sarah Suleiman. Dr. Sarah Suleiman is a colleague. She's an excellent researcher, clinician, and a faculty of so many organizations. She's the lead in a lot of training in obesity. Today, Dr. Sarah Suleiman, currently, she's the lead in genetic and pediatric service and a member of the UAE National Guideline Committee for Type 2 Diabetes. She's also in the process of establishing the MENA Obesity, which is affiliated by the World Obesity Federation. So Dr. Sarah Suleiman will talk to, in this session, she will talk to us about, let me see her topic. So her topic is evaluation of obesity complication. Dr. Sarah Suleiman, the floor is yours.
Thank you very much, Dr. Noor, for the very kind introduction. And شهادتك مجروحة, but that's okay. I'm very grateful to the organizers for giving me an opportunity to speak about the evaluation of obesity complications. I'm going to cheat and speak about the evaluation of obesity and its complications, because the first one is far more interesting. It's a big topic, so we're going to race through. Obesity is a chronic, relapsing, multifactorial neurobehavioral disease. It is not a lifestyle choice. It results in an increase in body fat mass, abnormal distribution, and dysfunction, and therefore has adverse metabolic, biomechanical, and psychosocial health consequences. Every patient has a different story, and it's our job to try and figure that out. There are more than 1 billion people living with obesity in the world, 1 in 7 individuals, about 880 are adults, and even more scarily, 160 million are children. It's associated with many chronic disorders. The ones in the dark blue are the metabolic. They're the core of what I do. 50% of people living with obesity suffer with hypertension. About a quarter have coronary artery disease. And everything else. The ones in green are the mechanical. They're no less serious, things like sleep apnea or problematic osteoarthritis. And we must not forget the mind. Obesity is associated with depression, anxiety, and many psychological disorders. It's a chronic relapsing disease, as we've said, and we need to treat it lifelong. It results in reduced life expectancy, lower health-related quality of life, and an economic burden on that individual and their family, as well as the countries at large. No country can afford not to treat obesity. However, it's not all doom and gloom. And we know from lots of studies that even a small amount of weight loss, 5% weight loss, leads to improvement in blood pressure and dysglycemia. And the magic number I'd like you to remember from today is 15%, because at 15%, we reduce mortality. We improve things like heart failure, which are terribly difficult to treat, and get type 2 diabetes remission. And in the middle, we get improvement of many other disorders. Obesity accounts for about 85% of type 2 diabetes, and I'm going to use type 2 diabetes as a model of a complication of obesity. Elliot Joslin in 1927 said, with an excess of fat, diabetes begins, and from an excess of fat, diabetics die. He's very right. We know from longitudinal studies that with the increase of obesity, there's an increase of diabetes. Not only that, looking within a BMI of 35, which these days is relatively slim, you can see that there's a 100% increase in rates of diabetes in young, healthy nurses. And if we look longitudinally, over a 10-year period, a weight gain of 5 kilograms, so half a kilogram a year, doubles your risk of diabetes. And a weight gain of 15 kilograms, 1.5 kilograms a year, gives you a 6-fold increase in diabetes. Treating obesity is the best management for the prevention, treatment, and remission of diabetes. And I'll go through a few examples, but there are many more. So if we look at prevention, we know from lifestyle, including the Finnish prevention study, that we can reduce the rates of conversion to diabetes by 2/3. If we use Orlistat, which is a very weak obesity medication, you halve the rates of conversion of prediabetes to diabetes. If you use more potent medication, 3/4, bariatric surgery, 90%. And with the GLP-1 agonists, there's a 94% reversion of prediabetes to normoglycemia. So treat the obesity, the prediabetes will go away. What if someone develops diabetes? We've learned from bariatric surgery, which is not a magic formula, but it just has taught us that efficient weight loss results in remission of diabetes, 13-fold chance in the first 2 years, and even 15 years down the line, 6 times as many people have gone into diabetes remission. We used to say that once a person was on insulin, they could not come off it. And I'd just like to point that with a gastric bypass, about 50% people on insulin beforehand, only about 10%. And as you can see, many of these have actually reverted to normal glycemia. Can we do this with lifestyle? Yes. The direct study from the UK has shown us that, again, the magic figure of 15%, if you're able to lose that with a very low calorie diet, then there is a remission of diabetes in those on metformin or diet alone of 86% in the first year and 70% in the second. This is a 12-week, very low calorie diet. Can we do it with medication? And yes, this is the data for tirzepatide. And as you can see, the mean HbA1c at start was 8%, and at the end, the mean HbA1c was 5.7%. What about the other risk factors? So many of you are now doing their own cardiometabolic, cardiorenal clinics. And I just want to highlight that stage 1 is well recognized to be abnormal adipose tissue and obesity. On the cardiovascular system, not only do we have the classic risk factors and atherosclerosis, but actually heart failure is one of the big orchids. So I'll define orchids now so I can then use it. It's obesity-related chronic disorders. Heart failure, arrhythmias, thromboembolism, valvular disease. So when you're assessing a patient, it's not just their blood pressure. It's everything else. What happens when we treat obesity? So we've learned again from metabolic surgery that you reduce MACE, both 3-point and 6-point MACE, by about 40% with bariatric surgery. More recently, with the SELECT trial, we were able to show that with Wegovy or semaglutide, there's a reduction of a smaller magnitude, but a reduction nonetheless of 20% on top of all our classic treatments. And more recently, we've had evidence on tirzepatide, we've had evidence on oral semaglutide. That field is expanding. Similarly, for CKD, there are many mechanisms that obesity results in deterioration of renal function without even the classical risk factors. So pressure on the kidney, adipose tissue and fatty acid deposition inside the kidney. And what that means is if we manage to lose weight, even with lifestyle and minimal weight loss, so 4 kilograms, then we have a 30% reduction in the incidence of CKD. And CKD 3 and 4 have a mortality higher than most cancers, 15% in 5 years. But those who've had bariatric surgery within that group, 2/3 reduction in their mortality. So obesity is a key driver and treating obesity helps. More recently, with the FLOW study, we've been able to show that this also happens with medication and semaglutide in particular. What about fatty liver disease? It's the bane of our lives. It's now the highest cause for transplants in women. And again, this is 12 weeks very low calorie diet. The intrahepatic fat has gone from 36% to 2%. And there is good data now for both semaglutide and tirzepatide showing not only reduction of liver fat, but improvement of fibrosis. Unfortunately, we're beaten by the bariatric surgeons on this one. So in bariatric surgery, there's a 90% reduction in biopsy-proven MASH. And in the same group, there's a 70% reduction of cardiovascular risk. And this is data from Ali Aminian at the Cleveland, Ohio. What about cancer? Cancer is well associated with obesity, and there are many reasons for that, not just the estrogen, but increased IGF-1 levels, chronic inflammation, and adipokine dysfunction. Of the top cancers, at least 13 are well associated with obesity. And not only that, individuals with obesity get a very rough deal. They often have no way of going for their screening because there's no easy transport. When they get there, the CT scan doesn't fit them. We don't know if there really is something in the mammogram or is it fatty tissue in the breast. When they're given chemotherapy, most chemotherapies say X milligrams per kilogram up to a maximum of 100 kilograms. If you're 250 kilograms, you're getting a quarter of the dose you really need. And therefore, their survivorship is much worse. Again, we've learned from bariatric surgery, and this is a huge cohort, 22,000 individuals who've had bariatric surgery and 3 times as much who have not, that there is a reduction of about 50% in breast, colon, endometrial, and pancreatic cancer. Very worthwhile treating obesity. So why does it cause these metabolic effects? It's a combination of adipose tissue dysfunction and metabolic inflexibility, aberrant fat deposition and insulin resistance, adipokine dysfunction, and regional adipose tissue distribution. I'm going to really race through this because we haven't got much time. But historically, we were taught that when you eat, the fatty acids go into adipose tissue, a little bit goes into muscle, a little bit goes into the liver, and they're just a store for energy when we need it. What we know now is that that's not the case. Adipose tissue is either flexible, where it produces lots of new cells and retains metabolic flexibility, or the adipose tissue cells expand and they become unhappy, inflamed, and result in insulin resistance. And there are many factors, including genetics, age, gender, that result in that. And therefore, these overfull adipose tissues, which in one person could be a BMI of 25 and another a BMI of 20, result in fatty acid overflow into the liver and muscle, resulting in insulin resistance. Adipose tissue is also the largest endocrine organ, and it's not just the adipocytes, it's the immune cells, it's the endothelial cells, and everything else in the middle. And these adipokines regulate themselves. They regulate appetite and satiety, such as leptin. energy, activity, glucose metabolism. And under conditions of adipose tissue dysfunction, this results in secretion of adipokines in a dysregulated manner. So how many of you were taught anything about obesity at school? Medical school, I meant. Great, I didn't either. The only thing I was taught is that there are apples and pears. And if you're an apple, it's high risk. And if you're a pear, it's low risk. And actually that's true. And we've known from data from very long time ago that people with upper body obesity or a tummy tend to have higher insulin response to OGTT, even within normal glycemia. And one of my favorite studies is the InterHeart study, which looked at 27,000 individuals across 52 countries for hard endpoints, a heart attack, coronary bypass, or mortality. And what they were able to show is if you look at different BMIs, you really can't separate them. Whereas if you look at a waist-hip ratio, there's a gradually increasing risk. Not only that, if you look at waist circumference, increases risk, and hip circumference reduces risk, suggesting that adipose tissue, where it is, actually means quite a lot. That answers our question of why does one person with a BMI of 30 have diabetes, high blood pressure, high cholesterol, or heart attack, and another person with a BMI of 40 not have any of that? It's because it's where the fat is and how the fat behaves. And in fact, if we look at the cutoff, where a BMI of 30 in Caucasians would result in diabetes and cardiovascular disease, in an Asian male, that cutoff is achieved at a BMI of 22.6. And in an Asian female, that BMI is achieved at a cutoff of 21.5. What's our local data? We don't know, but the data is available and we should be able to look at that. And if we look at all the races, all the guidelines are based on whites who actually have the lowest risk of cardiovascular disease per meter squared. So how do we classify obesity? Historically, this was based on BMI alone. We all know the WHO classification. There's now class 4 BMI more than 50, class 5 BMI more than 60, and God knows where it's going to go. But does that tell us the whole story? No. What about that bodybuilder who comes with a BMI of 38? 100% muscle, almost 100% muscle. Does he have obesity? No. Doesn't differentiate. So what's happened in recent years is that the obesity community has moved away from BMI alone and are looking at other things. One of them is waist circumference, which interestingly was here at the very beginning, went away and is back again. And the thing to say about that is we need to look at ethnic specific cutoffs. So for us, for example, a male with a waist circumference of 98 would have a significant risk, whereas for a Caucasian from North America, not so. The new kid on the block, and in 5 years' time, I think that's all we're ever going to be speaking about, is a waist-height ratio. A, because it's easy and can be measured everywhere else, and B, because it's associated with cardiovascular disease. But basically, below 0.5 is normal, 0.5 to 0.6 is high risk, more than 0.6, very high risk. There are additional measures that we can look at, particularly if we're tracking weight loss or health benefit. Bioelectrical impedance is easy. The others tend to be used for research, really. Last year, the Lancet Commission was published, and this looked at that question of, is it really obesity? And if it is obesity, how can we differentiate? And what they say is, it doesn't actually matter what the BMI is. If there is no excess fat, it's not obesity. So you should use another measure. And if there is excess fat with disorders, then it's clinical obesity. And if not, it's preclinical obesity. And the aim was to prevent people who are not sick being labeled as having a disease, and to allow those who have the disease, even with a lower BMI, to have therapy. Much older than that, the Canadians actually were ahead of the game, and what they produced was the Edmonton staging system. And this staging system was based on the classification we said earlier of medical, mental, and functional, and goes from stage 0 to stage 4. So stage 0 is no disease. So if we use diabetes as an example, that it would be normoglycemia. Stage 1 would be preclinical, so impaired fasting glucose or IGT. Stage 2 would be the disease with no complications, so type 2 diabetes. Stage 3 would be the disease with complications, so microalbuminuria, for example. And stage 4 would be end-stage disease, so dialysis or CKD 3 or 4. And what that has shown beautifully is that they can predict mortality based on this staging. So on the left, looking at BMI, going through the NHANES data, really not very much difference. But if you use stages 0 to 3, then there is a 70% difference between those with stage 0 and those with stage 3. More recently, earlier this month, earlier last month, the ACE have come out with a consensus statement, similarly looking at obesity staging. What they've called, actually they've called it for a little while, is ABCD, adiposity-based chronic disease, moving away from the word obesity. And again, they've gone for preclinical, clinical, and clinical with obesity-related diseases. They have this lovely pathway. I would highly recommend you look through it, telling us what we need to look for. But I'll go into details. So what do we need to do as a physician? What do I need to do to the patient in front of me? So the ACE guidelines have this table. They also have the disease. In the UAE, we're very lucky to have two guidelines, the national guideline and the Department of Health guideline, which were both published earlier this year. And I'll be talking to you about the Department of Health guidelines, which were published in February of this year. What they have allowed us to do is to give medication funded by insurance by individuals who qualify. So either a body mass index of 40, accepting that has to be obesity, body mass index of 35 or above with an obesity-related complication in the right column. And as you can see, most of them say all cases qualify. And even for those with a body mass index of 30 to 35, providing they have a severe obesity-related complication, they would qualify for treatment. To be able to offer them that, they needed to follow a certain assessment, and we'll talk through that. So the first thing to do is most people living with obesity have had self-stigma for all their lives. They feel it is their fault. And reiterating that by saying, eat less, move more, doesn't help anyone. They go away and they don't come back. Use non-stigmatizing language. Ask them why they're there and how they'd like us to help them. It's a person living with obesity, not an obese person. Obesity does not define who they are. Educate them about the number of treatments that are available and can improve their care, because that engages them, and focus on health gain, not weight loss. And actually, more recently, there's a lot of evidence about health gain even without weight loss. We take a history, and one of the most important things is understanding when the obesity started. Children who start their obesity journey below the age of 3 most often have monogenic disease. Their treatment is very different. It's beyond the scope of today, but please do ask how long they've had it for, what treatments they've looked for before, what the success was, their current phase. So some patients will come and say to you, I'm the heaviest I've ever been now. I'm 85 kilograms. And when I got married, I was 64. They forget to tell you that actually I was 118. I had bariatric surgery, went down to 84. Completely different story. Any clear precipitants of mobility, significant life events, getting married, losing a job, family history of obesity. Obesity is a genetic disorder. It's 85% or 80% heritable. Psychosocial disorders we need to ask about, looking at risk factors, so family history, dietary history. In our region, the highest risk is sugar-sweetened beverages. They are a disease that includes juices, Red Bull, all sorts. Highly processed food, exercise routines, sleep hygiene, again, really critical. وَجَعَلْنَا اللَّيْلَ لِبَاثًا وَجَعَلْنَا النَّهَارَ مَعَاشًا وَجَعَلْنَا مِنَ الْمَاءِ كُلِّ شَيْءٍ حَيٍّ. They are the basis of treatment. Stress and stigma. History of complications, and often they will tell you, but you still need to look for them. Assess their readiness to engage with management, their psychological state, their environment. Will they be able to afford treatment, their employment status, and speak with their family and their care workers, particularly people with disabilities. Like everyone else, the past history, the surgical history, their drug history, really critical medications that help lose weight or medications that gain weight, particularly people on antipsychotic medications, makes a huge difference fiddling around with that. Family history, medullary thyroid cancer, let's kill that now. Yes, we can treat people with thyroid cancer with GLP-1s, unless it is medullary thyroid cancer. And so see the histology. Smoking and activity history. So you review their apps with them, because them saying, I walk 6 hours a day, you take the stigma away when you say, actually, if you see my app, it's no better than yours. Systems review, look for that heart failure, breathlessness, chest pain, varicose veins, intertrigo. Examination, pallor. You'd be surprised how many people living with obesity have such a poor diet, they're anemic. Affect, dysmorphic features. Cushing's is a rare disease. It's a 1 in a million. So there are about 10, maybe 20 individuals in the UAE with Cushing's, yet we screen every second patient. We just need to be a bit more careful. Polycystic ovarian syndrome, signs of insulin resistance. Anthropometric measures, we spoke about earlier. So height, weight, waist circumference, hip circumference, and neck circumference if we're going to assess for sleep apnea. A full cardiovascular examination, including evidence of snoring at rest, reduced air entry. Stop bang score, simple score for obstructive sleep apnea. Stop. Do you snore loudly? Do you feel tired, especially in the mornings? Have you been observed to stop smoking? Do you have high blood pressure? Bang. BMI more than 35, age over 50, neck circumference over 40 centimeters. That's why we've asked for it. And male gender. If it's below 2, you're okay. Anything above 3, do refer for an assessment. And if it's above 5, they're very likely to have sleep apnea. We look at liver span, stigmata of chronic liver disease. We look at the musculoskeletal system and the skin. So what are the investigations? And these, for those who work under the auspices of DOH, are all covered by insurance. So glycemia assessment, lipids, blood count, thyroid function, renal function, urinary microalbuminuria, because often that's the first sign that it's affecting the kidneys, liver function, age-appropriate cancer screening, and any others that you feel are appropriate. Think about who you want to refer to. Do they need to see a hepatologist? Do they need an ultrasound scan or a fibroscan? Do they need to see a pulmonologist for their sleep apnea, a cardiologist? And do they need a DEX suppression test? So in summary, we would go back to that initial slide and think about what things are affecting the individual in front of us. We would then give them an Edmonton stage or any other stage. If you want to do the EASO one or you want to do the ACE one, they're all very similar. Discuss what amount of weight loss they need for their health gain. And what that allows us to do is to select the appropriate management strategy for each patient and give them personalized care. The goals of our management in 2025, and Alex, I'm not going to step on your toes, I promise you, are obesity management, which is not just weight loss. It's weight loss plus improvement in the symptoms of hyperphagia, hunger, excessive craving, managing all the associated side effects, metabolic, structural, physical, neoplastic, and everything else, and the prevention of future obesity complications. There are frameworks for treatment, and Alex is speaking about treatment, but they tell you if someone has fatty liver disease, what medication should I choose? So EASO has one and ACE has one. They're really good. And it tells you how much weight they need to lose to improve that particular complication. So in conclusion, obesity is a chronic, relapsing, multifactorial, metabolic, and endocrine disease associated with adverse health outcomes. It is not a lifestyle choice. Assessment, therefore, requires careful assessment to understand the risk factors and complications. The baseline assessment is key to selecting what therapeutics you're going to give them, and you need to agree that with the patient. Refer individuals with advanced stages of obesity for secondary care, please. They need an MDT, but those with stage 0 and stage 1 should be looked after by a family physician. There are not enough endocrinologists, bariatric surgeons, obesity physicians to treat 1 billion people. I'm very grateful to our multidisciplinary team. Together with Dr. Mohammed Haddad, we lead over 40 individuals with many specialties, including gastroenterology, cardiology, pulmonology. You can see We're looking for a sports physician if you know one, but the most important person in this picture is the patient who selects what type of treatment they're going to get, but helps us by being assessed properly. It remains for me to invite you to the UAE Obesity Conference, which is going to be held next month in Abu Dhabi. You're all very welcome. Thank you.
Thank you, Dr. Sarah, for this excellent lecture about obesity, evaluation, and complication. And I hope by now she really convinced all of you that when you see a patient with obesity, either you address the patient or refer to somebody who can address. So please do not ignore. And now I'll invite Dr. Amin to introduce our second speaker.
Thank you, Dr. Noor. Assalamu alaikum. Good morning, everyone. My name is Elamin Abdelgadir, and it's a pleasure to co-moderate this session with Dr. Muhammad and Dr. Noor. And it gives me a great pleasure to introduce a friend and a colleague, Dr. Samar Hassan. Samar has recently joined the endocrine community in the UAE, so welcome, Samar. And I'm sure she will add tremendously to the service and science. Dr. Samar is a dedicated, experienced pediatric endocrinologist with more than 15 years of experience. She has a special interest in obesity, monogenic diabetes, and growth disorders. She has published immensely in these fields, linking the data from the Middle East with international institutions. And she will address today the monogenic diabetes global insights in children. So, Dr. Samar, please, the floor is yours.
Assalamu alaikum and good morning. In the coming 20 minutes, I will present a global insight into monogenic diabetes in children. Please do not be surprised that my presentation does not fit fully in the theme of obesity symposium today. Okay, so these are my disclosures. So monogenic diabetes is a heterogeneous subtype of diabetes. And in contrast to type 1 and type 2 diabetes, they result from single genetic defects. Currently, there are more than 50 forms, with neonatal diabetes and Moody representing the majority of cases. Now, this table here shows the gene panel sequence for patients with monogenic diabetes tested at Exeter University in UK. So let us start with the main subtypes of monogenic diabetes. Moody, it's a miscellaneous group of monogenic diabetes that vary with the age of onset of diabetes, rate of progression and complication, the need for treatment and the response to treatment, and the presence of extra pancreatic features. Now, the phenomena of Moody was first published in 1975, and historically, Moody types were described using numbers. Currently, we use genes to describe the types, and ever since the identification of the first Moody gene in 1991, the list of genetic causes has expanded to include 14 genes. Some are common, like the HNF1 alpha, the GCK. Others are very rare, and they remain debatable whether they should be included in the list of genetic causes of Moody. So some potentially new Moody genes have been reported, and a lot of studies now are recommending to reclassify Moody into the three groups: the common Moody, the rare Moody, and those with potential new Moody genes. So if we look at the global frequency of monogenic diabetes, we find that there are many studies published and reported from some areas, as illustrated here in this map in the dark blue, mainly China, India, Europe, and America. If you look at the global frequency of Moody, we find that Moody has been extensively studied from European populations. And in this study here that was recently published earlier this year, we find that HNF1 alpha is prevalent among Denmark and Austria, while GCK Moody is prevalent among Spain, Greece, Italy, and Germany. On the other hand, monogenic diabetes among non-European populations are very sparse studies, not much studies from non-European populations. But if you look at Middle East, this study from Qatar, published in 2023, showed that Moody represented around 2.2% of the study population, and they were mainly HNF1 alpha Moody. From Kuwait, this study published in 2021, Moody represented 22.6% of the study population, but the cohort was rather small. From Africa, South Africa, HNF1 alpha Moody represented 5.9% of the study population. This study is our cohort from Sudan, which is under publication and review currently, and it is considered the largest of its kind from sub-Saharan Africa. So in this cohort, we had 88 patients that were divided into group 1, which are the neonatal diabetes patients, and we'll talk about later, and the group 2, which the onset of diabetes occurred after 6 months of the first 6 months of age. So we found that mainly it was syndromic monogenic diabetes that was predominant over the Moody. So the disease-causing variants in 7 genes affecting 33 patients, mainly the genetic causes for Wolfram syndrome and Fanconi-Bickel were the commonest, and only 1 patient who had Moody, HNF1 alpha. So why are Moody patients underdiagnosed in populations such as our population from Sudan? Well, overlapping clinical features of Moody with the common types of diabetes make many cases of Moody misdiagnosed as type 1 and type 2. Then the lack of awareness of clinical suspicion for Moody among physicians, and many physicians do not use the Moody probability calculators. Then if we look at the resource-limited countries where antibody testing is not available due to the high cost and the lack of funded screening programs, such as in Sudan, here this study showed that the incidence of type 1 in Sudan was among the highest in Africa. And despite this, all patients in this study were based on clinical diagnosis, not antibody testing. So imagine how many Moody patients we can miss in a large number. So the molecular mechanism of Moody involves different mechanisms that involve beta cell dysfunction, but the commonest is that those that are affecting the transcription. So different approaches have been published about Moody in the literature, and they all suggest that selecting patients for genetic testing is based on clinical criteria or clinical diagnosis. So the key indicators of Moody would be the age, the onset of the before the age of 25 years, a dominant family history in 3 consecutive generations, then the lean or the absence of insulin resistance, absent autoantibodies, presence of preserved C-peptide levels, and then specific Moody type features you can find. But we will see that it's not always these criteria are found in when selecting Moody patients. So this is the Moody probability calculator. It is, as I mentioned, is not practiced by many physicians, but it is available on websites. This is the Moody probability calculator used by Exeter. If we look at the age of onset, we might miss out Moody patients if we depend on the age of onset, as there are many cases reported at late adult onset. And if we depend on antibody testing, as I mentioned, from populations where there's no antibody testing, then we'll miss out a lot of patients with Moody. The family history is strong in Moody, but it's not always the case. Sometimes you find no strong family history of Moody. And these slides actually are the slides that will link my presentation to this theme today. If we depend on the BMI of the patients having normal, we will miss out on a lot of Moody patients who are actually obese. So obesity has been frequently observed in many types of Moody, such as Moody 4, Moody 6, Moody 11, and Moody 14. And it's really the interaction with environmental factors that are related to obesity So you can find obese Moody patients, especially in ethnic groups with high prevalence of obesity. So many studies have reported the link of obesity with Moody. And in this study, which was published almost a decade ago, 4% of obese patients were thought to have type 2 diabetes, and they were genetically diagnosed with Moody in the Today cohort study. And in this study from Qatar in 2022, 83% of the Moody patients were overweight or obese. And in this study here in early January, they compared 108 Moody patients who were genetically identified to 108 control group, and it was found that 24% of Moody patients were found to be obese, and even 72 had dyslipidemia. So all these studies kind of recommend that not to depend on absence of obesity when clinically diagnosing Moody patients. So the common forms of Moody are the HNF1 alpha, and this form is kind of common in Europe, and they are known to have glucoseuria, and they respond very well to sulfonylurea. But with time, they may their sensitivity to sulfonylurea may decrease, and they also have the risk of chronic complications. Then HNF4 alpha, which looks like HNF1 alpha, but there's variable response to sulfonylurea with no low renal threshold, and you might find a family history of macrosomia or persistent hyperinsulinism. So GCK is one of the common also Moody's found in Europe. It is due to heterogeneous inactivating mutation of GCK, and they usually are incidentally found to have fasting hyperglycemia, and the hemoglobin A1C is usually on the mild elevation, and usually they do not need treatment as they do not go into many complications. Then the syndromic forms of Moody, which are the HNF1 beta and the cell Moody, you can find pancreatic cysts or renal cysts in these kind of syndromes. So moving on to neonatal diabetes, which is the onset of diabetes in the first 6 months of life. To date, there are more than 40 genetic causes of neonatal diabetes. And in this diagram here, it nicely illustrates the molecular mechanism of genetic causes in neonatal diabetes, which vary. They can be at the level of the receptors, the potassium ATP channel, or it can be in the mitochondrial, it can be in the endoplasmic reticulum, and it can be due to synthesis, defects in the synthesis of insulin and action, and many other mechanisms. So in the recent 7 years, past years, with the advancement of genetic testing, 6 new genes have been added to the list of neonatal diabetes. And 3 other genes that were before known to cause other conditions currently are now detected to cause neonatal diabetes, and they were added to the list of genetic causes of neonatal diabetes. So if you look at the global frequency of neonatal diabetes, it is studies from European populations say that the commonest causes or the classification of neonatal diabetes is mainly the isolated permanent type and the transient type, with the incidence of 1 in 100 to 500,000 live births, and the activating causing variants of ABCC8 and KCNJ11 are the commonest cause. But if you look at the other countries with high consanguineous rates, we find that there's a difference in the incidence and the pattern of genetic causes. And over the years, there has been many reports on neonatal diabetes from these populations, and they all report the predominance of syndromic causes of neonatal diabetes. And this is our cohort that was published just last year on neonatal diabetes from Sudan. And we reported a very high incidence of neonatal diabetes in Sudan, which is kind of comparable to some Arab countries, with predominance of syndromic forms illustrated in the brown bars, compared to other countries where KCNJ and ABCC8 in 11, E8 were the commonest causes. So disease-causing variants for 14 genes in 38 patients in our cohort were detected, and the commonest cause were the genes due to Wilcott-Rallison syndrome. So there are more than 30 genes for syndromic neonatal diabetes and 15 genes for neonatal diabetes with autoimmune mechanism. And many genes, 19 genes that cause syndromic monogenic diabetes, and over 9 genes that cause monogenic diabetes with severe insulin resistance and lipodystrophy syndromes, and others that are involving mitochondrial variants. So as the list is expanding, I would just like to present a few cases from our cohort, which are on syndromic monogenic diabetes. These 2 patients presented with neonatal diabetes, as you can see, with the coarse facial features and signs and features of insulin resistance, and that was due to INSR gene mutation. Now, this patient on the left, as she grew older, you can see the clinical features that suggest insulin resistance, the acanthosis nigricans in the hirsutism. And then this child, she presented with neonatal diabetes and severe DKA. It was very difficult to treat this child. We had to give generous doses of insulin to overcome the resistance. And she also had presented with large ovarian cyst and clitoromegaly. And this is also an INSR mutation in a child that presented at an older age, at the teenage, with you can see the abnormal teeth and the convex nails and the acanthosis nigricans and hirsutism, and also she required high doses of daily insulin. And these 2 siblings also were INSR mutation, and you can see that the acanthosis nigricans that we tend to see in type 2 diabetes is very prominent here. And even the brother presented with gynecomastia. And this child, who was diagnosed with the Wilcott-Rallison syndrome, presented in the neonatal period with neonatal diabetes, and as he grew, we can see the deformities, the progressive skeletal deformities shown, and he had hepatomegaly, and in the x-rays you can see the metaphyseal changes. And this child, who presented with Rogers syndrome due to Salk 19A2, presented with congestive heart failure due to anemic heart failure due to macrocytosis, and he was found to have sensorineural deafness. So, and this child also presented in the neonatal period with hepatomegaly and signs of rickets, as you can see in the x-ray, and the wide wrist. And the liver biopsy showed glycogen storage disease. So this child had SALK2A2 due to Fanconi-Bickel syndrome. And in this child also presented in the neonatal period with AGPAT2 mutation that's causing generalized lipodystrophy. And you can see the wasting and the wasting of his face, and he has xanthomata and prominent veins. And this is another child who also presented at the neonatal period with the same genetic cause. This child presented in the neonatal period with neonatal diabetes. And as she grew, she had pancreatic insufficiency, malabsorption problems, and these deformities that you can see in her hands were due to rickets secondary to malabsorption. And she had the defect in PTF1A. This child, as you can see, is wearing a hearing aid, and he has a catheter in, and he presented with diabetes at the age of adolescent, and he was also found to have some optic atrophy. So this was genetically found to have Wolfram syndrome. And this child, he also presented in an adolescent age with multiple cutaneous manifestations, proptosis and cardiomyopathy, and he had PIK3R1 gene due to Short syndrome, and he was actually a very stunted child. And this presentation in 3 different patients due to Salk 29A3 with different cutaneous manifestations and diabetes, and these were patients who had what is H syndrome. So my last slide here is just showing the merit of genetic diagnosis in monogenic diabetes. And as Prof. Asma showed the importance of genetic testing in endocrinology. Genetic testing in monogenic diabetes gives us better understanding of the pathophysiology and pathways causing monogenic diabetes. It identifies new monogenic forms and discovers new genetic causes. It characterizes monogenic diabetes on population basis, and it helps a lot in genetic counseling. And it also has its very big importance in advancement in management, such as using sulfonylurea in some cases of Moody and neonatal diabetes cases. And also in GCK Moody, no treatment is needed, so they spare them from any treatment. And leptin as used in insulin resistance syndromes. It can also help in prediction and anticipation of complications and prognostic outcomes. So at the end, I would like to give my acknowledgement for all co-authors of the 2 publications we had, and to Exeter University, University of Cambridge and Wellcome Trust, and to our Sudanese endocrine societies, the SUSPED and the SCADA, and Ja'far ibn Auf Teaching Hospital and Sudan Childhood Diabetes Center.
Thank you very much, Dr. Samar. This is too much genetics to comprehend by adult endocrinologist group. Thank you very much. That was fascinating. I'll introduce Dr. Mohammed Hassanin to present or to introduce the next speaker.
Thank you, Amin. So we go back with more strength into the obesity theme, and I'm delighted to introduce Professor Alex Miras. Professor Alex Miras he works in Ulster in Northern Ireland. He is one of the eminent researchers in obesity. He's part of the NICE obesity guidelines as well as the Obesity Society. So Professor Miras, looking forward to your presentation.
Great. Sorry for disturbing your program earlier. Good to see you again. And thank you very much to Sarah for stepping in. In fact, she has made my life much easier. So I will move straight to the important points I wanted to share with you, and hopefully that will allow us to finish pretty much on time. So what I will be doing 2 things. I will be talking to you about some of the key data on pharmacotherapy for obesity that we have gathered in the last 2 years or so. I'm sure, like you, many others are bombarded by the huge amount of data that we are getting on obesity pharmacotherapy, and sometimes it's easy to lose where the direction of travel is. The second thing I will be doing is going through some of the safety issues that, again, over the last few years have raised some concerns. And I will try to reassure you by giving you some of my insights. So I will summarize the progress that we have made in the pharmacotherapy for obesity over the last 10 years only by saying 2 things. Firstly, our treatments are finally safe. And the reason why our treatments are probably safe and finally safe is because we are using a system in the body that already exists. We're not using anything which is acting on too many receptors that we don't know about. This is something that we did previously with other pharmacotherapy for obesity, and it didn't work very well. And the second thing that you will notice from this slide is that the amount of weight loss, at least, that we can induce with our newer agents at the moment is increasing exponentially, to the point, like as I said yesterday when we were talking about bariatric surgery, that to the point that in the next 12 to 24 months, we're going to have medications that cause the amount of weight loss that a gastric bypass operation would typically achieve. We have now surpassed the amount of weight loss that a sleeve gastrectomy would typically achieve, which is 20%. So this is where we are. in terms of the development of these medications, and we are now branching into the not only single agonists, but also, of course, dual, triple, and combination therapies. And in the Middle East, you have generally been very early adopters of these medications, and you probably have got a lot more experience than I do certainly in using them. So semaglutide, again, I'm sure you have been using for some time now. Remember the average weight losses that are approximately 16%. And what is very interesting is that if you follow these patients up for longer, at least in the clinical trials, you will see that their weight remains very flat. I was expecting that we will be seeing some weight regain over the years, but interestingly, at least in the trials, the weight is very nicely stable, which is a positive sign. Let's talk about what has happened in terms of hard outcomes now with semaglutide over the last 24 months or so. We have got very beautiful data on the use of semaglutide in people who have got obesity, diabetes, and heart failure with preserved ejection fraction, which is very common in our populations and difficult to diagnose. And in this randomized controlled clinical trial, 600 people with those conditions were randomized between placebo and 2.4 milligrams of semaglutide, so Wegovy. And what you will see is that there was a significant increase, a significant improvement in the Kansas City Cardiomyopathy Questionnaire, which is a questionnaire that assesses mostly functionality in people who have got heart failure. And what you will also notice is, as you would expect in people with obesity and diabetes, the weight loss was not 16%, it was about 10%, and that is a consistent finding amongst all studies of obesity therapies in diabetes. So we're now seeing the benefits, not only in terms of weight, but in really hard outcomes like heart failure that affects our patients' lives, but also can actually kill them early in their lifespan. The SELECT trial is being spoken a lot. It is a seminal trial in the field. Again, semaglutide, 2.4 milligrams, 17,000 people with obesity, no diabetes, randomized to placebo versus 2.4 milligrams for 4 years. And in panel A, you see this beautiful 20% reduction, relative risk reduction in the development of major adverse cardiovascular events, including death. But let me show you one of my favorite slides from the last 12 months. This is a busy slide, but basically what it shows you here is this hazard ratio. So it shows you the difference in terms of the MACE events between placebo and semaglutide. Here is the hazard ratio, right? In terms of the incidence of MACE. And this is a hazard ratio as it evolves over the course of the trial, ending up at the 20% reduction that I have just mentioned, right? This is at 4 years. But have a look at what happens here. The first statistically significant difference between placebo and semaglutide takes place on day 20 after randomization. Day 20 of using the drug, which means that you haven't even had the chance to increase the dose of semaglutide to the next level, and it is already showing signs that it is working, suggesting and complicating our narrative that maybe semaglutide is not just an obesity drug, but it is a cardiovascular drug that has weight loss as a side effect. And it suggests that even having a little bit of GLP-1 hormone around in your system, excess GLP-1 hormone, is enough to reduce the plaque instability in the coronary arteries or the cerebral arteries, stabilize the plaque, and reduce the incidence of major adverse cardiovascular events before any weight loss has taken place. Let's move on to the data on tirzepatide. You know its mechanism of action very well for the reasons that I have mentioned. You have been using it a lot longer than we have. The GIP effect is interesting. It's important for diabetes, of course. What it does on food intake, the GIP component remains unclear. And what the GIP does to the heart also remains unclear. But let's move on to a summary of the SURMOUNT-1 trial, which demonstrates that the higher doses of tirzepatide will cause a weight loss of 22.5% on average at 1.4 years of treatment or so. The reason why this 22.5 that you see there in panel B, the reason why this for us is so seminal is because we have never been able to get into the territory of weight loss, which is over 20% with our pharmacological treatments. This is a territory that for many decades only the sleeve gastrectomy and the gastric bypass have been able to achieve. But now we have managed to cross this important threshold. Let's talk about some of the hard outcomes that I was mentioning earlier on. This is the effect of tirzepatide on sleep apnea. Very common, very undiagnosed conditions, predominantly in men. And here what you see is that in this trial where people with sleep apnea were randomized to tirzepatide versus placebo, in one of the trials, they were using CPAP. In the other trial, they were not using CPAP, but that doesn't make a big difference in the results. In both trials, you will see that starting from a baseline apnea-hypopnea index of 50, which is very, very high. Remember, normal is over 30. Normal is below 30, or at least moderate and mild is below 30. Severe is over 30. You will see that the reduction in the apnea-hypopnea index is approximately 50%. So people are ending up with a new apnea-hypopnea index of around 30, or 25. So these are major reductions in this complication of obesity, and they appear to be very much weight loss dependent, as opposed to these cardiovascular ones that I showed you earlier on that are less weight loss dependent. Remember that I showed you some data on semaglutide and preserved heart failure with preserved ejection fraction. Here are the same data with tirzepatide, but even harder. Why? Because here in this trial, it wasn't only the Kansas questionnaire that was measured as an important outcome, but also we have got the incidence of heart failure events, so a combination of death from cardiovascular causes or a worsening of heart failure events. You'll see that there. And you are seeing a very significant reduction with tirzepatide, which is approximately 40% reduction in the primary outcome in the course of 2.5 years, in addition to improvements in the Kansas questionnaire. So really life-changing data for people with obesity and this serious complication. And finally, in terms of the liver disease, this is a phase 2 study of tirzepatide in people with metabolic associated steatohepatitis. And what you will see on panel A is a dose response curve. There is a correlation between the doses of tirzepatide, the weight loss from tirzepatide, and the resolution of MASH, which at the highest doses reaches a 62% over on the 15 milligram dose. So we are seeing that weight loss, glycemic improvements translate to this dose response curve in fatty liver disease, which doesn't surprise us, but it is obviously very beneficial. And this is what's happening at the moment in terms of development. You may already be taking part in some of these trials of medications like cagrilintide and semaglutide, oral semaglutide, oral orforglipron, which is a small molecule, but also retatrutide, which is probably going to be the next big blockbuster when it comes out in the next, hopefully, 24 months or so. I said yesterday that this myth that these drugs are new is just a myth. We have been using perhaps not the same molecules, but the family of these molecules for the last 18 years to treat diabetes. We have now changed the indications and building up on the variety of molecules that we have. But remember, these molecules come from the same family. And we have got many millions of years of patient years experience using them. So they are not new. We know very well about the gastrointestinal side effects, and we know that according to the trials, at least up to 10% of people will discontinue them because the side effects are so severe. Maybe in real life, that percentage is higher. It may reach 15 to 20%. And we need to do everything possible to try and hold our patients' hands, certainly in the early stages of treatment, so that they are able to get over that and hopefully benefit from all the fantastic effects these drugs have. And this is this timeline of most of those side effects. This is an example from liraglutide. Well, you see that this nausea peaks in the first few weeks after treatment, and then there is a dramatic decrease after 18 weeks of care. So most of the side effects will be dissipating over the course of the treatment. I would like to draw your attention to some of the issues that have attracted publicity, and I keep getting asked about them. I wanted to clarify that these GLP-1 based medications do not cause any form of cancer in humans. Zero cancer. They don't even cause medullary thyroid cancer. They are contraindicated in medullary thyroid cancer, but they don't even cause it in the human trials. They don't cause pancreatic cancer. In fact, we're now considering using them to prevent cancer in those that are at high risk. Pulmonary aspiration, when people are having a general anesthetic or sedation for colonoscopies, etc., is rare. It has been reported. It is very rare, but it also makes us puts us in a position where we can do something to prevent it from happening. So first of all, it's a good idea to inform the anesthetist because they can change the way that they do their anesthetic preparation. And my personal approach is to stop these medications for 2 weeks before the person has a procedure. Now, you're going to tell me based on the 5-week half-life, I need to do it for 5 weeks. Well, I'm a little bit reluctant to do that, even though it is pharmacologically the right thing to do. I'm now doing 2, and I haven't had any major issues so far. different organizations around the world make different recommendations. Diabetic retinopathy, again, very, very uncommon. Observed, but very uncommon. And it happens because we drop our people's sugars too fast, purely because our treatments are so effective. So my recommendation when it comes to people that you are worried about with diabetic retinopathy is still use the drugs, but titrate the dose more slowly so that the glycemic reductions are more gradual and you don't get this paradoxical deterioration in retinopathy. If this is the only choice that you have in terms of improving glycemia, don't delay it. Use it, because in the long term, it is going to be good for the eyes. Non-arteritic anterior ischemic optic neuropathy. I had no clue what this was before it became news, so I had to educate myself. And it is not very dissimilar to some of the vascular changes that take place with diabetic retinopathy and with the changes in glucose to the eyes. But there is some mentioning, there is some link that has been made between these medications and this entity. I can say to you that the link between those two has not been conclusively proven yet. It is a potential theoretical link that may be either a statistical anomaly or because of the choice of people treated in those studies, or it might be true. So what I would say to now is I'm keeping an open mind about this potential complication. If people that I look after develop weird eye symptoms, I get them assessed, and we will learn over the next few years as to whether this is something we need to worry about or not. But even if it is true, it is again extremely rare. And finally, psychological complications. So far, in all of the trials for obesity, including for bariatric surgery or pharmacotherapy, we are seeing improvements in quality of life, improvements in indices of mental health, reductions in the rates of suicide. So as a group, when you're looking at the thousands of patients in the trials that are taking these medications, the results are positive. However, there will always be a small proportion of people who take these medications, and because for those small number of people, they remove food as an event which is an event in their day, which is distressing, smoothing, soothing, and pleasurable. Some people may react badly to that, and some people may develop some complications in terms of their mental health because of this removal of food from their lives. But the good news, unlike bariatric surgery, is that if you detect that in a patient that you're looking after who's taking the medication, you can either reduce the dose or discontinue the medication and then avoid the risk of deterioration. That's the beauty of medications. There is so much flexibility. So I will finish off by saying that in addition to everything that you do to prevent obesity getting worse in the future generations, I think we have a duty to treat it in those that have got the disease, and biological treatment in the forms of medications or bariatric surgery are now very, very effective. We finally have got safety in our pharmacotherapy, and that's why the landscape is changing very rapidly in a good way. These medications are not for people who want to wear a dress when they go to a wedding. These medications are for people who have obesity and its serious complications. They are not there to improve cosmesis. They are there to actually make people live healthier and longer lives. The long-term safety of the new medication needs to be confirmed, but I very much doubt that we're going to detect something that we did not know before. And as we talked about yesterday, their weakness at the moment is their cost, but even that, with time, will come down, and these medications will be more accessible to many more millions of people. This is my email if you want to communicate with me directly for any comments or questions, and really thank you for your patience.
Thank you very much. We have 10 minutes of Q&A so that we can cover, the major issues. Please, if you have a question, make it brief question because of the time. And I ask the speakers as well to have brief answers. So go to the microphone, please. And if you already have the microphone, go ahead, Dr. Bashir.
Thank you so much for the talk. I have a question. These GLP-1 agonists are working fantastic, but if you look at the data from the recent data on the retention rate of these agents, it's very low. So type 2 diabetes, retention rate is about 55%. Obesity is less than 40%. So we're talking about 35% retention rates. Why do you think that's it? And I have another question. There has been recent data showing combination of small dose of semaglutide, even 0.25 milligrams or 0.5 milligrams, with incorporated in a program with weight, with diet and exercise, can achieve the same weight loss with a higher doses of semaglutide with a better retention rate. So can you comment on this?
You want to come here?
Yes. So the retention rates are very disappointing. And we discussed that yesterday in the session where we were comparing these treatments with bariatric surgery. And in obesity, the reason why we're making this mistake and having those rates is because the people who look after a lot of those patients don't always tell them very clearly from the start that this is a treatment for life. I was saying again yesterday, that is the first thing I say to my patients when I treat them. And if they tell me that from very practical reasons that I can fully understand, they cannot afford the medication long term, which is a terrible thing to happen, but it does happen often, then I don't even start the medication. I refuse to start it. I only start the medication to people who know they are going to use this medication for life or these medications for life. So I think it has been our messaging that has been the problem. And that's why we're seeing the same, we're seeing the results that you're referring to, the 40 and 50% dropout. We don't see similar dropout rates for drugs for diabetes or dyslipidemia. And that is because the messaging is very different. With regards to the second question, I think you're referring to a specific study. I'm not exactly sure about the details and if I'm going to answer your question correctly, but I think you said that you can use small doses of a GLP-1 receptor treatment as opposed to higher doses for maintenance, right? I don't know if that's what we are discussing. There is some. Or in any case, I will answer the question in the way that I would like us to think, which is that it seems that when someone has lost weight, even lower doses of the same medication, because of the lower volume of distribution, may have the same effects as the higher doses had previously. So that provides at least some physiological rationale for reducing the doses, improving the cost, etc. I think time will tell whether that is a robust observation, and then if it is, then we can start considering that as an option. At the moment, I'm not doing that. I'm trying to stick to the dose that does the job, because I fear that if you decrease the dose, you will end up with some weight regain. I don't know what my colleagues do.
So thank you. A really insightful couple of questions. Just to tag on to Alex, remember that the studies that showed compliance had a period where drug supply was an issue. Costing still is a big issue. A lot of the self-funding, particularly for obesity, the self-funding is a big issue. Like Alex says, what we say to patients is the only thing worse than obesity is sarcopenic obesity. So intermittent treatment does that, just that. You lose 70% fat, 30% muscle, you regain 100% fat. And then you do that again in cycles and you run into trouble. So we say that very clearly at the outset, and that encourages patients, and certainly our retention is much, much better than 50%. Going to the microdosing, I think that's the study that was published yesterday or the day before. And there are many studies like that with small numbers that want to push lifestyle. Now, lifestyle is a cornerstone of management. Nothing can be done without lifestyle. And the example I give, and I'm sorry for anyone who has heard it before, is if you have a Ferrari, you can drive at 200. If you have a Corolla and you drive at 200, you're likely to die. And therefore, you service your car, you drive at 100. That is lifestyle in obesity management. No one's going to take that away. However, we've had lifestyle for hundreds of years, and people suffer with obesity. It is a biological disease. And I think some people will need small doses, and we see this, 0.25, 50 kilograms weight loss in 1 year. And some people will need more. And the more we understand about the biology, the more we'll be able to figure out who needs the lower doses. But I don't think it's just about lifestyle.
Can we change tactics and ask Dr. Summer an important question regarding MODY? Most of the data of MODY are from Western societies. What can we do to get national register or national prevalence or even regional prevalence of MODY? Because it makes a huge difference for a young person to go on insulin versus oral medication, sulfonylurea.
Yes, thank you. Well, first of all, I think awareness about the clinical criteria of MODY in order to select more cases of MODY to be tested, and probably maybe funding programs to cover the screening of antibodies just to make sure that these candidates are should be tested genetically, and practicing the MODY calculators, the probability calculators, and making this awareness on the physicians would help, reporting more cases of MODY among our populations, our regional populations, maybe, yes.
Okay, thank you. Final quick question and quick answer, please.
Sorry, can I add one more thing onto that? I'm stepping out of line and wearing my genetics hat. Any patient diagnosed with diabetes below the age of 1 should have genetic testing.
Yes.
Well, thank you. My question.
Quick question, please, and quick answers from the speakers.
So the GLP-1 agonist based treatment effect on cardiovascular and pulmonary complications, were they independent of the weight loss?
So the improvements in sleep apnea, which is very much a mechanical, actually, complication of obesity because of narrowing of the airways, is completely dependent and dose dependent on weight loss. What we were surprised to see in the SELECT trial is that there was no dependence, there was no correlation with weight loss. And you actually saw the effects very early before weight loss became an actual reality for those people, suggesting that the hormone itself has got anti-atherogenic properties.
Final comment, Dr. Amin?
It's actually a question to Dr. Summer. You have addressed underperformance in screening for genetic diabetes. We got 2 patients in our pediatric endocrinology department. We were discussing those cases last week. Non-type 1 diabetes with profound history of diabetes in the family, screened for Moody and proven to be Moody positive. Would that change the management in future? And have you encountered such cases before?
Yes, of course, it will change a lot in the management. As I mentioned, genetic testing and identifying Moody patients, you can change the management, sparing families from insulin dosing every day and switching to sulfonylurea, GLP-1. So genetic does play a big role on the management of monogenic diabetes in pediatrics. Also in the neonatal diabetes, the KCNJ11 and the ABCC8 are known to have response to sulfonylurea. So genetically identifying these patients would help a lot in the management of these cases.
Can I ask Dr. Noor to close the session, please? I'm sorry for many friends are having their hands up for more questions. The speakers are around for further questions.
So I would like to thank everybody for attending and for our speaker and the discussion. And due to the time, we'll come to the close. Thank you very much. Thank you.
And now, please stay tuned. There is the symposium for Abbott will be presented by Dr. Raya Al-Mazroui. Dr. Raya is the head of endocrinology department in Tawam Hospital, and she will present the evolving role of CGMS in diabetes management and the CMS quality standards.
Assalamu alaikum, good afternoon. Hopefully it will be a quick presentation, inshallah, and the focus for this presentation will be on the CGM quality standard. So to start with, these are the outlines of the talk. There we will discuss the evolution of the CGM in diabetes management and why accuracy matters, and then we'll go over the key performance metrics, regulatory framework, and then the IFCC comparator standards before we conclude. So currently, these are the varying techniques that exist to measure glycemic control. That includes self-monitoring of blood glucose, hemoglobin A1C, and CGM. And these methods utilize different samples, and they have different frequency and cover time range differently. However, CGM is the only one that can assess and measure glycemic variability. By now, all of us know that hemoglobin A1C itself is not enough, because behind the same level of hemoglobin A1C, there could be different stories and different glycemic variabilities. CGM already have transformed diabetes care, replacing capillary blood glucose measurement as the main method of monitoring glucose. And there is a plethora of study across different types of diabetes, where already we have a solid outcome on mostly surrogate markers like reduction in hemoglobin A1C, increased time and range, and reduction in hypoglycemia. So the use of CGM has expands beyond only a glycemic management and dosage of insulin adjustment, but it has been also studied in different scenarios like lifestyle modification, early diagnosis, as well as utilized in clinical research. And therefore, with all this advantage of CGM, there have been a huge plethora and proliferation of CGM devices. And now, day by day, we are encountering more CGM devices around us. And therefore, it's important to understand the standard and the accuracy of CGM. And this is because CGM accuracy directly affects insulin dosing and patient safety. Inaccurate readings can lead basically to missed hypoglycemic episodes, to incorrect insulin adjustment, to patient distrust and reduced adherence. So accuracy itself is not just insulin dosing, but it is safety and patient trust. So in order for a CGM to get into the market, they have to get an approval body. And the approval body that exists so far, which are widely adopted in many countries, including UAE, is either FDA or CE market. Now, there is a key differences between these two bodies. The FDA had approved CGM based on specific CGM safety and efficacy. It has clear defined accuracy performance metrics, and each and every one of these criteria must be fit in order for the device to be cleared. So far, at this point, CE market requires the approval for CGM through compliance to general safety and performance requirement, and they don't have defined performance metrics for CGM, but it is coming. So basically, CE market has already performance metrics for other devices like pacemaker, glucometer, insulin pump. The only thing they are lacking at this point is for CGM, and it will happen soon. So before we start deep into the standard of CGM quality, I just need to clarify the difference between adjunctive and non-adjunctive CGM. So the adjunctive CGM basically are the one that requires finger prick. It requires SMBG confirmation before insulin dosing or adjustment, while the non-adjunctive CGM is the one that is approved for insulin dosing decisions without additional SMBG. And therefore, only non-adjunctive CGM devices can be used or utilized or integrated into sensor-augmented insulin pumps or hyperloop closed system. The FDA based their definition of non-adjunctive CGM on these criteria, where it is indicated to replace information obtained from standard blood glucose measurement. It is intended to determine glucose level and direction and used for decision of insulin adjustment, as well as use the historical glucose information. In order for CGM to get the approval for non-adjunctive, it has to come with certain criteria, including accuracy study. And this accuracy study has to reflect a robust clinical data, which represent the performance across target population. And here are the key criteria. One of them is that the published data needs to be either reviewed or published in a peer-reviewed journal, or it has to be reviewed by a recognized body. So it is not necessarily to be a peer-reviewed, but to be recognized and reviewed by a recognized body like FDA, CDRH. And this is to ensure scientific validity. More than 70% of the included patient needs to be type 1 participant, because mostly they are the one who will use insulin, and will be a reflection of the real world conditions. Also, the device need to be tested during post-meal and insulin-induced glucose fluctuation, and therefore in the study there have to be meal and insulin challenges. Also, accuracy need to be validated during hypoglycemia and hyperglycemia, and therefore more than 8% of the readings needs to be in the range of hypoglycemia below 70 milligram, and more than 5% of the readings needs to be in the hyperglycemic range of more than 300 milligram per deciliter. Now, apart from that, the clinical data should demonstrate the accuracy across the intended use population. So type 1, type 2, pregnancy, or others with comorbidity. And the reference comparator lab or measurement has to be through FDA accepted laboratory-based glucose measurement. And as well, the accuracy needs to be assessed throughout the measuring range and throughout the sensor wear period. These are the metrics that are FDA approved or used, and I will not go into details. However, I will give you example. For example, in the setting or the requirement for hypoglycemia below 70 milligram. The first criteria, more than 85% of CGM readings should be within 15 milligram per deciliter from the reference range. The second criteria, that more than 98% of the CGM reading has to be within the 40 milligram per deciliter of the reference comparator. And all these criteria does not only cover different glycemic range, but also include the rate of change accuracy. So for example, the change reading, if it is less than 1% of the readings indicate rising more than 1 milligram per deciliter per minute, when a true, it should be less than 1% of the readings when the true change is less than minus 2 milligram. Additionally, there are certain things that are critical and should be approved before as part of the criteria, which is no critical mismatch. For example, no CGM reading below 70 milligram when the reference is above 180 milligram per deciliter. So in order to achieve these metrics performance, we have just to define precision and accuracy. And when we speak specifically about the CGM, accuracy means how close the CGM readings are to the plasma glucose or to the reference. And this is a reflection of the analytical, clinical, and the trend accuracy. When we speak about precision, it is the consistency of readings between sensor or repeated measure. These are the different CGM accuracy metrics that you need to be aware of. Most of us, we know about MARD, but MARD does not tell the whole story. So MARD basically is defined as the average percentage deviation from the reference glucose. And this is the purpose of it is overall analytical accuracy. When we speak about other metrics like 20-20, 15-15, 10-10 agreement, or 40-40 agreement, these are the percentage of readings within a limit or a percentage limit from the reference comparator. And this is a reflection of precision. While error grid analysis categorize the readings into different clinical risk zone, and the aim for it is a clinical safety of error. A trend accuracy will assist the sensor response speed, and the lag time is important and critical for detecting hypoglycemia. So from all these metrics, you could divide them into two. One that affect the analytical accuracy, and this tell you the numerical closeness of the CGM readings to the lab comparator reference, like MARD and the 2020 metrics or whatever, and the clinical accuracy, which evaluate the safety of those errors in real-world care, like the error grid zone. So you need both because they are complementary. One shows you how close you are to the real reading, and one show you how it is safe. So with the plethora of CGM, most of the CGM now have excellent MARD, and actually the clearance of DA for MARD to be non-adjunctive, the MARD has to be less than 10%. However, the race for lowest MARD, I can say it's over, because MARD is affected by different things, and most of the current CGM will come with you with excellent MARD below 10. What we need at this stage is a standardization of the CGM, evidence of a clinical outcome benefit, sustainability, and equal access. Let me give you some example of limitation of MARD. MARD is affected by different variables. One of them is the study protocol variability. So different glucose distribution, for example, different proportion of hypoglycemia or hyperglycemia, rate of change, sensor wear duration can all affect the MARD. And therefore, you cannot come up with a sensor with excellent MARD, and most of your patients are type 2 patients. This is the reason why we need mostly type 1 patient to be included in this study. Sensor age and calibration. Early and late sensor performance typically show higher MARD compared to the rest of the period. A reference system error. That's why we need standardization of the reference comparator and data point count. For example, in this figure, the more data point count paired between sensor and the reference, the lower is the MARD. The less number of count, the higher the MARD. So you could see that MARD by itself have lots of variables that can affect the result. Additionally, MARD is affected by the rate of change. For example, you have here system A and system B. If you look in the middle of the chart, rate of change is low. So low rate of change, you could see that both the accuracy of system A and B are very close to each other. But when you go both to the extreme left and right, when the rate of change is higher, then you can see that the MARD is completely different between the system, and you could pick that the superiority of accuracy of system B over system A. Let's move now to the error grid analysis. As I said, this system categorized bird sensor reference reading into zones. We have different zones, A, B, C, and D. And A is basically the zone A clinically accurate and safe for decision. What zone B means, this is still benign, safe deviation. When it comes to zone C to E, there is a risk of incorrect treatment, overdosing or underdosing. What we need is that more than 95% of the readings to be in zone A and B, and would be clinically acceptable safety threshold. Here is a simulation test. These are two systems, simulation A and simulation B. And the first figure, the MARD of this CGM is 8. However, you could see the distribution of the bird sensor and reference range readings. Actually, most of them, if you go down to A and B, you could see that most of the readings, around 97%, are within A and B. So it achieved the target of more than 95. However, look to the other chart. The other chart looks fantastic and will bird readings. Actually, more 100% of the readings are within zone A and B. However, the MARD of the second system is a 12. So if you go only by MARD, you will underestimate the second or the second system. And therefore, we need to incorporate, as I mentioned, both of these metrics together. Other metrics that maybe you need to be aware of is, for example, a 20/20 accuracy metric. And what does this mean? It means it is a clinically meaningful measure, indicate how close CGM reading are to the true glucose reading. A 20/20 metrics means, for example, if the CGM reading below 5.5 millimole, then reference, it has to be within plus minus 1.1 millimole. So if CGM reading is 4.5, the true reading needs to be between 3.4 to 5.6. If the CGM reading is above 5.5, the reference, it has to be within 20% of the CGM value. So if CGM reading is 10 millimole, then the true reading needs to be between 8 and 12. And similarly, it applies to the other percentage of accuracy. So the 20/20 is tight metric. It reflects on insulin safety. 40/40 is a broader metric. It identifies risk range for dosing error. So CA market already are recognizing the importance of having performance metrics. And there is these authors here came up with a suggestion with minimal expectation for core criteria for any CGM that will seek CE approval in Europe in order to get the designation of eCGM compliance status. And basically here, as you can see in the figure, these criteria are quite similar to the criteria by the FDA, where it clearly identified the type of the study, the number of the patients, the type of population, the importance of accuracy, rapidity of change, meal, and insulin challenge test. And they come up with this minimum accuracy requirement, which, as I said, is quite similar to the FDA. And you can see that, for example, for glucose range below 70, they suggest that acceptance should be within 50 milligram with a required of more than 85% of the readings to be so. They suggest that adult patient at least to be 100 subject, more than 12 paired readings, and children more around 4,000 paired readings, and the performance between pediatric and adults had to be concordant. On top of that, the International Federation of Clinical Chemistry already came up with the recommendation of the reference comparator, which also has been endorsed by the authors in the previous publication for the European CGM standard. So at this point, many studies will utilize the comparator reference, either capillary, venous, or arterialized venous blood. Arterialized venous blood is basically venous blood, but before withdrawing, they warm up the hand or the arm, so increasing the blood flow. And there is a slight differences between these, around 5 to 10% physiological difference. When you have different comparator, it is unfair to compare the sensors together because the comparator reference is different. And therefore, the IFCC recommendation is to use capillary blood glucose as the preferred comparator, with matrix criteria, duplicate samples required, at least 14 days data, and to perform bias correction. And therefore, CGM accuracy must be verified against a standardized comparator method to ensure reliable and comparable device performance. With that, I hope that I give you a clue about the CGM standards, because CGM has redefined the glucose monitoring and insulin safety. Accuracy and transparency are central to patient trust. ECGM will come and will harmonize the European standards with the FDA rigor, and the standardized comparator method will ensure fair evaluations between the sensor, and then the future focus will be reliability, interoperability, and the patient confidence. With that, I conclude my presentation. Thank you for listening. Any question? So as you know, for example, here we rely on FDA approval or CE market approval. What any CGM or any device will come in the future, I think they have, once the European CGM performance criteria implemented, will be fine. However, at this point, they have to provide the data. It is not necessarily to be published and to be provided to the regulatory bodies. So regulatory bodies that will give the clearance are the one who will review this data. It is not necessarily for the clinician. For the CGM device to be released, it has to be cleared by the regulatory data based on the submitted data from the manufacturer. Yes.
Dr. Khalid, can I go first?
Dr. Huda, yes, please.
Thank you, Dr. Araya. Fantastic presentation and very important topic as well. My question is related to the use of CGMS during pregnancy, where we really need to have a tight control over the weeks of gestation. Although some of the available CGMS systems have been approved during pregnancy, still the variability between the recorded readings and the capillary is quite significant. Do you expect that we should have a pregnancy-specific tools rather than one fits all? And what would be a criterion to actually accommodate one of those tools during pregnancy? What is the most important feature in a CGM that needs to be incorporated in the digit?
This is very excellent question. I do agree that performance criteria across different types have to be fit, not one size fits all. I'm not sure if any of the regulatory bodies is working on this. And if you ask me regarding the precision is very important in a pregnancy. Among these metrics, as I told you, it is not only one metric that we need to depend on. It's collectively all are needed together. However, the criteria, I do agree with you, different population have to be different. Maybe it will come one day, I think. There is a question, Dr. Khalid first, and then you.
Thank you, Dr. Raya. Just quick question. Now, there is a new metric also introduced, the glycemia risk index, I think, where you focus mostly on the very low readings and also the very high readings. Is this something that could be incorporated on these CGM devices where we look into this as well?
Yeah. I'm not sure of Saraha. I don't know.
Yeah.
Excuse me. Thank you very much for this insight. Actually, my question is related to the pregnancy also. Not related to pregnancy, I mean, in the same area. Do you have any experience in using the CGMS during DKA management instead of breaking the child or the patient every hour or every 2 hours, instead of that using the non-adjunctive CGMS?
During DKA?
Yes.
I don't have any experience. No. Any other questions? Yeah, please.
A normal person, it's becoming more important also, or as important. Okay, but the problem with it is the price. The price is really expensive. Every month you need about 500 dirham, something like this, which is really very expensive. I gather in other areas of the world is much cheaper. Do you have an idea?
Yeah. So this is what I conclude with. Now, there will be more CGM in the market. There will be more and more as well. When we attend the last EASD, there was at least 7 CGM. CGM will replace SMBG, but the most important thing is that we don't want to lead to distrust of the patients on the system. And the only way you don't distrust them is by accuracy standard. At the end, the prices of CGM will come down. And my own opinion that most of the CGM will pass the performance criteria. It needs rigorous improvement. All the available non-adjunctive CGM approved for integration start with the lowest accuracy, and then they develop over time. So it is like other like medications. It will come expensive initially. When there will be more proliferation, there will be lower prices, but we need to keep the standard in order not to lose patient trust. So it will come one day. Thank you so much. We need to conclude and enjoy your lunch. Thank you.
Assalamu alaikum. I know it's difficult to start a session immediately after the lunch break. However, we need to continue, and we have 3 more interesting talks, and we have an authority in that field. My name is Adil Ma'mari, and I came from Oman, and with that, I am happy to chair this meeting with Dr. Mashoud Sadiq from Qatar and Dr. Ahmed Hassoun from Dubai. Without further ado, we'll start our first session, and that will be Professor Petros Peros. And Professor Petros Peros was introduced yesterday. He is honorary consultant at the Victoria Royal Infirmary in Newcastle. Dr. Peros is an authority in the field of diabetes endocrinology, mainly thyroid disease, and his name is attached with thyroid with the pregnancy. He attains so many several posts in leading posts in Europe and the UK, and his interest mainly in his clinical and research interest in autoimmune thyroid disease, thyroid cancer, and thyroid eye disease. And today he will talk to you about the latest in hypothyroidism management. And in addition to that, he's a friend because we trained in the same place in Glasgow. So I am welcoming a friend to this auditorium, Professor Petros Peros.
Thank you very much, Ali. Ladies and gentlemen, it's a great pleasure to be here. I'd like to thank the organizers very much, particularly Tariq Al-Had, for inviting me. Both a pleasure and a real honor to be here with you. So I've outlined here some of the common questions that I think many of us face in our clinical practice that are addressed to us from our patients and sometimes from our colleagues. And I'll try to just touch upon these. And the first is about selenium in relation to Hashimoto's thyroiditis. Closer, yeah. So selenium and Hashimoto's thyroiditis is the first question. I'm sorry about the echo. And you will all know, of course, that this is an important micronutrient in the terms of thyroid economy. It's important in the conversion of T4 to the active hormone T3 by deiodinases. And we already know that if you load people up with selenium, TPO antibodies go down. And certainly in the West, in social media, this is very heavily promoted as a supplement for people with thyroid diseases. And it's not so much a question amongst the social media about whether somebody should be on it or not, but it's about how much. And interestingly, European thyroid experts have been asked about what they do with selenium in a survey, and 2/3 said they use it regularly for benign thyroid diseases. And what's even more interesting is that nearly 70% said they used it in order to bring the TPO antibodies down, as if this was an important goal. Anyway, we have an answer about selenium in the form of a recent study that was published from Scandinavia. And I'll tell you just a little bit about it. It was a very well conducted, double-blind, randomized control trial. Large numbers of patients with Hashimoto's who were receiving thyroxine treatment. And the primary endpoint was to see if selenium made a difference to quality of life. And the first thing to say is that following the initiation of the trial and towards the end, indeed, selenium did bring TPO antibodies down compared to controls, as we knew this would happen. But when they looked at quality of life, so quality of life of patients with Hashimoto's before treatment was poorer than the background normal population. Quality of life improved both in the selenium and the placebo group to the same extent, but still remained worse than the background population. So, is this something worth taking notice of? Well, I think yes, because I think it is now fairly clear there's no justification of wasting money or effort on selenium supplements in Hashimoto's unless you live in an area in the world which is severely selenium deficient. Another common question relates to subclinical hypothyroidism, whether we treat it or not. And much of this debate is focused about symptomatic people with subclinical hypothyroidism. Certainly in the West, and I think throughout the world, is the commonest indication for levothyroxine treatment. Something like 80% of patients on levothyroxine are on it because of subclinical hypothyroidism. And the latest guideline on this comes from NICE, and it states really what we already knew. If you have advanced subclinical hypothyroidism with a TSH that's greater than 10, there is reasonable evidence that such patients benefit in terms of symptoms. But if you are in the category where most patients with clinical hypothyroidism lie, that is a slightly raised TSH, then NICE tells us, well, first of all, you check it again, because very often this slight abnormality improves with time. But then if it is persistent, it says, consider treating it if your patient is less than 65. And if they're symptomatic, then this is an indication for treatment. And interestingly, the NICE guideline cites a meta-analysis for basing this recommendation on and their own expert opinion. The trouble is that the meta-analysis they cited has found that treatment of subclinical hypothyroidism makes no difference to symptoms. And in fact, the recommendation from meta-analysis is not to treat. So it all really clinches on how symptoms relate to this subtle biochemical abnormality. And one interesting insight into this has come again from Scandinavia, the connection that is between subclinical hypothyroidism and symptoms. And this is a really worthy study of mentioning, because it was a very large-scale study, a community-based study. So patients, the participants were not selected particularly. They excluded people with known thyroid disease, and they identified a reasonable number of people with subclinical hypothyroidism, and they had plentiful controls. And the bottom line is that if you compare this group of patients with untreated subclinical hypothyroidism to the background population in an unselected way, then you find there's no difference in symptomatology between the two groups. So how does this bit of information influence our attitude to this? Well, the way that I interpret it is that when you are faced with patients who are symptomatic and they present subclinical hypothyroidism, then you need to think that this is more than likely that the source of the symptoms is something other than the subclinical hypothyroidism, and one really needs to look for other causes. In this group of patients, treatment is very unlikely to be helpful other than the placebo effect. And I think very often such patients come to our clinics loaded with lots of expectations for our intervention, and that is something that one needs to manage. And one has to remember that the moment you commit somebody to long-term treatment with levothyroxine, there is always a risk of overtreatment. So let me move to another question that, again, patients increasingly ask, and that is, with Hashimoto's, should they have a thyroidectomy? So the background to this is that a reasonable percentage of people with hypothyroidism who are on levothyroxine and achieve normal biochemistry still complain of symptoms. And one of the plausible explanations for this is that maybe this has nothing to do with the biochemical levels of thyroid hormones, but maybe it has to do with the fact in Hashimoto's, the fact that there is an underlying autoimmune process, and the inflammation from that may be driving these symptoms. So the hypothesis, therefore, has been put forward that if you can deal with the autoimmune process, maybe patients will feel better. And one way of achieving that is to remove the antigen. And so, again, this comes from Scandinavia. It's a study that looked at total thyroidectomy in patients with Hashimoto's who were symptomatic. So this is not a thyroidectomy to address a goiter. This is to address symptoms. So they had a reasonable number of patients that were randomized to either having thyroidectomy or not. And the endpoint was quality of life after a period of 18 months. So the first thing to say is that doing a total thyroidectomy is probably the most effective way of reducing TPO antibodies if somebody wants to do that. And certainly patients in this particular group had very precipitous decline in TPO antibodies. When they looked at quality of life, and the vertical axis, the higher up you go, the better the quality of life, the group that were treated with thyroidectomy felt better, whilst those that weren't treated continued to be miserable. But of course, there's a downside. You intervene with something as drastic as a total thyroidectomy, there is a price to be paid. So what does that mean? How does that influence our practice? And the first thing to say is just to highlight that this was not a placebo-controlled trial. Now, it's understandable to do a placebo-controlled trial with surgical treatments is a really huge undertaking, not easy. But let's not dismiss the power of placebo. I'd just like to remind you, this is data from one of the largest randomized controlled trials of combination treatment with T3 versus levothyroxine alone. And the quality of life is in the vertical axis here, but it goes in the opposite direction. So the lower the score, the better the quality of life. And this shows that in this randomized controlled trial, there was a very rapid and impressive improvement in quality of life in both groups, which was sustained for 12 months at least. So in my view, the evidence is really insufficient to subject these individuals to such a drastic treatment. Another thing that's been talked about an awful lot amongst some patient groups is the issue of deiodinase polymorphisms and how that influences the symptoms and response to treatment for hypothyroidism. And just a bit of background to that, the thyroxine, of course, is a relatively inactive hormone, has to be converted to T3, and the key enzymes are deiodinases 1 and 2. And there are certain relatively common polymorphisms of these enzymes. Now, if these polymorphisms affect the activity of the enzymes, then you can imagine that may have clinical consequences. And maybe that is what is underlying the persistent symptoms that some of these patients experience. Now, the diagnostics industry has been very quick to respond to this. And in the UK, anybody out in the street, anybody can do a buccal smear, put it in the post, and have a result of the deiodinase polymorphisms for a mere 3-figure price. So what does this mean? Well, there are now several studies that have looked and to see whether having these deiodinase polymorphisms makes any difference to serum levels of T3. And the bottom line is that there's no consistent evidence of a biological effect. But the more interesting evidence of this comes from a very large study that utilized the UK Biobank. So large numbers of patients have been entered into this that have been worked up very carefully and in detail. So they were able to identify no less than almost 2,500 patients on levothyroxine for hypothyroidism that happened to have one of these polymorphisms. And they had a large number of hypothyroid patients on T4 that did not have the polymorphisms, and a huge number of euthyroid controls. So there were data about quality of life, neurocognitive assessments, and all kinds of patient-related outcomes. And the bottom line is it made no difference to whether you have symptoms or not. What about the latest on combination treatment? This has occupied, or rather I would say preoccupied, thyroid experts now for 30 decades. So the combination of T3 and T4, the latest, ladies and gentlemen, is that there is a race on. And the race is between the Iranians and the US in producing a reliable, slow-release T3 formulation. And the background to that is that the ordinary T3 that people have used in trials has a very short half-life, and you get inevitably wide fluctuations in serum T3 levels if you're on T3, which are highly unphysiological. So the proponents of combination treatments have argued that we've got the wrong formulation. We need a slow release to actually test it and see whether it works. So Iran is ahead of the game because they've produced a formulation of slow-release T3 that seems to produce steady and reasonably physiological fasting levels with a once-a-day administration. What they haven't shared with the rest of the world yet is what happens to patient-reported outcomes on this particular formulation. And so the tally now for the number of trials for combination treatment has risen to a total of 21. The latest was published just this year, and overall, there is no benefit in terms of quality of life and other parameters that have been used to assess. But hold on a moment, a recent meta-analysis has appeared from the US that is looking at this in a slightly different way. And that is, they've taken advantage of the fact that a number of these trials and combination treatment, besides using all the validated questionnaires and tools for assessing patient outcomes, also included a question on patient preference. So they asked the patients after they've experienced combination treatment or levothyroxine alone to state blindly which phase they preferred. So if you look at the data on preference, then just a little over 50% of patients seem to prefer combination treatment, and fewer have no preference or preferred levothyroxine. And the conclusion of these authors was that here, clearly, there is an important outcome we should take into account. And that outcome is in favor of combination treatment. The other side of this coin is that in our clinical practice, I think most of us, if we are tempted to offer patients the option of combination treatment, we do so for a while. Then after a period of time, we'll ask the question, do you want to continue or not? So if you look at this same question in a binary way, then the data look a little bit less impressive. This is an illustration of what I think is a fascinating phenomenon. That is the dissonance that sometimes we see between quality of life assessed by the most validated tools and other outcomes such as preference. And I think this is another paper, yet again from Scandinavia. That's where a lot of the work is done, which I think is fascinating and gives an interesting insight of what goes on in patients' minds. So this is almost like an audit. This is a center that for years now has offered the option of combination treatment to patients who are symptomatic. And they followed up 66 patients who were given combination treatment. And after several years, they looked at the outcome. So a number of them actually felt that they didn't they didn't experience any difference. And so they went back on levothyroxine. The rest, the majority, judged that they were benefiting and then carried on with combination treatment. And at this particular point, having been on this treatment for a while, the researchers asked the question, what is the quality of life for these patients? And it turns out their quality of life using the validated questionnaire was excellent. It was as good as euthyroid controls. And then they asked also whether they were symptomatic. And the same group experienced the same symptomatology as patients with untreated overt hypothyroidism. So what on earth is going on here? And I think this is just an indication that we pretend that we understand what our patients experience. And we think if you transition from euthyroidism, you develop hypothyroidism, we expect patients will become symptomatic, the quality of life will go down. And if you ask them, what do you prefer? They say, I didn't have this condition. And we believe that with treatment, we restore all these things. So if you think about these patient outcomes, symptoms, quality of life, patient preference, our model, our understanding is that these should move generally in parallel in the directions that we expect them to. In real life, in our daily practice, I would suggest that what we find is that the direction of movement is very much more unpredictable. Do the guidelines help? Well, I've extracted this particular part of the NICE guidelines, which says that if you're hypothyroid, you have persistent symptoms, then consider adjusting the dose to achieve optimal well-being. And this is really a bit of a surprise to me, because there is good evidence from two large, very well-designed, randomized controlled trials, which have found similar findings. If you fine-tune your thyroxine and you bring the TSH down to the almost suppressed level, or allow it to go up to just above the normal range, it makes absolutely no difference to symptoms or neurocognitive function or quality of life. The American Thyroid Association tells us that one of the main goals is to resolve symptoms. Now, I've already told you how difficult it is to interpret symptoms. And so, and most of the symptoms in patients, in my opinion, who are treated with hypothyroidism are unrelated to the hypothyroidism itself. So sometimes I feel a little bit utopian about the role of guidelines in this difficult clinical arena. And finally, I'd like to share just some insights from a very large survey that I was involved with. This attracted nearly 4,000 responses from patients with hypothyroidism who were treated, and the respondents came from most all over the world. 68 countries were represented. And what we were interested to find out was what was the relationship between these common patient outcomes that we were all talking about, or concerned about: symptoms, quality of life, patient preference, and dissatisfaction with treatment and care. And so the strongest associations that we found between dissatisfaction with treatment were with lack of trust in doctors, where the patient lived. So North and Western Europe were really hotspots for patient dissatisfaction. The Mediterranean, Southeast Asia were the happiest, it seemed. Having somatic symptom disorder, certain personality traits, and exposure to misinformation were all highly correlated with dissatisfaction with the treatment. And things like the type of thyroid hormone patients were being treated, whether it was T3 or T4, or the level of TSH they achieved, had little to do with these patient outcomes. So, just to sum it all up, what I would say is that the evidence now seems that selenium supplements are of very little value in hypothyroidism, unless you just happen to be in those rare parts of the world where there is severe selenium deficiency. I think the lesson here is that for us to be a little skeptical about symptomatic patients with subclinical hypothyroidism, because I think the majority of cases have symptoms not due to the subclinical hypothyroidism. I think bothering with deiodinase polymorphisms is expensive and futile. Certainly, total thyroidectomy is an interesting story, but it's far too invasive. The saga with the T3 replacement goes on, and I think we all should be aware that looking at patient outcomes is a complicated matter. We really don't understand it very well. There is no neat fit with biology, and sometimes we really struggle to interpret it. Thank you very much for your attention.
Thank you so much for a very clear presentation, Professor Petros. I'm extremely delighted to chair this session. I'm Dr. Mashoud, consultant endocrine from Hamad, Qatar. It gives me immense pleasure to introduce the next speaker, Professor Amir Babikar. He is a consultant in pediatric endocrinology at Children's King Saud bin Abdulaziz University for Health Sciences. After graduation from the UK, he is currently the lead of pediatric endocrinology and oncology service at King Abdullah Specialist Children's Hospital. He is also the head of the scientific board, and he is also the deputy chair of Endocrine Research Committee of the Arab Society of Pediatric Endocrinology and Diabetes since 2019. He has a lot of research interest, and he has also authored several chapters in textbooks. So, Professor Abubakar, the floor is all yours. He is going to talk to us on a very important topic, that is congenital adrenal hyperplasia, especially the transition from the pediatric to the adult care.
Thank you very much for the introduction, and thank you for giving me the opportunity to share this experience with you. I'll talk to you about another entity. So after you heard about the very nice talk from the professor about the thyroid that deals with the energy, level of energy, and the neurodevelopmental outcome, we're always pediatricians talking about the early part of life, the neurodevelopmental and the consequences of congenital hypothyroidism. I'll talk to you about this gland, which deals with life-saving. It deals with gender assignment, and also it deals with stress. So it's a very wide subject, actually, because I'll take you through a journey from the embryology and the real challenges with these abnormalities in this gland with regards to the embryological course, the anatomy, the physiology, the genetics, and the abnormal biochemistry, and the different options of pharmacotherapy, and also the psychosocial impact of problems with this this part of the gland, which is the zona reticularis. And we'll make it very practical, because I'm talking to adult endocrinologists. So I'll give you the relevant parts of the presentations with regards to infancy, childhood, adolescence, and I will focus on the transition of care and highlight the importance of multidisciplinary team input in this condition. I'll give you 2 slides of 2 case studies before we conclude with take-home messages. So I have to be clear with the learning objectives, as I mentioned, because we are dealing with a broad spectrum and heterogeneity of problems. So we'll try to identify the key pediatric adolescent CH presentations and the relevance to this to adult practices, and recognize the acute management and long-term monitoring of patients with CH, and also shedding light on the transition of care and multidisciplinary team input. So it's a very small gland, a classic example of endocrine glands, small with heavy blood supply and multiple functions. More than 80% of the gland is constituted by the cortex, which has got 3 layers with distinct arrangement of the cells. And the pathology in each of these zoni affects the other zones or zoni. Okay, so the production of the steroid hormones starts from 8 weeks of life, and before that is mainly dependent on the placenta. And there are different hormones here, so you need to focus with me. We are talking about the 3-beta HSD2 that starts from 8 weeks and finishes by 14 weeks. So you have a drop in the cortisol hormone production, and after that is taken over by the proper steroidogenesis pathway. Before that, the placenta has got a role through the 3-beta HSD1. And we also have some of these enzymes coming from the gonads that helps in the virilization of organs. The virilization in female fetuses with CH is typically completed by 12 weeks. So we have a limited fetal adrenal activity, starting with DHA, and this one gets sulfated in the fetal adrenal gland, and then further hydroxylated in the liver of the fetus to form the dias, the dihydroepistenedione. And we also have the placental conversion of some of these hormones into the different types of estrogen. So we have different pathways of the control of CAH, one through the ACTH, and this is underpin the strategy of treating this virilization in babies, in pregnant ladies through the prenatal dexamethasone therapy. But we also have ACTH independent mechanisms, as you heard, the contribution from the fetal liver and the placenta, and this has been evident in some studies on anencephalic fetuses. So it follows the pathway of the normal axis of hypothalamic pituitary gland axis, and it has overlapping with other hormones like the AVP, and this is named the stress gland, as I mentioned. So it has a short-term stress response and a long-term through the mineralocorticoid glucocorticoid pathway, and this is a very important part in the management of this condition. And cortisol is important for everything. So it's important in its stress coping, important in arousability, inflammation, and the metabolism. And it has these distinct peaks, actually a smaller one in the afternoon. And the mineralocorticoid function of the gland is of paramount importance, so it has relation with the vasoconstriction and the fluid retention in the body. And we have different pharmacokinetics of the steroid replacement therapies. Some of them are pure glucocorticoid therapies, and some are pure mineralocorticoid, and this is important to recognize in the course of management. So what's the CAH about? The CAH is an autosomal recessive condition that is characterized by genetic enzyme defects that leads to cortisol deficiency. So this is a unique feature in CAH. All of the CAH patients have cortisol deficiency. Some of them will have aldosterone deficiency as well, and some will have androgen excess, and some will have androgen deficiency. Most of these conditions have a classic form, which is a typical phenotype of the condition, and we have a milder form, non-classic type. So if we talk about the 21-hydroxylase deficiency, you're talking about enzyme deficiency due to genetic problem that leads to deficiency in the end products, and also accumulation of the precursors that will deviate and drive the pathway towards the open side, which will lead to accumulation of androgens that will affect the virilization of the fetus and affect the gender assignment in some conditions. The commonest is the CYP21 deficiency, or that leads to 12 or mutation that leads to 21 hydroxylase deficiency that constitutes 95% of the condition. It has a genotype-phenotype correlation, and there are key hormones here to identify the diagnosis, as I previously mentioned in the previous slide. So most of the recommendations in this talk is based on this consensus guidelines from the Endocrine Society. So what is this complex diagram or pathway of steroidogenesis? When I started in endocrinology training, it looks like London Underground to me. So it's very complex, and it needs a map. And a simplified way to look at it is possibly to focus on the cortisol. And you have this group of enzymes or pathway, starting from the cholesterol, then followed by this protein star, and then you have the side chain cleavage, and you have number of hydroxylase enzymes, 17 to 11, and ending by the cortisol. And this is apparent here, obviously. So this is in the pathway, and this pathway is sometimes confusing because in some texts it's drawn in the horizontal way and in the others in the columnar way. And you have the 17 contributing in two sides of the pathway, and you also have the 3 beta. The 3 beta is different from the others because it's not a cytochrome P450 enzyme. And we also don't forget that you have contribution from the gonads as well to the virilization. So this is a summary slide that tells you about the enzymes and the gene location and their location in the cell, as well as the function or dysfunction happens as mutations in these sites. We'll go through them one by one. So this is the first one, the 21 hydroxylase deficiency that results in cortisol and aldosterone deficiency and excess of the androgens. And we also have this rare one, which is a severe form of congenital adrenal hyperplasia. This is a lipoid form, and it has two hits, one in the star, that results in severe deficiency in all the steroidogenic hormones. And the second hit is that the accumulation of fat in the cell affect the mitochondrial function that worsens the condition. And we have this hypertension-related CAH, which is a deficiency in the 11-beta hydroxylase enzyme due to CYP B1 deficiency or mutation that's different from CYP-B2, which affects the aldosterone synthase enzyme. So we have, as a result of the CYP-B1 mutation, we have accumulation of the 11-deoxycortisol in the cortisol pathway, and we have accumulation of the 11-deoxycorticosterone, which is called DOX, in the aldosterone pathway. And we also have the 3-beta hydroxysteroid deficiency, which can result in also mineralocorticoid and glucocorticoid deficiency and maybe virilizing in girls. And it's one of the known associations with precocious puberty in girls, later recognized as one of the rare 3-beta hydroxysteroid deficiency. And it can result also, obviously, because of disturbance of the pathway of producing androgens, can result in under-virilized or masculinized boy. So this very important condition needs to be recognized earlier. Therefore, it's included in the newborn screening, and the way it's tackled through the elevated 17-hydroxyprogesterone. But this also has got some limitations because it can go high as well in prematurity and stress-related conditions. But early detection of salt losing or salt wasting is important for emergency management and also for psychosocial emergency of sex assignment. And a positive screen should urge endocrine evaluation as well as other multidisciplinary team input. So this, for example, is an emergency plan that has to be accompanying a patient all the time if this patient is vulnerable and has cortisol deficiency. So one of the limitation is that this test needs to be done in 48 hours, after 48 hours of life, because it's known that 17-hydroxyprogesterone is raised in the first 48 hours. There is some methodological limitations as well. So the mass spectrometry is better in improving specificity as well as interpreting the results in terms of ratios, also can improve the accuracy of the test. This test is not designed to pick up the non-classical type of 21, so this is one of the limitations. So if we talk about the presentation, the infants present with emergency, vomiting, poor feeding, and dehydration and hyperkalemia in the first 1 to 2 weeks of life. And that's more apparent and important in boys, but it is very clear that they do have ambiguity of genitalia and virilization in genetic females. And thus urge immediate prioritization of medical resuscitation by hydrocortisone and IV fluids, dextrose and saline, and correcting the electrolytes, and also the social emergency. So the virilization is challenging, and there are different methods of assessing this in babies. One of them is this one in the right hand corner, which is an external masculinization score invented by Professor Hughes and Faisal Ahmed, who I worked with, and Dr. Asma as well, worked with in Cambridge. And this is informative because it's very subjective and tells you in a subjective way whether this is likely to be a boy or a girl or something in the middle. So we are talking about the external genitalia, but also you have to look at the internal organs and what tubes you have inside. So ultrasound is very important besides the karyotype. So 21-hydroxylase deficiency is the commonest cause of 46XX DSD. And for males, for genetically male babies, actually is the way of presentation is not a genital abnormality, but an emergency as acute dehydration in this baby due to salt wasting. So the basal 17-hydroxyprogesterone and can be raised and sufficient, but sometimes you need to consider ACTH stimulation to make it more apparent, and you need the karyotype, the ultrasound, and you need also to look at the aldosterone axis. Genetic testing is usually confirmatory, and the treatment will not await this. So this is the different types of the classic of the 21-hydroxylase. So you have the salt wasting and the symbol virilizing as part of the classic. And then you have the non-classic. I wouldn't go through this because we talked about. For the non-classic one, is it usually of late onset, and it presents with hirsutism, acne, oligomenorrhea, and infertility, and it can mimic the PCOS in adolescence. There is also a cryptic type, which is more make it more challenging, and it needs ACTH stimulation to pick up the high 17-hydroxyprogesterone. So the hypertensive type, which is the 11 beta, it talks about, and that's usually because of accumulation of two precursors. One is the deoxycortisol that mimics cortisol and it has mineralocorticoid function, and the other is the DOX, which is the main contributor to hypertension. This form is common in the Middle East and Muslims and Jewish, and it has unique features which is not well described in literature. One of them is very advanced bone age. I have a couple of patients who have advanced bone age up to 6 to 7 years without being in true puberty. And that they may present with transient salt wasting as well, and that's due to immaturity of the kidney of the newborns and resistance to mineralocorticoids. But the classic type is hypertension with a salt loss and a virilization as in the females and isosexual precocity in boys. There is also an non-classic form. As I mentioned, most of these conditions have got a non-classic form. And it can be picked also in the newborn screening by a mildly raised 17-hydroxy, not like the 21, but the key diagnostic findings is to identify the 11-deoxycortisol and the DOX. If you have, this is not usually available in most common labs. ACTH stimulation will make a little bit of differentiation from the 21. And also an apparent feature here is that you have a suppressed low plasmabrenin activity, and obviously mutation can be picked by the genetic test. So the treatment is by glucocorticoids, which not only compensate for the cortisol deficiency, but also can help controlling hypertension because it suppresses the drive of the pathway towards aldosterone site. And to monitor these patients, you need to look carefully at the growth and the blood pressure, as well as the biochemical markers. So the 3-beta deficiency is life-threatening. It's a rare condition. You have deficiency in the glucomineralocorticoid and the sex steroids. It's all dealing with the HSD 3B2, as I mentioned before, because B1 is a placental hormone and is critical for life. Those who have mutations in this do not survive usually. And you have DSD in both. This is unique for the 3-beta. Because, and the reason for that, because in the 46XX genetic females, you have excess adrenal DHA that is transformed to testosterone by the peripheral HSD3B1 in the liver of these babies. And you also have obviously in the 46XY, you can have undervirilized male because of the interruption of the pathway. For the 17 hydroxylase, it has two contributions in the pathway, as I mentioned earlier. So it can be on both either of these sites. And in this one, you have accumulation of the mineralocorticoid part, because it's not contributing to the aldosterone pathway, but you have deficiency in the glucocorticoid side. So it somehow it mimics the 11 beta in causing hypertension, which is milder because you don't have a real blockage before the precursor. And you can also have sexual infantilism in the females, as well as undervirilization in boys. And the diagnosis of this condition is challenging, but usually with the absence of the 17-hydroxylated steroids, you can pick that, and this is usually requiring ACTH stimulation test. And a combination of elevated DOX and also failure to have impressive 17-hydroxyprogesterone going up with the ACTH stimulation is very helpful in making a diagnosis that the block is earlier than the 21. And the treatment is by glucocorticoids, which also helps the milder accumulation of DOX, and most of the time you may not need antihypertensive treatment. So if I talk about the lipoid one, which is a severe form, interestingly, in the gender side, they have preservation of the Wolvian duct but no Mullerian ducts, but they have a external female genitalia. And this internal organs is preserved just because of the early fetal testosterone effect. And the 46XX usually can proceed up to the full puberty, but they have anovulatory cycles. And that's because of steroidogenesis via the star-independent pathways. And they usually have amenorrhea, but they may have some periods through that pathway. And they need sex hormone replacement. So the clinical suspicion is in a female genitalia with 46XY, and you have classic hormonal profile and imaging supporting this, so everything is deficient, and they need lifelong glucocorticoid therapy, but that's in a physiological way. They have salt, they receive salt supplementation early, as many other CH, and the growth typically not affected because they don't have excess of androgen. The 46XY usually end up with gonadectomy because these are non-functioning gonads and with estrogen replacement, and the female genetic sex, they are infertile, but they may have some fertility assisted reproduction. So this is a rare one, the last one with the 450 oxidoreductase one, which is the opposite of the lipoid one. It's a mild one, and usually may not have, you have a little cortisol deficiency in that, and it's usually picked only by the ACTH stimulation, and it requires glucocorticoid therapy in a low dose. It can be associated with craniosynostosis, and they require some orthopedic reviews because of related abnormalities. So the management of CH in general, speaking the first 3 months, the salt losing is a medical emergency. They may present with failure to thrive and early precocity of puberty. And the investigations focuses on identifying what's going on in the internal organs as well as the karyotype beside the genetics, because you can see the external genitalia, whether it's going towards virilized or undervirilized subject. And the emergency treatment is for the electrolytes and monitoring of these, as well as the renin-aldosterone pathway, and managing dehydration, glucose, and hyperkalemia properly. In the childhood period, beside this emergency for the glucoamilylarocorticoid, early adrenarche and rapid growth is a feature, and this should be carefully recognized by serial X-ray bone age. This is a classic uncontrolled type, accelerated early growth with plateauing later in life. And in adolescence, beside the previous described problems, you have the precocious puberty, hirsutism, and acne, and irregularity in the menstrual cycle, as well as the huge psychosocial impact on this because of the body shape. And they don't really have gender identity problem. It's rather a sexual behavioral problem. And they also have the challenge of TART, which is testicular adrenal rest tumors, rarely occurs in ovaries, and this is stimulated with high ACTH, and they're usually small and needs to be picked by MRIs or ultrasound, and it requires a periodic monitoring of 1 to 2 years, and it can be as big as this. If you want to read about it, we have this publication about it, so it gives you more insight into this. So these two publications highlights also the psychosocial impact on these patients. So that the treatment priorities is to treat the adrenal insufficiency, to suppress the androgen excess and prevent virilization, and to avoid over-treatment also that can affect the growth negatively. Surgery, there is lots of debate on that, and there is no robust RCTs on it, but presumed values of seeking early surgery, it can restore dysfunction of the female genitalia to some extent and avoid social stigmatization. So it needs a careful ethical handling and multidisciplinary input. The follow-up needs to be so frequent in the first 3 months, okay, in the first 18 months, and then infrequent after that, focusing on growth velocity, blood pressure, and signs of virilization, and annual bone age, as well as avoiding metabolic syndrome because of the steroids treatment, and also annual screening for TART, and looking after the bone health. There are different therapeutic strategies and experimental approaches. I will skip this one, but I will talk about the emergence, this slide. The emerging therapies looked at different ways of giving the hydrocortisone through modified released forms, also the oral selective CRF1 antagonist, and the ACTH antagonist is in phase 2 study, very successful and promising results. It needs contribution from all people in this. The transition of care, if you allow me for a couple of slides. Okay, the adolescents can miss the follow-up and they may have poor adherence. So the transition is improve the continuity and metabolic control in these patients. It needs to start early and with a clear emergency plan and addressing the fertility, contraception, long-term cardiometabolic risks, and also coordinating referrals with other teams, focusing on the physical health, sexual health, psychosocial health, and education and transition with reasonable interval periods. So this is a study case just to highlight what I have mentioned, 11 years old. So I'll leave that one. Okay. So I'll just go through this one then, which is 19 years old. You receive this patient in your clinic after transfer. Obviously, you need to go through the transfer summary, the labs, the TART screening, the long-term plan, addressing the metabolic risk and transition to doses. So the take-home messages, this is a very heterogeneous, complex condition, needs addressing to medical and psychosocial side. It needs a multidisciplinary team input and regular monitoring for different conditions with empowering patients on how to self-manage themselves. And the structured transition is of paramount importance as well as family involvement. Thank you for listening.
Thank you very much. A very important subject for, especially for adult people that they have transitional of these cases. I think we're going to come back to our Professor Petros, who needs no more introduction except to say that he's expert in the thyroid eye disease, and he's going to talk to us about updating the management of Graves' orbitopathy.
Thank you very much. Hello again. So the part of the title is an update, and that kind of caused me a bit of a problem, the update since when. And so I went on the Gulf Association website to see whether there'd been any recent talks about thyroid eye disease. And indeed, there was one in 2023, and it happened to be me. So I'll try to pick it up from there, and I'll try to avoid repeating myself. Just some background things to remind you. It's not a very common condition. It affects women more than men, usually presents in middle age, and there's a very strong, really quite impressive association with smoking. And if we think about patients with thyroid eye disease, you will know from your own experiences that usually these are people that present at the same time with thyrotoxicosis due to Graves' disease. So the two things usually come together. But occasionally there are some exceptions. So occasionally patients will present with hypothyroidism and thyroid eye disease, and some rare cases that will present with no previous or present history of thyroid dysfunction, and yet they have the features of thyroid eye disease. And these are dynamic because sometimes people with hypothyroid thyroid eye disease become thyrotoxic, and sometimes this happens the other way around. And interestingly, those with euthyroid thyroid eye disease, if you follow them up for long enough, they usually would drift into one or the other categories. But what is really at the center of this, what is common denominator, is that all of these display evidence of thyroid autoimmunity, and particularly TSH receptor antibodies, which are the best biomarker both for Graves' and for thyroid eye disease. We now know that there is a shared antigen shared between the thyroid and the orbit, and that antigen happens to be the TSH receptor, which is expressed not only the thyroid but also on orbital fibroblasts and fat cells. So if you mount an autoimmune response to the thyroid against the TSH receptor, both in terms of autoantibodies and cellular immunity, then those are likely to affect those same antigens expressed in the orbit. So in response to this common question, why are the eyes affected in thyroid eye disease? A simple answer, this is a misidentification of the innocent bystander. That's the basis for getting thyroid eye disease. And we know quite a lot about the natural course. This is described by Rundle's curve. So if you do nothing, you just watch these patients over a period of maybe 6 months or so, they may get worse, they reach a peak, and then they start to get better again, slowly. And most of them will get better, but not quite back to normality. Except those who have mild thyroid eye disease do really well, because they usually completely resolve as long as you control the thyroid dysfunction. This is just an example of somebody presented with thyrotoxicosis due to Graves, had some mild features, and a year later she was off antithyroid drugs and the thyroid eye disease had more or less melted away. Even the more severe end of the spectrum, if you do nothing, will get better. And these are data from a variety of different sources, looking at different parameters of the disease. So with this as an introduction, I'd like to focus a little bit about what is the latest on these aspects of thyroid eye disease. And I would like to start with the pathogenesis. So I think this is the most interesting recent paper about pathogenesis that I've come across, and I will go into it a little more, but just to put the background to it, I've already told you that the TSH receptor is expressed in orbital tissues, and that is the shared antigen, but it is also in very close association with the IGF-1 receptor, not just physically, but also functionally. So these two cross-talk to each other. So although they utilize different post-receptor pathways, stimulation of one can stimulate the other and the reverse. The common denominator here seems to be beta-arrestin that mediates this cooperative function. The end result is, if you stimulate one or the other, is two events. One is that there is increased adipogenesis in the orbit, and there is secretion of hyaluronic acid. So these two events are crucial in the pathogenesis, and particularly hyaluronic acid, which is very highly hydrophilic, and it just attracts water into the orbit by osmosis. So there is an expansion in volume that raises the pressure inside the orbit, and this pushes the globe forward. And you can explain just about all the clinical features of thyroid eye disease on the basis of this simple mechanical disturbance. So you may know this, but the 2021 Nobel Prize for Physiology and Medicine was won by a Lebanese American and an American, and they got the prize because they discovered mechanoreceptors. And these are really important, not just for proprioception, but for all kinds of other functions. And they are expressed in a variety of different tissues. So many cells express them, and what stimulates mechanoreceptors is stretching or compression or so-called poking and shear forces. All of these will stimulate the mechanoreceptor. And the paper I mentioned to you, which I think is probably the most interesting one in the last year, looked for mechanoreceptors in the orbit of patients with thyroid eye disease. And the first thing they did, they showed that these are expressed in cultured orbital fibroblasts from patients with thyroid eye disease, and they're expressed quite avidly. And what they also found was that if you stimulate these receptors, you reduce adipogenesis, one of the key events in the pathogenesis of thyroid eye disease. And so here is a potential new therapeutic target for thyroid eye disease, which has never been explored before. And there are already molecules that are effective mechanoreceptor agonists. So I think we should watch this space because this obviously may lead to clinical effects on adipogenesis. The other topic I want to touch upon is about assessment. And this is really the cornerstone of how we manage these people. You have to assess them first, and then based on that, you decide on your treatment. And the first thing to say that we still really don't have a very good diagnostic definition of diagnosis. The one that is in existence is gathering cobwebs, and it's more than 30 years old. So if there are any interested young people that want to do a research project, this will be one to try and actually use modern methods of defining thyroid eye disease. But there are three really important parameters that we try to use when we assess our patients to decide on our treatment, and we use these in clinical trials as well. So quantifying how much inflammation there is, the clinical activity score, and motility. And I'm very sad to admit that these are terrible measures. The ways that we have to assess them are performing really badly with a very poor intra and inter-observer variability. It is unacceptably high. And here comes artificial intelligence. If you look at the number of publications on artificial intelligence in thyroid eye disease, there is total silence just about until the last couple of years. And suddenly there is a huge amount, as I'm sure in other areas of medicine. And what is really promising and interesting is that in a recent international thyroid meeting, a team from Shanghai in China produced some data, and they have made a device where you put your patient's face into it and it does all the rest for you. So they use a variety of different optics and techniques and artificial intelligence, and they work out proptosis and eyelid fissure, redness, and ocular motility. And the data that they presented in this meeting a few months ago was from a very large number of patients, and they claimed that the measurements were really reliable, they were reproducible, they correlated very closely with the golden standards of clinical assessments. They claimed that this was a very valuable asset for clinical practice and research. So we'll have to wait and see how this pans out in a proper peer-reviewed publication. But I think this offers some real opportunities. So we mustn't forget our surgical colleagues, and there are some surgical advances in thyroid eye disease. And our ophthalmologists have really followed the paradigm of neurosurgeons in recent years with image-assisted navigation for orbital decompression in thyroid eye disease. And this is now being used extensively. Interestingly, what happens in the surgical sphere is the techniques become widely used before the evidence appears that they're actually helpful. But we hope that this is actually helping and will lead to better results of orbital decompression. Now, there are some old tricks that are resurfacing. So I'm talking about new data on drugs that have been around for a long time, but they've been repurposed recently and used in thyroid eye disease. And there are three of these: this selenium, mycophenolate, and tocilizumab. The selenium story goes back a few years when there was a European study, a very well conducted study, placebo-controlled, which showed that, at least in this particular context, selenium seemed to help in terms of preventing the progression and settling down the eye disease in mild cases and improved quality of life. So what we've had just in the last year is an attempt to reproduce this data in South Korea. So this was a well-conducted study, large number of patients, and they broadened the scope, so they included cases not just with mild, but also moderate to severe disease. But unfortunately, selenium did not seem to do anything in this study. So maybe the explanation here is the state of selenium sufficiency in whichever geographic area you happen to be. Europe is relatively selenium deficient, South Korea is not. So there's a little bit of doubt about selenium. Another drug which has featured fairly consistently in the last few years is mycophenolate. And there are 3 randomized controlled trials that are cited extensively in the literature. The first one came from China, and it just reported absolutely spectacular results of mycophenolate. You've never seen it before. The next one was a European study which showed no efficacy. And the most recent one has come out of China again, confirming the first Chinese study. So you can take your pick, but the plot thickens because the first Chinese spectacular study has been withdrawn because the data were fake. And the third Chinese study has got considerable methodological problems. Now, moving on to tocilizumab, again, an interesting drug. It was used in a small study back in 2014, which reported spectacular results. It improved everything. It reduced exophthalmos, it reduced diplopia. Then the same group tried to repeat it with a larger study and placebo-controlled. The effects were far more modest. And just recently, again, this is not yet published, an Italian team has done what one might consider the definitive tocilizumab study, because this was a large study. It was very well conducted and compared it with steroids. What they've reported, again, this is not yet peer-reviewed, was that this was really effective, much more effective than intravenous steroids, and it did improve proptosis and diplopia and improved quality of life. So these are the old drugs, but there's a plethora of new drugs in development. And this has really been triggered very much by the appearance of teprotumumab, which appeared in the American market 5 years ago. So this is an IGF-1 receptor antagonist. And there are 3 randomized controlled trials. It was approved and came into clinical practice in the US alone in 2020. So the outcome of these studies is that it shows remarkable efficacy and it reduces proptosis to the same extent as a decent surgical decompression. The sales of this drug have been absolutely remarkable, reaching nearly $2 billion per year, year after year in the last 4 years. And not surprisingly, this has been named as a blockbuster drug. The 2 randomized controlled trials that the FDA approval were based on treated patients up to 24 weeks, and that's the results that the approval was based on. The question, though, is what happens to these patients afterwards, after cessation of treatment? And if you read the papers published by those that are very close to the pharma that's behind it, then the data that they produce is that there are relapses. The proptosis comes back in about a third of patients or so. But if you look now outside the randomized controlled trials and look at the kind of daily clinical experience of our colleagues in the US that have used this extensively, you get a different flavor. And in one of them, the relapse rate was no less than 64%. And this happens usually within about 6 months to a year after stopping treatment. And another smaller study, but much longer duration from the US, has reported that actually 2 years on from stopping treatment, the vast majority, 67% of patients, have not benefited from this treatment. In 2023, 3 years after it was licensed, the FDA had to issue a warning because one of the side effects that was thought to be minor based on the randomized controlled trials is turning out to be much more of a headache and is actually leading to permanent hearing impairment in a significant number of patients. So 5 years on, there are some lessons to learn from the American experience that this blockbuster drug, which incidentally costs about $350,000 per patient, is associated with a reasonably high relapse rate, and the hearing impairment is a problem. And this is the USA. You wouldn't be surprised to know there are more than 200 lawsuits pending of patients with hearing impairment against the company. What about future therapies? Well, the advent of teprotumumab has led to an incredible rush in interest by the pharmaceutical industry to develop similar biologics and other drugs. So at the moment, there are at least 14 studies going on various biologics and novel agents, as well as a number of other trials repurposing old drugs. And the one to look out for, because I think that's what we're going to hear about soon, in the next year or so, there will be some data, and this might actually be licensed for this indication. These are drugs that target the neonatal FC receptor in thyroid eye disease and Graves' disease. And basically, just to give you the background to this, immunoglobulin Gs, of which TSH receptors are mainly of, they are recycled in the body. So they're taken up into cells using the FcRn receptor, and they're recycled and then pushed out of the cell. And this is what prolongs the half-life. At the same time, a small proportion of IgGs gets degraded, and that's what determines the overall half-life. The drugs that I've mentioned actually target the FcRn receptor. They block the recycling and they increase degradation. And so these drugs seem to be able to treat both the thyrotoxicity to Graves' disease and the thyroid eye disease. And there are already preliminary data showing efficacy. The key question is, will these beneficial effects be long-standing, or are we going to have to treat patients for years with these agents to actually maintain the benefit? So just to sum everything up, I think AI, as in every walk of medicine, will play a big role, and I think it offers some new approaches to the assessment of thyroid eye disease, which is a real big problem at the moment. I think the value of selenium is probably questionable. We shouldn't be as confident about its efficacy as we have been in the past. Mycophenolate, probably unhelpful, I would say, and tocilizumab actually may turn out to be the top drug of recent times in thyroid eye disease. With teprotumumab, which is about to be approved in Europe and the UK, I think we're left with many unanswered questions, and particularly the question of cost is very high up in the agenda. And we should look out for some of these new agents that I think will appear very shortly. But will our patients be prone to relapse as they have proven to be with the teprotumumab? So thank you very much for your attention.
So we'll have few questions to both speakers. I'm happy to have Dr. Ahmed Hassoun here and Dr. Mahjoud also with me. Yes, go ahead, please. There. Microphone there.
Dr. Peros, this is regarding your second presentation.
We don't hear you well, please.
Yes. Dr. Peros, this is regarding your second presentation about thyroid eye disease. You mentioned mechanoreception and mechanotransduction and how this affects the orbital fibroblasts and results in the swelling of the eyes. And my question is, would you use any type of ROCK inhibitors or integrin inhibitors as a supportive therapy to lessen the symptomatic eye swelling?
Did you hear the question well?
I'm very sorry.
Ahmed, did
Can
you hear the
you
question?
speak slowly and a little more loud?
Yes. So you mentioned how mechanotransduction plays a role in eye swelling. You mentioned the role of mechanoreception and mechanotransduction in the pathophysiology of eye swelling. And I was wondering, would you ever use integrin inhibitors or ROCK inhibitors in the management of, to lower the swelling of the eyelids in Graves' disease?
Yeah. Thank you. And apologies for asking you to repeat it. So I'm not aware that anyone has used any mechanoreceptor inhibitors. Excuse my ignorance, I don't know an awful lot about mechanoreceptor inhibitors. I'm not aware of any that are already available and licensed for this purpose. And if there are, obviously they're waiting for somebody to actually do some study. You don't want to inhibit, though, the mechanoreceptors. You want to stimulate. More close, yeah. So, interesting question. I think if you want to try something in this direction, you need a mechanoreceptor agonist rather than inhibitor to reduce adipogenesis.
Assalamu alaikum. Dr. Prof. Petros, I have two questions. The impact of early recognized hyperthyroidism with Graves' ophthalmopathy. If we recognize it early and we start treatment early and we control thyroid function early, will help in recovery. The second question, if we proceed with the surgery as soon as possible, will help in recovery or not?
Yeah. So the evidence that we have is that the more effective the control of hyperthyroidism, the better the outcome. So if you look at populations of patients with thyroid eye disease who have had unstable thyroid function, they tend to do badly. Patients with good control of hyperthyroidism do better. Now, having said that, nearly all of these studies are cross-sectional, rather prospective. There is definitely an association, but the effect, I think, is small. So most patients that have significant thyroid eye disease, moderate to severe, controlling their hyperthyroidism in itself is not usually going to be enough. And from kind of clinical experience, the worst thing you can do to these patients is just to allow them to go up and down. Swings between hyper and hypothyroidism are bad for them. The role of surgery, and by that I suppose you mean a thyroidectomy. Yeah, that's been looked at in a number of randomized controlled trials, and it doesn't seem to make any difference if you compare it to, say, antithyroid drug treatment.
I will ask you in that category. What about oral steroid at early beginning with slight exophthalmos? Does it help to change the outcome for the patient at the early?
Yeah. So the evidence that we have is largely in patients who already have established and moderate to severe disease. I think you're talking about maybe patients in the early stages, and nobody knows that. Nobody has paid a lot of attention to mild disease. This is a relatively unexplored and neglected area. So there are kind of... So oral steroids, talking about moderate to severe disease, is effective, but not as effective as pulses of intravenous steroids, and they're associated with more side effects than pulses of intravenous steroids.
Okay, two questions, please. Abu Bakr, please, first, Doc. Now, I'm an adult endocrinologist, and my question for you on patients with TART. Now, is there a role for dexamethasone as add-on to hydrocortisone? And if there is a role, what is the dose that you recommend and for how long, since dexamethasone can be associated with obesity and risk of metabolic? And for Professor Peros, gluten-free diet, is there any benefit in autoimmune thyroid disease, since autoimmunity can be exacerbated by gluten? Thank you.
Thank you very much for the question. Yes, there is a role for dexamethasone. I have my colleague in King Faisal, the specialist hospital, Dr. Afaf Sahir, is using this frequently for patients who completed their growth. It's quite potent in the glucocorticoid effect in regressing quite advanced start. They usually preserve it for advanced start, which is progressing towards the surgical type, stage 4 or 5, to avoid damage and surgical intervention. And you use it for a short time to regress them, and then you can continue with either prednisolone or hydrocortisone. Usually, as adults, you use either prednisolone or dexa. You don't need to use the hydrocortisone. I don't have experience with using it myself, so I don't know the dose, actually.
Yes, go ahead. My colleague.
Okay, my question to Professor Amir.
There was a second.
Sorry. He has some additional comments.
So the question was about the utility sorry, but the utility of a gluten-free diet in thyroid eye disease. And I think what you're thinking of is gluten in the gut makes the gut leaky, allows antigens and exacerbates autoimmunity. So this is a common narrative that we hear from various corners, especially patients. The evidence for or against in thyroid eye disease is zero. We just don't know. The evidence in Hashimoto's disease is unless you have celiac disease, there doesn't seem to be a clinical benefit of gluten-free diet. That's my understanding of the evidence.
Okay, my question to Professor Amir. Professor Amir, thank you. You talk about the congenital adrenal hyperplasia. It's here. You talk about congenital adrenal hyperplasia, and we know that in the non-classical non-salt losing in boys, it may appear late if there is precocious puberty or advanced bone age. Do you think the early screening and diagnosis will prevent a lot of complications in the future?
Yeah, sure. It's a good question, actually. It's always challenging, the non-classic type, because you don't have a screening tool for that, and it needs high index of suspicion. And I think hypothetically, yes, if you discover that early, but the main challenges in this group is the final adult height and the body image. And I think usually their main risk is to progress into true puberty, precocious puberty. Unfortunately, we have the GnRH analog that rescues them in this direction. But obviously, the area of secondary sexual characteristics, even for other ordinary precocious puberty, is a challenge for pediatrician. We don't have medications for that, so we teach our patients to cope with it rather than. But you can easily secure the final adult height and stop the progress into true precocious puberty by the GnRH analogs.
Great. Doctora?
Okay, my question to Dr. Amir. Yes, here. So I have a patient who was diagnosed in early childhood as
Can you put the mic to you? We cannot hear.
congenital adrenal hyperplasia since childhood. I received him in the clinic. He's 27, short, hyperpigmented. He's not compliant on medication with two brothers with same diagnosis. So he has very high ACTH and very high renin, hyponatremia, hyperkalemia. But 17 hydroxyprogesterone came back low. So I proceed to genetics, came back as familial glucocorticoid deficiency and NT gene mutation, type 4. So in such patient, he has mineral corticoid deficiency in addition to glucocorticoid deficiency. How do you think changing diagnosis would affect his management?
So you have deficiency in the glucocorticoid and mineralocorticoids, both of them.
Yeah.
But initially was diagnosed, you said, as classic 21?
Yeah.
He was diagnosed. Okay. So I think this is clearly highlighting the importance of overlapping of these conditions upon suspicion, and the importance of confirming your diagnosis by the genetic test at the end, because you can have different combinations. As you can see, they're all working the same pathway, and you can have different degrees of increase or decrease or reduction in the hormones, depending on whether you have a direct blockage at the site, and this is a direct precursor, or you have a deviation of the pathway. So this is what you described is more consistent with the P40 450 reductase, oxidoreductase, or you said you have a diagnosis already. You said what?
Congenital glucocorticoid, familial glucocorticoid deficiency.
Okay.
Yeah, type 4.
So I guess you need to replace. Obviously, there is a replacement for both of the hormones, but you don't have the. How about the androgens?
It's high, a little bit high, but not
Okay,
that.
so you need to suppress. You need to suppress the androgens, and you replace for the deficient hormones. I think the management principles will be the same, but always you need to know your diagnosis, because you don't need to overuse the glucocorticoids, which will suppress the growth and affect the final height. It's 27 years old now, So you don't have this issue, but you can have the side effects of cushingoid features.
Sure, thank you.
Okay, two short questions, Dr. Hadi. You short question, short answer, please.
Thank you very much to all speakers. So I have a question and a comment, if that's okay. So the question is about the utility of the newborn screening for CAH. So not long ago, this subject was revisited at the UK, and at the UK Society for Endocrinology, we were asked to provide an opinion. And the problem, we did not support it. I'll tell you why. First, you can't do the test until day 3. Yeah, after delivery. And by then, you've already diagnosed most of your classic CAH patients with ambiguous genitalia, or they could have even developed adrenal crisis by then. Secondly, prematurity is common, and those babies have quite sky-high 17 HP. Thirdly, you need to have data normalized for your local population. So I would appreciate your comment on that. The comment, and sorry for being lengthy, is an answer to my colleague who asked about the role of treatment intensification for TARDs. I think patient selection is key. For adults, I tend to look at the ultrasound. If I feel it's stage 4, stage 5 TARDs and FSH is already high, it's probably too late. But last week I had a patient who still wanted to have a go, and I agreed with him 0.25 of DEX twice a day for up to 6 months, and I do semen analysis at 3 months and at 6 months. At adolescents, it becomes trickier. So what's your endpoint? So you're going to pre-treat for 6 months, and then what? They are not seeking fertility at that age. If you're going to do it and then sperm bank, that's reasonable. But otherwise, I wouldn't do it. I would just aim to improve their overall control, because you don't have an endpoint unless you're going to sperm bank at the end of the treatment intensification period at adolescence. Thank you.
Great, thank you. The last so you can have a comment or
Yeah, I can't agree more with what you mentioned about the skepticism about the newborn screening, because it's one of the screening tools which has got great limitations, as I highlighted here, with the stress, prematurity, the use of steroids in the mother for any reason. And so it's a negative one does not exclude. And also the positive one, the negative one does not exclude because of the reasons you mentioned, and the positive also does not necessarily mean that you are treating the right condition. So it needs further improvement. Yeah, but for the time being, it's quite useful in picking the true positive cases for medical emergencies before they land up in a week or 2 weeks in the ER.
Short question. Yeah, no, sorry, Dr. Sarah, yes, before.
Just a quick question. With regard to thyroid eye disease, I just wonder if the treatment with carbimazole or anti-thyroid drugs with a fall in TSH receptor antibodies, or the rate of fall or continued use of carbimazole, does it affect the future course of the thyroid eye disease? Has anyone looked at the fall with TSH receptor antibodies?
Yeah, so if you compare the treatment modalities that we have available for Graves' disease, antithyroid drugs, radioactive iodine, or thyroidectomy, carbimazole or antithyroid drugs and thyroidectomy are associated with the best. Can you? Sorry. You compare thyroidectomy versus drugs versus radioactive iodine. Okay, radioactive iodine comes out the worst in terms of the course of thyroid eye disease. So the best outcome is associated with the use of antithyroid drugs or thyroidectomy.
Thank you all for some
short, please, and short answer.
Yeah. Thank you all for some lovely talks. Again, to Professor Amir on the neonatal screening. Now, the UAE has the genome-wide neonatal screening. For the classicals, it's easy. For the non-classicals, how good is the genotype-phenotype correlation? So do we want to tell everyone who has it? Or is it going to scare some people who are not going to have the disease?
As I mentioned, actually, a short answer is the current screening is not set to pick the non-classic type. So the specificity and sensitivity of it can only pick the classic ones. Yeah.
With that answer, we'd like to thank you all and for the interaction and for the guest speakers who did a great job and to our chair people here. Thank you very much. And now we have a break for 15 minutes, right, Priam? 15 minutes? 15 minutes break.
All right, we're going to start to keep on time. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. Great pleasure to be here again and to have an interactive session. I would like first to call upon the panelists, Petros Peros, Dr. and Richard Quinton. So we'd like you to come to the podium. All right, so this is an annual activity that we started a few years ago. As you know, the format is interactive. There is a voting system that we will use. We will present 3 interesting cases, challenging in many aspects. And we are very honored and blessed today to have Dr. Petros Peros and Dr. Richard Quinton, who are professors of medicine and endocrinology. They've been introduced several times, and I don't think they need any further introduction. I'm also very pleased to have Dr. Hassan Shawa, who is an associate professor at will come later on. All right. And Dr. Shada Samarkandi, who is also an associate professor from King Abdulaziz University Hospital. So without further ado, let's start the first case. Dr. Hassan. Now, while Dr. Hassan is coming, we will prepare you for the interactive session. So please use your mobiles to connect to this system, either scan the code or go to the application and put the ID number. And to test the system, we'll start with some questions. So the first question here is, do you enjoy the annual Grand Round session? We'll see how much you enjoy this, and you can now vote. We'll go back. All right. So let's try the second question here. You're practicing, yeah, this seems to be working. You're practicing in one of those countries. Please go ahead and choose. Okay, I'm sorry. So 37% from UAE, 58% from Saudi Arabia, and 4% from Oman. All right, let's move on. Okay, so I think the system is working and we can start with the first case, Dr. Hassan. So again, to introduce Dr. Hassan, he's an associate professor at Khalifa University, head of thyroid cancer clinic, chair of endocrine division at Sheikh Shakhbout Medical City in Abu Dhabi, UAE. All right, let's just start with the first case.
Bismillah. Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's my pleasure to be here. Thank you very much. I want to start with congratulating the organizers of this wonderful scientific meeting. It's so useful, mashallah. It's very good to see those faces, and it was very good as well in terms of the networking and the sport night that we had last night. Thank you very much. It's my first time presenting at GAED, so it's an honor for me to be here since I joined 2.5 years ago from the US. Since it's my first time, I would like to say just a little bit about me. I did my training at MD Anderson Cancer Center, and then I was the leading of the endocrine neoplasia clinic and the endocrine fellowship in Albany, New York for almost 10 years. And then early 2023, I joined Sheikh Shakhbout Medical City, where I currently serve as the division chair and the lead of the thyroid cancer clinic, where we have plenty of thyroid cancer patients because we are the only center in Abu Dhabi region where we can provide adjuvant iodine ablation dose for those thyroid cancer patients. My case today is not a thyroid, but not thyroid cancer. It's thyrotoxicosis. Very challenging from both diagnostic and therapeutic perspectives. I thought it's going to be educational. It's the end of the conference and the end of the day, so probably you are brain drained, but I promise I will entertain you with this case that I consider myself to be the hardest thyroid case I ever encountered in my 14 years career of endocrinology. So we shall start. So she's a 46-year-old woman presented to our hospital in April 2025 with persistent thyrotoxicosis. Her diagnosis originally was in 2020, so 5 years of thyrotoxicosis. At that time, when she presented, she had a technetium thyroid uptake scan that showed low uptake, 0.2%. I'm going to share the images. And she had all the thyroid antibodies checked and they were negative. She was started though on carbimazole and has been requiring hefty doses. So she was on carbimazole 20 milligram twice a day on average, and reports being very consistent with treatment. On the top of that, she is on propranolol at least 40 milligram a day, sometimes takes it twice, 3 times a day, depends on the palpitations feeling. Her family history is quite strong for thyroid disorders. So she has a couple of daughters with Hashimoto's, not on treatment, overt hypothyroidism in her mother, and paternal uncles, and thyroid cancer in one sister. So, and if you practice in Abu Dhabi, probably you are aware of what we have something called Malafi. So it can show the records of the patients at other institutions. So I just took a snapshot here of her previous records because, sometimes patients don't give very accurate history. So it's good to verify if you can. So this her labs from 2023 until 2025, when she presented to us, her TSH always undetectable, and the free T4 on high dose carbimazole always high. So the normal range for free T4 is between 12 and 22, always on the higher side. And the free T3 is either is either elevated or normal. Okay, so this is between 2023 and 2025. And this is a snapshot of her antibodies, the thyrotropin receptor antibody. As you can see here in 2022, checked a couple of times, negative. And this is the thyroglobulin antibody, also negative, and multiple times checked. And this is the TPO antibodies, always negative. And even the thyroglobulin was checked once in 2022, was not low, was not high. So it was detectable, 10.7. And this is the thyroid uptake scan using technetium, originally in 2020. And as you can see, the uptake, so it was 0.1% in the right lobe, 0.1% the left lobe, so the total is 0.2%. That's considered low, the normal between 0.4 and 4%. But you still see, though, the thyroid shadow. So those are all the previous records. And when she presented to SSMC here, she came to internal medicine in April with symptoms of thyrotoxicosis, palpitations, weight loss, heat intolerance. You can see the labs showing very obviously low TSH, high T3, high T4. The antibodies again for TPO and thyroglobulin antibody are negative. Here a few days later, she came to ER with similar symptoms. They checked again the free T4 and TSH, no change. And here when I saw her for the first time, April 18th, again, the TSH pretty low, high free T4. I checked the thyroglobulin to make sure it is not low, to see what it is, if it's high, and it was similar to what it was a few years ago, about 11.5. The total T4 at the high end of normal. And I repeated the thyroid tropin receptor antibody, again negative. I also checked the thyroid stimulating immunoglobulin to make sure I'm not missing this, and that's done outside in Mayo Clinic, and it is negative. And I have ultrasound in my room, so that becomes very handy when I see thyroid patients. I take them to the table and then do the ultrasound on the spot. So that can give me sometimes a diagnosis on the spot. But anyways, in this patient, as you can see, her thyroid, nothing impressive. It doesn't look enlarged, not heterogeneous, as we see with Graves, no nodules, etc. And I repeated the technetium scan on her, pretty similar to the previous one. So now we are in April 2025. Numerically, it's 0.3%, the total uptake. Previous one was 0.2%. Even though you can argue, you can see the thyroid slightly better than the previous uptake scan, but numerically still low uptake. And while I was repeating the thyroid uptake scan, I told the patient to hold carbimazole for a few days before the thyroid uptake scan for two reasons, just in case if it was the reason for having falsely lower technetium scan, even though theoretically it should not affect it because it's not iodine uptake scan. Also, I wanted to test how much carbimazole is helping. And as you can see, the difference here between April 18th and April 30th, her free T4 definitely jumped up and the T3 went high by holding carbimazole for a few days. So carbimazole was helping, but it was not controlling the thyrotoxicosis. And I repeated the thyroglobulin for the third time was around the same range, 12.3.
Okay. Can we hold for a minute, Dr. Hassan? So in summary, this is a middle-aged lady who is thyrotoxic, clinically and biochemically for 5 years, despite large doses of carbimazole. In her biochemical profile, her antibodies are negative. Her thyroglobulin is on the lower side, around 10, but quite detectable. And 2 technetium scans showed low uptake. So with that, Dr. Hassan is asking you, what do you think is going on? I think, and again, during this course, he held the medication and he showed an increase in FT4 and FT3. So it sounds like straightforward case with hyperthyroidism, the day-to-day stuff. All right, so with that, you can go ahead and choose an answer. You have 10 seconds to make up your mind, giving you a chance more than this. And tell us, what do you think is the diagnosis at this point? Okay, so now you can choose. Sorry to keep you on. Okay, so these are the answers. All right, so most of our colleagues here think that this is stroma ovary of 50%. 10% only think that this is Graves' disease, 24% factitious, 11% lab interference, and 5% think that this might be metastatic functional thyroid cancer by the fact that Dr. Hassan is a thyroid cancer practitioner. So what do you think, Beers?
Yeah, I don't think this is Graves' disease.
You don't think
That's the first thing to say. But what I haven't heard from you, maybe I missed it, was she clinically thyrotoxic?
Yes, heat intolerance, palpitations, weight loss.
And are you able to give us a little more of a social history?
Social history. So she is married. She has 5 grown children. She also has grandchildren, married.
Yeah. So do you want me to comment more? Or?
Yes, sure.
So the reason I don't think this is Graves' disease is that she has negative thyroid autoantibodies, the ultrasound. Interesting finding, normal ultrasound of the thyroid gland. I don't think it's struma vari. If that was the case, or if it was metastatic, if it was struma vari or metastatic functional thyroid cancer, you would expect the thyroglobulin to be sky high, and she doesn't have thyroglobulin antibodies to interfere with it. So we're left really with factitious and.
So if you have to choose 2 or 3, we'll not tell you to choose one.
Choose one.
Huh?
Because I'm a suspicious type of person, I would say this is factitious.
Okay.
If I have to come off the fence.
Sure. Okay. But you want to add anything, or you're happy to hear us?
Yeah. Does she have any other healthcare professional in the family? Is she a pharmacist or something?
Say that again?
Any healthcare?
Anyone in the family, a healthcare professional, pharmacist, or whatever? No.
But she has people at house with Hashimoto's and thyroid cancer.
Yeah, her mother is hypothyroid, only with thyroxine.
Levothyroxine, right? So that's the supply sorted. Yeah.
I may ask you to take the seats there. I think they have to prepare 2 additions. That's a better place, I think, isn't it? That's a better place. Yeah, closer to the. All right, so let's move. Okay, so there you are.
So at this point, personally, I was debating if I am dealing with trauma ovary versus factitious. The fact that her T4 went up with holding carbimazole gave me the sense it is probably more trauma ovary rather than factitious, requiring very high doses of carbimazole as well. So that's why I went in that direction first. And I got disappointed that both pelvic ultrasound and that CT scan were negative.
So here's another question: what should we do? What should we do next? Okay. So again, be prepared. So you have heard the story. I think the experts here are saying this is not a Graves' disease. I think most of you agree with this. What do you want to get here?
Ali, can I make a couple of comments whilst we're doing this?
Sure.
So another couple of things to think about. I would go very deeply into the history of whatever she's taking other than thyroid hormones, particularly supplements. And I don't think you've talked about that.
Other supplements or something else that could explain this. I mean, herbal medication or.
Yeah, I asked her, and I asked a couple of daughters also. I met with her in person. I took their phone numbers as well, so I can talk to them privately.
Yeah.
All of them denied taking anything, including herbal supplements.
And the other thing, do you have any information about whether she ever had thyroid function tests earlier on in life?
Thyroid function tests, what?
Any thyroid function test early in life?
Earlier in life? No. She never.
Never. Okay, so this is the answer for what should we do next. So the majority is something else, and those people do not know anything about anything, okay? But let's see the positive answer there. So CT chest and abdomen, or iodine scan, or A and B. And I want to go back to you briefly and tell me, what would you do, Deros, at this stage? Would you choose one of those or something else? That's just a CT scan plus iodine, whole body scan.
I mean, these are, reasonable choices. I think particularly an iodine scan may actually give you some additional information. But to be honest, I think I would just concentrate very much on taking a really good history and trying to understand this patient's perspective of everything. Really detailed history about supplements, because biotin which is very widely used amongst the people, can give you this kind of pattern.
Sure.
And that's very reasonable. Any chance that she's on biotin or?
She denied, and I actually even measured it. I did not put it here, but I measured the biotin level in her blood to make sure it's not elevated, and it was normal.
Okay, let's proceed. Again, for the sake of time.
Sure. So we did both. I did the CT scan, chest, abdomen was basically negative for an extrathyroidal source of thyrotoxicosis. We did the I-123 scan after following low iodine diet for 2 weeks, and she is such pleasant and obedient patient. She did the 24-hour urine collection for me as well before doing the iodine scan, which I confirmed to be normal, so it wasn't high. And the thyroid, the scan here using the I-123 numerically was low, 2.1%. But if you look at the thyroid shape, it's much clearer than what it was on the technetium scan. And when I discuss the case with nuclear medicine, they say this is ablatable. This is something we can ablate. Don't worry about this number, the 2.1%.
Let's proceed. We have 5 minutes. So again, we'll take one more question or 2 more questions. So she's still thyrotoxic?
Correct.
She has all the investigation. What would you do?
So now it's already 2 months in June, and she's still thyrotoxic. In fact, they are very frustrated that they are not reaching a diagnosis nor a treatment. They went to Thailand to seek for answers. They stayed there for a week. They got scoped, endoscopy, colonoscopy to make sure there is no source of weight loss, because by now she lost 15 kilograms down to 38 kilograms. Basically, they found nothing. Now she is back to me. What do I do?
So she was on carbimazole for a long time. So would you switch to BTU? Would you ablate her with radioactive iodine? Will you send her for surgery? Will you have a combination of this? Let's see what are the answers. Think about her. Okay. Great. So let's see what people would do. All right. Remember, her iodine uptake was low, but 44% choose to give her iodine 131, 4% switch to BTU, and 24 send her for thyroidectomy. Would you do any of this, Piros?
So I'm still struggling with what the primary diagnosis is here, because the iodine scan tends to suggest that this is Graves' disease. But there are things that don't actually add up to that. The normal ultrasound, entirely normal ultrasound, is a problematic. Why should she not have responded to carbimazole is also problematic. I would, the options of ablation or thyroidectomy really definitively destroyed her thyroid, and they're too drastic in my view. I will be thinking about, are we dealing with something perhaps that is familial? As a trial, a switch to PTU would not be unreasonable, I think, because it wouldn't definitively destroy the thyroid gland. But I'm still struggling to formulate a definitive diagnosis.
So Dr. Piros is still skeptic about diagnosis of endogenous hyperthyroidism, and a trial of PTU is reasonable, but the whole thing is that there might be either congenital familial thing, or she's taking exogenous material. Would be with suppression. Okay. Richard, do you have any additional thinking?
So I'm just going to wind back again to the beginning. I mean, both Petros and I were thinking, that is fictitious. The one thing against that was that when carbimazole was stopped, her thyroxine doubled. Now, if she was an evil genius, you could do that. If she's using thyroxine, she could double the dose. but she'd have to be really clever, devious to do that. So I'm not a very good diagnostician really in this. But I think there are certain cases where sometimes we endocrinologists, we do get obsessed with like diagnosis and the minutiae of that. I think she needs a thyroidectomy.
You would choose
And I think that will solve the problem, might even give us a diagnosis.
Sure.
All right, let's
So-
see what the
So at this point, I wanted to reach definitive treatment. Not sure yet of the diagnosis, perhaps seronegative Graves. Anyways, to go straight with either ablation or thyroidectomy, I felt probably not the ideal scenario because she is thyrotoxic. So I wanted to try the PTU as a bridge for the ablation first. And the very interesting thing that she did awesome. She did great on PTU. For the very first time on PTU, I gave very hefty dose, 200 milligrams, 4 times a day. For the first time, free T4 normalizes, and her free T3, in fact, went low on this. But the very unfortunate event that she developed leukopenia with agranulocytosis on the PTU. So at this point, she became, because we had to hold, of course, PTU, she became very ill and we admitted her to the hospital. Here we are in July. That's why you are seeing almost daily labs. And during her hospitalization, after holding PTU, you can see how the free T4 is going up so quickly. So within 1 week, it doubled from 35 to 69. The T3 maintaining because she was on propranolol maximum dose as well as steroids. And during her hospitalization, I tried to re-challenge her with very small dose of PTU, 50 milligram twice daily. And within 24 hours, her white blood count and the absolute neutrophil count went down so quickly. So I realized here that I should not use it anymore. So
Again, one more question here. What would you suggest next? This is a patient who was put on BTU, developed a granulocytosis, taken off all medication. Quickly, she relapsed. So we have to do something for this patient. Think about it. All right. You have 7 seconds, 6 seconds. Right. Okay. So again, somebody or the majority suggested thyroidectomy, and a good percentage suggested iodine therapy, and 8% something else. Quick comment,
Anyway, yeah, thank you. So first of all, I think one is forced to conclude this is Graves' disease. That's TSH receptor negative. So got that wrong. I would go for Lugol's followed by thyroidectomy for the simple reason that if you use radioactive iodine, even with a fairly large dose, you have no control how long the patient will continue to be thyrotoxic. And if she runs into any complications, you can't use anti-thyroid drugs, you're really stuck. So I think you're at the point that you really need a quick, definitive treatment without any ifs and buts.
Sure. And I think that's what Dr. Hassan did.
yes, I didn't feel safe to do the iodine ablation at this point because how long it can take. And of course, at the beginning, we will have worsening and thyrotoxicosis. So we switched plan to thyroidectomy. I gave her Lugol solution for 5 days before the thyroidectomy. And interestingly, for the third time, I'm seeing response to medical treatment. So meaning after holding carbimazole, the free T4 went high. After giving PTU, the free T4 went down. And now I'm giving Lugol and it stabilized the free T4. It didn't make it down, but it stabilized it around 70. And then she had the thyroidectomy safely. Now, the interesting thing, the pathology, not consistent in terms of the measurements with Graves, the thyroid lobes measurements, as you can see, 3.5 centimeter, not very large. The microscopic explanation, it said consistent with thyrotoxicosis, even though I have to say, because I was skeptical with the diagnosis, I asked another pathologist in our institution, and the other pathologist said, if you are honestly skeptical of Graves' diagnosis, then I would not call it Graves' disease. It's normal thyroid.
That's cool.
Yes. So this is after the surgery. Her T4 improved, so now down from the 70 to about 30, 25, but never normalized. Now we're talking about 3 months history from July until October. So free T4 never normalized, and T3, in fact, it got slightly worse, perhaps because we decreased the propranolol dose to, she was taking only 20 milligram a day as needed for palpitations. So that's why we saw the elevation in T3. Clinically, she gained 11 out of 15 kilograms back. So she did improve after the surgery, less palpitations, and thyroglobulin has become undetectable, but she is still thyrotoxic, biochemically speaking. So what do you do next?
This is a patient who had total thyroidectomy. Despite that, she is still thyrotoxic. So repeat neck ultrasound, do a scan again, send her for a psychiatrist to evaluate all of the above, something else. We are running short of time, so what would you choose here? All right, 4 seconds, 3 seconds, 2. Okay. So the majority would give radioactive iodine. I repeat, radioactive iodine whole body scan. 6% will send her for psychiatric evaluation, ultrasound. Let's again, for the same time, move and see what will happen. We'll not ask you this time.
So neck ultrasound basically showed post-operative findings and no residual thyroid tissue. The psych evaluation was perfectly normal. The psychiatrist felt she is very legit, reasonable person. He made the likelihood of this being factitious very, very unlikely. And the repeat I-123 scan after following low iodine diet, this was negative, completely negative. Even the thyroid bed, as you can see, there is no uptake in the thyroid bed at all. So she came to me just literally on Monday or Tuesday last week with having 6 kilograms recurrent weight loss. She attributed it to the low iodine diet, but apparently she's now getting worsening in thyrotoxicosis biochemically. So the free T4 now up to 65 and the free T3 is up to 12 or 13. And I really need your help now what to do with this patient.
So I think basically we are not sure. Dr. Beros, you have any suggestion at this time? Her thyroid is out. She's still thyrotoxic.
She's on how much thyroxine is she?
She was not on thyroxine. She never got started on thyroxine.
Any suggestion? Or Richard?
Highly perplexing. Again, it makes me wonder whether she's taking something exogenous. And in this case, it would have to be something which is both contains thyroxine and T3, so desiccated thyroid extract. The fact that she gained weight may be a reason that's driving her to take something.
Maybe episodically, maybe sometimes, not all the time.
Maybe there.
Because she gained weight and then she had...
Yeah. The thyroglobulin becoming undetectable be consistent with that, but also you would expect that with a total thyroidectomy anyway. So it's diagnostically still unclear what is going on. Can you say anything more about you said the psychological assessment was normal? What does that mean?
What's that?
The psychological assessment was normal. What does that mean?
Well, she was seen by the psychologist and the psychiatrist, and she was felt to be very reasonable, no psych background, unlikely to do this factitious to herself, to damage, to harm herself, etc.
I think
Clinically, she's having now recurrent weight loss and palpitations never disappeared. So she's always has been always on beta blocker as needed.
Let's see what happens. Time is running, and we still have two cases, and I'm not sure if we can do it. But let's move, please. Okay.
That's it.
That's the last one.
That was the last slide.
All right. So we don't have a diagnosis, but let me ask you with a show of hands, who think that this patient is taking thyroxine?
Including.
Who thinks that she has endogenous source of thyroid? I told Dr. Hassan he was not convinced that this patient is taking thyroxine. We presented a few years ago similar patient in this forum, and we searched her room. She was taking thyroxine. Yes, correct. So I'm sorry, Dr. Hassan.
Sure, just in 10 seconds, to defend this statement. I'm not saying I'm not convinced. However, her history is not 100% consistent with factitious for multiple reasons. Thyroid globulin never been undetectable. The uptake is not undetectable, and in fact, we can see the thyroid uptake as stated. Or she is responding to carbimazole, holding the medication, raises the T4. She was both outpatient and inpatient. We are seeing the same trend of T4 withholding medication, giving PTU. So
I have to close it here. I know there are so many burning questions, but I'm really sorry. We'll move to other interesting cases. Thank you so much, Dr. Hassan. All right. So we'll see if Dr. Shada and myself will be able to manage to present two cases. Sariyan. Okay, while you're preparing. Okay. All right, so the second case is another challenging case, and I'm pleased again to introduce Dr. Shada Samarkandi, who's an associate professor at King Abdulaziz University in Jeddah. King Abdulaziz University in Jeddah.
Assalamu alaikum. Good afternoon, everybody, and thank you for this invitation to share my interesting case. This is a thyroid case, but it's a different flavor, I'm assuring you. So this is a 38-year-old Saudi lady who reported a history of palpitation, restlessness, excessive sweating, diarrhea, so the hallmark of thyrotoxic manifestations. She denied history of recent viral infections, fever, any visual disturbances. And a little bit of about the past medical history for this lady. She was diagnosed with relapsing remitting multiple sclerosis when she presented with optic neuritis and ataxia 6 years ago. Before the presentation, she was initially in interferon for 4 years, and then due to treatment failure, the neurologist shifted her to natalizumab, which she developed again, John Cunningham virus infection. So she was shifted to alemtuzumab, and she received the full course for alemtuzumab. The family history for this lady is significant only for hypothyroidism in her sister, but otherwise no other autoimmune disorders in the family. And the medication is as stated before for the multiple sclerosis, and she's also on vitamin D and no other supplements. On examination, she was tachycardic, but otherwise we did not find any features of Graves' or Bridgeopathy. By neck exam, she had diffuse goiter, smooth, with no nodules, no tenderness, no bruit, and no cervical lymphadenopathy. And the rest of her examination was unremarkable. And for her investigations, the thyroid function showed clear evidence of thyrotoxicosis with suppressed TSH and high free T3 and high free T4 with raised thyroid peroxidase antibody and thyroglobulin antibodies. And the thyroid technetium scan showed increased uptake that was diffuse, homogeneous, that goes suggest with Graves' disease.
So this seems to be a straightforward patient, young woman who presented with hyperthyroidism. She has no family history of. She has one sister with hypothyroid, and she's clinically hyperthyroid. She's biochemically hyperthyroid. She has a technetium scan showing high uptake. Why you're bringing this, Shada? What's the fun here? So let's see what people would think. So what will you do at this stage? This is a patient who is hyperthyroid, so please treat her. Symptomatic treatment only, start carbimazole, radioactive iodine, or send her for thyroidectomy. All right. Okay. Let's see what are the here. All right. So most of you start having carbimazole. Richard, this time we're gonna change you to a thyroidologist.
Yeah, I think starting carbimazole is a reasonable thing to do.
Okay.
Yeah, so this is clearly Graves' disease. It's likely.
So this is a Graves' disease, and
it is likely to be related to the alemtuzumab.
Likely
to be related to the treatment for MS alemtuzumab. And if that is the case, then there's an added reason for going for carbimazole because it's more likely to be remitted.
We'll see. All right.
So in fact, this patient was started on carbimazole and propranolol therapy, the classical thing that we do with Graves' disease. And then after 4 years, we saw her and repeated the thyroid function, and it showed evidence of overtreatment. So we went down to with the dose from 40 to 20 milligrams, and we stopped the propranolol therapy. And then again, she came with signs of overtreatment, and we at that time maintained her only on 10 milligram of carbimazole. And then we repeated the workup, 6 weeks on carbimazole, 10 milligrams only. And that time patient reported a history of weight gain and fatigue, and she was clearly hypothyroid with a TSH of reaching almost 30. At that time, we discontinued carbimazole altogether, and no thyroxine was initiated. And then we asked her to come again in 4 weeks to reassess her thyroid status. But however, she did not come to the clinic. She actually came 2 months later to the emergency department with history of fever, generalized tonic-clonic seizures, and untold mental status. And she was clearly tachycardic and febrile. Lumbar puncture and CNS imaging at that time showed clear evidence of meningoencephalitis, and her primary neurology team ruled out that this is an MS flare, and it was actually a meningoencephalitis that was treated with dexamethasone antibiotic and anticonvulsive therapy. And during hospitalization, thyroid function was again repeated. Remember, this is now 2 months off carbimazole therapy and off any thyroid medication. And you can see that there's a clear evidence of severe hypothyroidism with a TSH of 150. So the question here.
So this is a patient who presented with the classic features of Graves' disease, but now she's hypothyroid in a matter of 2-3 months. And Dr. Shada is asking you, do you think this is sick-you thyroid syndrome because of the meningoencephalitis? Is this thyroiditis on top of Graves' disease? She has hashitoxicosis. Is there a SAE interference, or you have another diagnosis? Oh, I'm sorry. Okay, so let's see what the other people think. All right, so let's see what the majority thinks. The good thing is that you will have choice in every item. So 3% sick-you thyroid, thyroiditis on top of Graves' disease. She has hashitoxicosis, the majority, SAE interference, another diagnosis. Would you like to comment on this?
So I have to say, remember, I'm the lazy doctor and the non-thyroid doctor. So I think at the beginning, yeah, this looks like Graves' disease, but there's alemtuzumab, and I think I wouldn't have dose titrated her. I would have said block and replace for a year, and then pull her off everything after a year, see what the situation looks like, because God knows what might happen in between.
Very good.
Yeah, so this clearly is not just sick-you thyroid, although there may be some contribution. The TSH doesn't go up to that level. So it is semantics. This is thyroiditis or hashitoxicosis. I think all of us are a little confused about what these terms really mean. It's not just straightforward Graves' disease, and so there's something going on. But clearly, the answer here is to replace with thyroxine as soon as possible. Yeah.
Great. Okay, Shana, let's move.
So, of course, we started this lady on levothyroxine 100, and she was discharged from ICU to her home, actually, in a stable condition. So, any final thoughts from the audience?
Any
from the panel?
final thought? You can shout. What do you think is going on with this patient? Yes.
Hashimoto encephalopathy.
Any other burning diagnosis? Yes. Okay, let's see what is the diagnosis.
Okay, so the final diagnosis for this lady is alemtuzumab-induced thyroid autoimmune dysfunction. So since we are endocrinologists here and not neurologists, a little bit of background about alemtuzumab. So it's a recombinant monoclonal antibody directed against CD4, which presents in the T lymphocyte and B lymphocyte. And as you can see here in the bottom left side of the slide, there is the initial phase of depletion of T cell and B cell, and then it is followed by immune reconstitution or the proliferation phase, but the T cell lag after, so the B cell proliferate, but the T cell lag before, afterwards, sorry. So, and this unopposed naive B cell proliferation without the tolerance signals to identify the self molecule might cause autoimmunity, and there's actually going to be high levels of trap autoantibodies. And this is what happened to this patient. And this phenomena is not just limited to alemtuzumab. It can also occur in treatment of HIV-infected patient with highly active antiretroviral therapy, and also following allogenic bone marrow transplant or hematopoietic stem cell transplantation. And this can occur actually in 33% of patients on alemtuzumab that they can experience the thyroid dysfunction during follow-up. And around 20% of those patients will have a fluctuating course, as we saw with this patient, so a hyper-hypo, or they can just have a transient of around 3 to 6 months course of thyroid dysfunction and they go back to normal. And so if you encountered such patient, what should you do? Actually, so the first thing is to do nothing in the first 3 months. So to avoid treating a patient that will go spontaneously to another thyroid state, delay the treatment actually by 3 months to determine if the thyroid dysfunction will spontaneously resolve, or the patient will have a fluctuating course as this patient. But of course, if the patient is high risk, such as a cardiac patient or pregnant, by all means do not delay the treatment. Or if the thyroid dysfunction persisted more than 3 months, then by all means start the treatment. Keep in mind that most of those patients with alemtuzumab-induced thyroid dysfunction, the thyroid dysfunction usually occurs 1.5 to 2 years after alemtuzumab. So you have to really dig in the history, review carefully the medication chart to pick up this past event in the. And the 2019 European Thyroid Association guidelines had great guidance regarding this phenomena. And they actually suggested that in the first 4 years after the alemtuzumab last dose is to screen the patient every 3 months with thyroid function, because the course can be fluctuating, which is what occurred in this patient. So I will not leave you with before telling you the final history and what happened now with this patient. So this patient now, I saw her a few months after the hypothyroidism. This patient returned back spontaneously to euthyroid state, and we stopped all thyroxine therapy. And in fact, she had a successful pregnancy of any thyroid medication, and her last clinic visit, her TSH was 2.1, and this has been off all thyroid medication for the past 2 years.
Thank you so much, Shada. Wonderful case. The idea here, The idea here is basically to alert you to the drugs, especially new drugs, especially antibodies. And as our panelist suggested earlier, in the case that this is related to this drug used for MS, but other drugs can do the same thing. Okay, I have one more case. I can do it in 5 minutes, inshallah. And it is more interesting, obviously. All right, so name may change. Okay, so this is a 33-year-old man who was in the hospital, and we were consulted to see him by the hematology service for hypocalcemia of 1.79. Albumin was normal. Phosphate was 1.79, and this is the normal range, so it was high. Alkaline phosphatase was normal. And vitamin D was normal. So I'll ask you right away, what do you think is the likely mechanism of this hypocalcemia? Now, sorry. I will go back to the case just for you to look one more time at the numbers. Hypocalcemia, hyperphosphatemia, normal alkaline phosphatase, normal vitamin D. So the question is, what do you think is the likely mechanism here? Is this PTH related issue? Is this vitamin D related issue? Some other mechanism? I'm not sure. Okay. Oh. My technology. All right, we'll try one more time. Press delete to clear. Can you clear it? All right, with show of hands, is it number 1? Who thinks it's number 2? Few people. Who thinks that this is some other mechanism? Okay, some other people. Richard.
So I think that with the low calcium and high phosphate, you've got to be thinking about PTH deficiency as your first thing. But also you want to be thinking about, is that low calcium level real? Is that low calcium real? So is the ionized calcium also low?
Oh.
So ionized calcium, PTH level.
So here's the second question. What would you suggest? Do ionized calcium, PTH level, X-ray of the pelvis and femur, magnesium level, or serum creatinine? And again, I think we are failing again one more time. Who wants ionized calcium? Some people. Who wants PTH? The majority. Who wants X-rays? And who wants magnesium? Many people. And who wants serum creatinine? Richard, what would you like to have one? You are allowed to get one.
I'm allowed one. I think you have to go for PTH first.
Okay. Very good. Okay, let's see. So history first and examination second. However, I will give you the numbers because you want to know. So the calcium, as you can see here, is low. Phosphate is high. The important thing here is the PTH is 500, extremely elevated. All right. So let me give you also some history. This is 33-year-old man who presented with symptomatic hypocalcemia and seizure after birth. Now he's 33, and this is a consultation. He was treated with different doses of calcium carbonate and calcitriol, and he had inadequate control of his symptoms and frequent recurrent hypocalcemia. He was diagnosed 33 years ago as pseudo-hypoparathyroidism type B. Do you think this is reasonable? Who think that this is not reasonable diagnosis? I would have diagnosed him at that time that way. What about you, Richard?
Yeah, I think that's a reasonable diagnosis, yeah.
It makes sense, isn't it? Especially he doesn't have any features of Albright hereditary osteodystrophy, but he has evidence, biochemical evidence of PTH resistance.
And because he's had high doses of calcium over the years, he's sludged up his kidneys and it's given him some CKD.
Sure. So at age 29, he presented with increasing stiffness of the lower trunk and thigh muscle, and he was unable to walk. This is 5 years ago or 4 years ago. His evaluation revealed the new diagnosis of a rare condition, stiff person syndrome. based on neuromuscular evaluation, an extremely high anti-glutamic acid decarboxylase, GAD 65. So now he has another diagnosis. His past medical history, for this condition, he was treated with diazepam, baclofen, immunoglobulin, but he was not really controlled. So finally, they did for him autologous hematopoietic stem cell transplantation. And this is why he was in the hematology section. He improved from the stiff man or stiff person syndrome. He improved and became ambulatory again, but with recurrent tetany-like episodes and chronic muscle spasticity. This is his past medical history. He has CKD stage 3. However, the workup was negative for proteinuria and hematuria. An ultrasound of the kidney showed normal sized kidney, no nephrocalcinosis, no stones. And in fact, he had even kidney biopsy that failed to show any specific cause of CKD with only some interstitial fibrosis. This is his family history. He's not the only person in the family. He has a twin sibling, the one in the middle, who has the same condition. He has a sister who is older than him by 1 year, and she has the condition. And he has 21-year-old brother who has the condition. His parents are first-degree relatives, and the biochemical profile of this family is similar. All of them have hypocalcemia, hyperphosphatemia, normal vitamin D, normal albumin, and high alkaline phosphatase. And a good number of them, they have actually high creatinine. I don't know if this is here. Yes. Many of them had high creatinine. Okay. This is just better projection, just for you to see. So these are the numbers: hypocalcemia, hyperphosphatemia, and high PTH. Physical examination, apart from muscle spasticity, the clinical examination was unremarkable. He did not have any evidence of Albright hereditary osteodystrophy, brachydactyly, or short stature, or obesity, or other features, or short metacarpals. MRI of the brain also was normal. There was specifically no calcification of the basal ganglia, and his clinical survey was unremarkable. So back to you now, you have a lot of information. Do you think this patient has what was his diagnosis of pseudohypoparathyroidism type 1B? Is this hypocalcemia and hyperphosphatemia secondary to CKD? Is this vitamin D resistance? Is this hypoparathyroidism? And again, you can choose. All right. Let's see what is the choice here. So the majority thinks that he has pseudohypoparathyroidism type 1B. Some thinks that this is because of CKD, vitamin resistance, D resistance is 26%, and hypoparathyroidism 6.6%. Picture the game.
Well, I think, can you show the slide of the family's bloods? Because that shows that the sister, even though she doesn't have CKD, has the same biochemical picture.
That's correct.
So I think that's why I would rule out 2. Clearly not hypoparathyroid because the PTH is up. Phosphate's up. I think this all fits with like a functional deficiency of PTH. So I'm going to go for pseudohypoparathyroidism.
Yes.
Pseudohypoparathyroidism.
Yeah. Okay. Pseudohypoparathyroidism. Thank you. You would agree with that? Okay. All right. So just to remind you of the pseudohypoparathyroidism, we have type 1A. The most important characteristics of this is the Albright hereditary osteodystrophy. Type 1B is the same picture biochemically, but they lack the Albright hereditary osteodystrophy, and they lack also multiple hormonal deficiencies. And I will just skip the other ones for the sake of time. Is there anything else that we could do to, or we are happy? This is pseudohypoparathyroidism, continue calcium and vitamin D. And sorry? All right. Any suggestion from you guys? All right. So we did genetic testing. The reason for this, I was Usually pseudohypoparathyroidism type 1B, you don't see multiple members, although it is hereditary in around 20 to 30%. The second thing, the bone was completely normal. So I was a bit skeptic about this, and I asked for genetic testing, although I was nothing was in my mind specifically at that time. And this is what we got. We got actually very rare condition of PTH mutated. So this is a mutation within the PTH. So the PTH is bioactively or is not active, basically biologically inactive. Although it is very high at 500 and 600, it was not active. What you see here at the top is the reference sequence. And then you can see the siblings, one, you can see here a change of G to A, and sibling 2, the same thing, and the mother is heterozygous at this position. So this is very rare condition. There are only 10 cases, and I will show you that in a minute. We treated the sister who was not very compliant with teriparatide, and you can see nicely that her PTH came down and her calcium. So we gave her teriparatide for like a year, and she did not need emergency room visit. We reported this case as familial hypoparathyroidism, despite the fact that the PTH is high, with elevated parathyroid hormone due to an inactivating PTH mutation. And these are all the cases that we are describing in the literature, only 10 cases. Interesting that in this case, 9 was reported by one of my mentors when I was a fellow, Dr. Michael Levine, maybe some of you know him. And he reported 2 families. One family is actually from Emirates, and they have the same mutation like my patients. And Dr. Jamal Jubba, it was the treating physician. So I contacted him to see if there is any relationship between my family and this one. It doesn't seem to be. The names are quite separate. This is the family that was reported 1 year ago by Dr. Jubba and Dr. Levine and the others. And this is the family pedigree from Emirates. You can see several generations, but it is the same mutation. Okay, I'll just skip some of those for the sake of time. But one important issue, we don't have explanation for the CKD. When we reviewed the sequencing of this family, we found that they have mutation, another mutation in this gene called COQ8B. And there are many reports of mutation in this gene causing nephrotic syndrome and chronic renal failure. So we think that this mutation might be the reason for the CKD in this family, especially when they did a renal biopsy for the patient and 2 of his siblings was basically unrepeated. Okay, so the highlight of the case is basically the power of molecular genetics. And this is a patient who and his family who had a diagnosis for 34 years of pseudohypoparathyroidism type 1B, but today we are diagnosing him to have familial hypoparathyroidism due to PTH mutation. And with that, I stop here. Thank you so much. I'd like to thank our panelists. Thank you so much for very insightful thoughts. And with that, we end it up here. Thank you so much.
Good afternoon, everybody, and welcome to the most distinguished moments of the Congress. It's the time for the award of the year in our meeting. We have 3 categories, like every year. The first one is the Ibn Sina Distinguished Service Award. The second one is the Oral and Poster Abstracts Award. And the last one will be the Journal Award of the Year. So we will start with the Ibn Sina Award. The Ibn Sina Award is given to the 3 most outstanding community services to award for the 6 countries of the Gulf. And each year we choose from Saudi Arabia and Emirates, and we rotate through Qatar and Oman and Bahrain. So the first award is no particular order. They're all the same. but I will start with the first one, and I will announce the name. I'm going to ask a colleague of his, the winner, to come and give us a bit of biography before he comes to the podium. The first one is from Emirates, and it's Dr. Walid Qablan, the pediatric endocrinologist. I'll ask Dr. Bashar.
Assalamu alaikum. It's my privilege to present my dear friend and colleague, Dr. Walid Qablan, a brand name that means excellence in pediatric endocrinology in the UAE. For more than 20 years, we have shared offices, research, friendship, and even when he moved away, somehow he always found a way to come back to Tawam Hospital, and I have a feeling that he will do it this time again. Dr. Qablan journey started from Damascus University to Michigan University, then Baylor College of Medicine, where he trained in pediatric endocrinology. He was the first Western-trained pediatric endocrinologist in the UAE and the founder of the pediatric endocrinology section at Tawam Hospital. His leadership as chairman of pediatric department, chief medical officer, and chief quality assurance at Tawam Hospital left a lasting mark on clinical care, education, and research in our hospital. He also founded the Emirates Pediatric Endocrine Club, nurturing a new generation of specialists in the field. Beyond the impressive credentials, what truly defines Dr. Walid, his passion, mentorship, and care to children. So please join me in recognizing Dr. Walid for his excellent achievement.
The second award, you already saw the picture and the name already. It was leaked. The winner will be from Saudi Arabia. And I will announce and then call a colleague of his to come and present his biography. Dr. Abdul Rauf Mahfouz from Riyadh. Dr. Saud al-Sifri will present his biography.
Assalamu alaikum. Good afternoon. It's really a great honor, really, to talk about or to present a colleague. Not only a colleague, a great friend, a great mentor, a great researcher, whom you feel that with the time, he's getting younger and younger. So everybody is growing up except him, mashallah. I knew him personally for the last 25 years. And he has been a consultant endocrinologist for more than 32 years. Should we say everything, Dr. Mahfouz? Okay. He started his medical career graduating from the Royal College of Surgeons in Ireland in 1984. Would you imagine? MashaAllah. And then he came to King Faisal Specialist Hospital. He did his residency, and then he moved to USA, where he got his fellowship in internal medicine and endocrinology. And then he came back to King Faisal Specialist Hospital and Research Center in 1987. So that was more than 32 years being a consultant endocrinologist. He had been the chief of endocrine section at medicine department in King Faisal Specialist Hospital for more than 16 years. He had participated as a researcher and as a scientific leader in many of scientific committees at different levels, at the national level as well as at the regional level. He had been, again, lecturer at Al Faisal University in Riyadh. He had been mentoring more than 100 fellows and residents, and I'm lucky that I was one of his fellows. Really a great achievement, really somebody who deserves really to be recognized, and we would like really in this to welcome Dr. Abdurrauf Mahfoud for being announced.
Next will be our candidate from Qatar, and it's Dr. Amin Jayousi from Qatar. And I'll call Dr. Omar Dehimat to give us a brief biography.
السلام عليكم. التقدمة حتكون باللغة العربية. يسعدنا اليوم أن نقوم بتكريم واحد من أوائل الأطباء في الغدد الصماء والسكري في قطر. لقد أفنى الدكتور أمين حياته في خدمة مرضاه في الأردن وقطر، وحل شابا في قطر عام 1982 مع أستاذه الدكتور كامل العجلوني، وبقي إلى تاريخنا هذا طبيبا متميزا محبا لمرضاه، كريما مع زملائه، محبوبا من كل الناس، وعازبا طول حياته رغبة في البقاء دائما في خدمة المرضى والعلم. يعود آل الجيوس الكرام إلى قضاء طول كرم في فلسطين، وأنهى دراسته هناك، ثم كان طالبا في أول دفعة من خريجي الجامعة الأردنية 1978، وكان من الأوائل في دفعته، ثم أنهى تخصص الباطنية بتميز، ووقتها حضر مع الدكتور كامل إلى قطر. 43 سنة من العطاء والإبداع وتأسيس جمعية السكري في قطر وخدمة المرضى من خلال مؤسسة حمد الطبية والتدريس الجامعي، جامعة العلوم والتكنولوجيا وجامعة كورنيل، وتأليف العشرات من الأبحاث الطبية وإلقاء المئات من المحاضرات الطبية في مختلف المؤتمرات داخل وخارج دولة قطر، والمساهمة في إنشاء مختلف الجمعيات الطبية في قطر ودول الخليج. حصل على العديد من الجوائز التقديرية على مستوى قطر والعالم العربي خلال مسيرته الحافلة بالإنجازات. وأخيرا نقول كما قال الشاعر: ما دام رائدنا الإخلاص في العمل لا بد تبلغ يوما غاية الأمل، وذو العزيمة إن رام المحال فلا يحول دون مناه أوعر السبل. دكتور أمين.
I'm going to ask the previous winners to come and take a photo of the three winners, please. Dr. Mahfouz, if you're here. He left. Hiyo, Dr. Mahfouz, please join us for a photo. Dr. Walid, I see you coming. Congratulations to all the winners. We move now to the next category, which is the oral and poster abstracts. It will be done by the head of the committee, Dr. Bashar Afandi.
Assalamu alaikum. So now we'll talk about the abstract awards. Before we start, I'd like to thank, we had two judges actually evaluating the oral presentations, and we have more than 10 evaluators, judges evaluating the abstracts. So with that, let's start with the awards. So we'll start with the oral presentation, it looks like. And we'll start with the third place. And we had a tie actually here. Two presentations, one from Oman, presented by Dr. Ibrahim Al-Ali about differentiated thyroid cancer in Oman. Dr. Ibrahim. The other one, again, the third place award is from Saudi Arabia, Dr. Nouf Abdel Samah, who presented assessing basal morning cortisol and central adrenal insufficiency score, diagnosing central adrenal insufficiency. Move now to the second place award, and it was from Kuwait. It was about ethanol ablation for cystic thyroid nodules using trans-ethnic approach, and is safe and effective, and was presented by Dr. Mudaw Al-Dosari, with Dr. Al-Kandari was available. And the first place award is Professor Adnan Agha, who discussed the urinary C-peptide ratio used in diagnosing diabetes. Professor Adnan. Again, I'd like to thank Dr. Ahmed Hassoun and Dr. Huda Azzuddin who helped in evaluating these presentations. Now we'll move to the abstract awards. And the third place was for gaps in blood pressure control and cardiovascular risk assessment in hypertension. And it was submitted by Dr. Thamer Alais. Anyone will take it for Dr. Thamer? The second place award was for the abstract effects of first-line oral hypoglycemics in bone markers of treatment, naive Saudi adults baseline characteristics, and was submitted by Professor Muhammad Al-Musfa. Is he around? Dr. Naji, would you like to take it for him? And the first place was for the virtual oral presentation yesterday. The first place award was for the abstract high-dose vitamin D supplementation improves glycemia and endothelial function in vitamin D deficient pre-diabetic adults. I'm not sure if anyone is here to take this. Anyone? Okay. So I like to thank all reviewers. We had more than 12 reviewers actually who helped us in evaluating these abstracts. Also, I like to thank the abstract committee, 7 colleagues that we worked on the abstracts for a long time. Thank you very much, and hopefully we'll see you next year for the same competition. Thank you very much. Assalamu alaikum.
Sir, thank you very much for your efforts, you and the scientific committee and the abstract committee and all the work that was done for this year. I'm going to call Dr. Salim Bishia to announce the 3 winners of the journal.
Firstly, as the editor-in-chief, I'd like to thank the board of directors and the association for supporting their own journal by providing these awards. The awards were meant to be first, second, third. The first is dedicated for original research. The second is for a review article, and the third for a case report. The basis for the selection is on citation, if it has happened already, as the first criteria. Secondly, on the scientific value and methodological rigor. Okay, so I think in the third place, we have adrenal crisis with hypercalcemia precipitated by levothyroxine initiation in a patient with polyendocrinopathy. And this is a case report by Fatma and Rael Mizroui. Please. The second place is the evolution and management of the post-bariatric hypoglycemia. It was a review and comparison of the international guidelines from 2017 to 2024 by first author is Alamin Abdul Qadir, with Fazia Rashid and Barbara McGowan. Alamin? Any of the Dubai group? Hamid Hassanin Al-Yara? Any of the member of the group and from the department? Department? Okay. All right. Okay, and the first award is for the impact of the IDF DAR risk stratification and pre-Ramadan education on diabetes-related complications from the Oman Diabetes Research Group, led by Ali Al-Raisi, together with Hamid Al-Raisi and Salim Ghiyati and colleagues.
Thank you all. Thank you, everybody. We had a very fantastic and very successful Congress for 2025. And it gives me actually great pleasure, first and foremost, to thank every one of the faculty and the chairperson who has contributed actually to such success. Thank you very much on my behalf as well as on behalf of all my colleagues in the board of directors. I would like to thank also all the delegates and the audience who has made actually this event looks quite impressive and looks quite actually successful. Would like to thank also all our sponsors for their unsurpassed and their unwavering support. And without that, this event wouldn't have been at all feasible. And last and not least, I would like to thank Dr. Rafat Husni and the team of Choice for being so wonderful and so fantastic. And I think, everybody actually should have them now to organize their event. Ladies and gentlemen, I would like also to thank the all board, current and past members and officers for their actually contribution to establishing this organization and making it strong year after year. I joined this organization first in 2017, 2018 as a board member, and since 2018, 2019, I have been an officer. It gives me honor and humility to start my presidency, and I thank everyone for their undeservedly for their support and their trust. We will continue to uphold and maintain the tradition and values of this organization, which began as great and it will continue as great. These values and traditions were centered on ethics, professionalism, transparency, dedication, and teamwork, esprit de corps. روح الفريق. We will continue to strive to serve and support our platform and medical community at large and take this organization from strength to strength. We are proud of where we are and shall strive to be and stay at the highest and supreme level. The visionaries could only create a better future. We are very proud that our younger generation are coming of age and are capable of holding the flag and take it to new frontiers. Here, I pay tribute to this breed of younger generation who will continue to infuse blood into the veins of this organization and anchoring the mesh of the old guard who were behind the creation of this establishment. Today, it marks the start of a new era and a new chapter, and here I salute the efforts, contribution, and dedication of all my predecessors. I will just announce that I have chosen the last member of the new board, and it gives me special honor and special privilege to call Dr. Mohammed Abdurrahim Bashir from Qatar as the new member of the new board of directors. Mohammed Bashir. Just to make two final announcements, and I would like to introduce Mohammed Bashir. Prior to that, Mohammed is very well known to us here in the Gulf since he has joined Hamad Medical Corporation in early 2014 as consultant in diabetes and endocrinology. He has actually made his impact, and he has established himself nicely as a very prominent figure in research and in clinical care. And I'm sure, in addition to the bunch of the other young generation who currently actually form the backbone of our establishment, I'm sure he will make great contribution, and we will take this organization to new frontiers. Welcome, Mohammed, and I'm very proud that you'll be joining us. Thank you very much. Just before we conclude, I would like just to remind you that the next event we will be holding very shortly, from the 6th and the 8th of November, we will have the board review course. And I again salute and thank those who have actually made it quite feasible. And here I mean primarily the drive force behind this, Dr. Khalid Al-Dahmani. And I would like to pay special tribute to Khalid. Unfortunately, we are going to lose Khalid as part of our mesh from inside, but I'm sure, his input, his contribution, and his dedication will not stop because his term has finished. Thank you very much, Khalid. And we have very much enjoyed, working with you. And thank you again for your effort. Our next 2026 Congress of GAED shall be again here in United Arab Emirates. It's going to be in October. The exact date and the exact venue will be actually declared very shortly following the first meeting of the new board of directors. Thank you very much, everybody, and thank you for being with us, and thank you for contributing to our success. Assalamu alaikum wa rahmatullahi wa barakatuh. And if I can call you for a group photo before we go, if everybody could come to the fore, please.